Good morning, one and all. Welcome to the final day of 31st annual meeting of INASL 2023. We now begin the day with a special interest group, cirrhosis and complications. The chairperson of the same are Dr. Pankaj Puri, Director of Gastroenterology and Hepatology at the Fortis Escort Liver and Digestive Disease Institute, Okhla, New Delhi. Dr. Kaushal Madan, Max Super Speciality Hospital, Saket.
Good morning, everyone. As we can see that people are not much interested in other complications of cirrhosis since the audience is quite thin. So attendance is quite thin. Audience may be obese also. So, so I think this is a hybrid between a panel discussion and meet the experts session because most meet the experts sessions start at around 8 and it's very difficult to get up early in the morning, but still we are here. Maybe that's the reason that attendance is thin. So we'll start with the it will go like this, that there will be two presentations, which the two presentations are selected abstracts. They were submitted as abstracts to the conference for being considered to oral presentations. Out of another 42 were selected for presentation in the oral session for this ISG, for this SIG. So, and this would be followed by a panel discussion. So I'll also request my other experts, Professor Patrick Kamath, also to join us. I'm not sure if we have Professor Russo here, Paulo Russo, Professor Paulo Russo. I don't think he's here, but Professor Patrick Kamath, please. So we'll start with the first paper, which is abstract number 4764 being presented by Dr. Subarma Bhattacharya on performance of MR elastography in prediction of high-risk esophageal varices in obese NAFLD patients. Dr. Subarma, please. So you have 7 minutes to present and 3 minutes for discussion as an open house. Thank you.
A very good morning to all my respected judges, my respected dignitaries, and my teachers. Today, the morning session, I'm starting with my study in my department, that is Institute of Gastrosciences, Liver Transplantation, Apollo Multispeciality Hospital, Kolkata. I myself, Dr. Subarna Bhattacharya, DRNB first year trainee. The title of my study is Performance of Magnetic Resonance Elastography in Prediction of High-Risk Esophageal Varix in Obese NAFLD cirrhosis patients. Starting with the background literature and problem statement, elastography-based techniques has been utilized to non-invasively predict esophageal varix in cirrhosis. Multiple models based upon transient elastography-based liver stiffness measurement has been utilized for the same. Conventional transient elastography has been shown to underperform, specifically in obese non-alcoholic fatty liver disease cirrhosis. And liver stiffness measurement by MRE has been shown to non-invasively predict esophageal varix and high-risk varix in cirrhosis. However, utility of MRE LSM for predicting esophageal varix and high-risk varix, specifically in obese NAFL cirrhosis, remains relatively unexplored. Starting with the literature that we have till now, that Abe et al. At Japan in 2019, he has done a study that consists about 30 patients who are having had cirrhosis, esophageal cirrhosis, and the cutoff value of MRE LSM was 7, and the dominant population were viral hepatitis, specifically hepatitis B and C, and with AUROC value of 0.85. Then next coming to Shin et al. In Korea, they have again their cutoff was 4.58 with any varix AUROC of 0.8 and high risk varix was 0.75, and the dominant population was again viral hepatitis. Matsui et al. At Japan 2018, they had a mixed etiology with NAFLD 35%, with the patients presenting with esophageal varix was 78, with cutoff value of MRE-LS was 4.2, and NFLD subgroup has sensitivity of 100%, specificity of 50%. So can MRE non-invasively predict high-risk varix in obese NAFLD cirrhosis patients? It was a cross-sectional observational study between March 2022 to February 2023, and our objective was to assess the diagnostic accuracy of MRE in predicting high-risk varix in obese NFL cirrhosis patients, and our inclusion criteria, we have included obese NFL cirrhosis with BMI more than or equal to 25 kg per meter square. And exclusion criteria had a current and previous decompensation patient, technical failure of MRE patients, claustrophobic patients, liver space occupying lesion on ultrasonography, pregnancy, and chronic kidney disease on renal replacement therapy. Philips 3 Tesla with M. Dixon's Quant software has been used for MRE, and along with estimating 15% prevalence of high risk ferrics and prior AUROC of 0.75 in Sheen et al. Radiology 2014, we have kept the data of our sample study at around 80. We have taken 82. So total number of patients initially were 124 with the NAFL cirrhosis. Decompensation happened 32, and liver as well in 6. Claustrophobic were 1 and technical failure 3. So after excluding them, now total number of patients we had 82. MR elastography, liver LSM for liver stiffness measurement and screening for endoscopic varices were done on the same setting. Uh, the, the mean difference between the two procedures were around 30 days. The female in results, we had 29.6% female, rest were male, and with mean age of 53.85 plus minus 9.62 years, with mean body mass index of 29.1 plus minus 3.39, with the most of the patient having diabetes 70.2%, with a baseline hemoglobin, mean hemoglobin of 11.5 plus minus 1.7 gram per deciliter, with a platelet mean median amount of 1.3 lakh per cubic millimeter. With the any varics we had 58%, that is 47 out of 82, and high risk varics we had 20, that is 24.6%. There we are showing there's a box and whisker plot. The median MRE LSM value for low risk no varices were 4.9, and for low risk varics it was 4.9, and high risk varics was 5.7, 5.6, and there is no significant correlation between any varics or no varics. Then coming to the next slide, there is a significant correlation between high risk varics and no varics, and low risk and high risk varics correlation. With AUROC criteria, we are saying that area under curve receiver operating curve characteristic for MRE LSM for high risk ferrics was 0.66, whereas for MRE LSM and platelet count combination it was 0.7. So in our criteria we have put the cutoff of 5.2. It came out to be 5.2 with a sensitivity of 82% for high risk varices. So coming to our discussion, our current study, obese nephral cirrhosis patient, we have found 47 patients having esophageal varices, that is around 58% with a cutoff of 55.2. The AUOC is 0.66 for MRE alone with sensitivity of 82% and specificity of 62%. But if you combine with platelet count, that comes around 0.7. Limitation of a study is single center data, lack of hepatic venous pressure gradient, unavailability of vibration control transient elastography to compare with VCT and LSM and VCT platelet criteria. And in conclusion, obese nephral cirrhosis with high risk ferrics has significantly higher MRE LSM values than those without esophageal varices and low risk varices. Technical success of MRE in obese nephral cirrhosis is excellent with failure rates of less than 5%. MRE alone has modest diagnostic accuracy for non-invasively predicting high risk varices, with current study showing inferior metrics as opposed to previous literature. Model combining with MRE LSM with platelet count better identifies the high risk varices in obese nephral cirrhosis and needs further validation in larger cohorts. Thank you for the opportunity.
Thank you, Dr. Suparna. So we can have a discussion or we can start with the experts.
So nice presentation. Question I have for you, when you show that MRE, the spleen is very stiff. And what we find is that is a better indicator of one, portal hypertension, and second, we take spleen to liver stiffness ratio.
Yes, sir.
In cirrhosis, liver stiffness is more than spleen stiffness. Whereas in non-cirrhotic disease, because the liver is not normal, but it's not cirrhotic. Spleen stiffness is more, so a 1.2 ratio. So that is something you can probably do because that study has not been done.
Yes, sir.
Whether you can use spleen stiffness, liver stiffness ratio for
Yes.
detection of high risk varices. So when you finish a paper study, the question always is, what am I going to do next? And that would be my suggestion. The second suggestion would be, remember there's a lot of variability when you look at varices, depending on the operator, how
Yes.
experienced the person is. So when we did CT scan for detecting of varices, experienced endoscopists, the agreement was not very good. So what was complete agreement was when there were no varices, nobody called them high risk varices, and when there were high risk varices, nobody called them normal. Okay? Presence of varices, some called normal, some called varices, and intermediate varices, some called high risk, like that. So make sure the images are stored, and 2 or 3 experienced endoscopists have to sit down and agree that this is low risk or high risk. So I think that should be your next project.
Sir.
I think those are very good suggestions. I think it's a very important point that since MRI is being done for the abdomen, you can simultaneously have splenic and liver stiffness, and you can have this ratio calculated. My question was, how do you explain or discuss your cutoff of 5.2 vis-a-vis other cutoffs which have been defined earlier?
Sir, regarding other studies, like
So,
comparison
like
to.
why your cutoff is higher? Any explanation for that?
Sir, actually, the number of first of all, in our study, the number of subjects were less, and in 3 Tesla machine, whatever that sensitivity, when we have increased the cutoff, the sensitivity has been gone up. So our main motto is for higher sensitivity for screening all those truly positive patients. So we have put a higher number of sensitivity. So the cutoff has been increased for that reason.
And you said combining with platelets. So what cutoff for platelets did you take?
Sir, it was 4.8.
No, the cutoff of platelet.
Cutoff for platelets are 1.8 lakh,
Less than 1.8 lakh.
less than 1.8 lakh.
So any last question or comment?
So, Kaushal, we have a similar poster of around 380 patients of NAFLD cirrhosis, MR elastography, and our cutoff was 5.6. But we usually do, along with an MR elastography, an abbreviated MR. So we can actually see the collateral. So we correlated the stiffness score with the presence of collaterals. Need not be only esophageal varices, just the presence of significant portal hypertension, which would be detected by presence of collaterals on an abbreviated MR. Because that's now you won't start beta blockers only for varices now with the current evidence being that you start it for any clinically significant portal hypertension, and the cutoff we had was 5.6. That's a poster in this conference itself. Yeah.
That's interesting. Right. Thank you so much, Dr. Subarna.
Thank you, sir. Thank you, sir.
May I now request the next speaker? The next speaker is Dr. Arpit Shastri, and he'll be presenting endoscopic ultrasound guided occlusion for large gastric varices. Can we do away with coils?
A very good morning to all. Thank you, INASL organizers, for the kind invitation. I'm Dr. Arpit Shastri, DM resident in the Department of Hepatology, PGI Chandigarh, and I have been working on this project with Dr. Sehaj Rathi, who unfortunately couldn't grace this occasion, and I'll be presenting on his behalf. So to begin with, endoscopic ultrasound guided occlusion of large gastric varices. Can we really do away with the coils? Endoscopic ultrasound has lately expanded its role from being a diagnostic modality to a therapeutic one in the clinical practice. The proximity of the gut lumen to the splenoportal axis has actually enabled us to access the the varus as well as the feeder to the gastric varices for specifically targeting it. It appears to be a safe and effective treatment modality for gastric varices, and in contrast to the conventional endoscopy, it helps in better delineation of anatomy. Moreover, the vision is not obscured by the blood and the food in the stomach when we use the endoscopic ultrasound. Additionally, it also helps to localize the feeder and target it wherever necessary, to prevent the bleed or to treat the bleed. So there have been various modalities which can be used in the EUS, which include cyanoacrylate glue, embolization coils, thrombin, or the gel foam, among which the glue and the coils have been most commonly used. So what does exactly the coil do? It acts as a scaffold to trap the glue, to hold it and prevent the embolization in the systemic circulation. So this cyanoacrylate glue is often diluted with lipoidal, which prevents the block in the needle which has been used along with it. However, if the glue is being used in an undiluted form, we see there is a spontaneous rapid solidification as soon as it comes in contact with the blood, which minimizes the chances of embolization. And in our experience, when it is being used with a 19 gauge needle, especially with trained expert hands, the blockage becomes very less likely. The coils, in contrast, they are associated with an increased cost. The procedure time is prolonged, and often there are difficulties like they're stuck in the needle. So here we present our comparative data on the use of cyanoacrylate glue with and without embolization coils for EOS carried obliteration of large gastric varices. So it was a single center retrospective data which we have collected, which included those with a large gastric varices. Those presenting with the active bleed or stigmata of high risk hemorrhage were included. EUS was also done as a part of primary and secondary prophylaxis for gastric variceal bleed. Coils, the option for coils was given to almost all the patients except for those who had small varices of feeder or those where the cost was the factor. A 19 gauge needle was used to inject the glue with and without the embolization coils, and the primary outcome was the clinically evident systemic or pulmonary embolism, but the secondary outcome was the varicose rebleed and the amount of glue used. So this is one of our patient of chronic Budd-Chiari syndrome, who we can see has a large gastric varices, which was around 74 millimeter in the maximum dimension and seen on the EUS. So what we do, we identified the feeder which came out to be the short gastric vein, and we injected 2 ml of glue in the feeder. As we can see, even after the glue cast has been formed, there is not complete obliteration of the varices, and some of the, as confirmed on Doppler, the persistence flow was there. So another 2 ml of glue was injected with the previous glue cast acting as the scaffold to trap this glue. And subsequently we see there is complete obliteration of the varices when we targeted the feeder to it. So the pre and the post procedure in endoscopic images, we can see there is reduction in the size of the varice as well as a nicely formed glue cast. Coming to our data, we took a total of 52 patients with a mean age of 49 years, which predominantly constituted males, and the etiology being in majority of the cases ethanol, followed by NASH. The primary prophylaxis was done in 41% of the patients, while the secondary prophylaxis was carried out in 59% of the patients. Among the type of gastric varices, the GOV2 formed the majority in our cases. So in most of our cases, we tried to identify the feeder and targeted it. Around 70% of the cases, we were able to identify the feeder, while in remaining 30% of cases, we did identify the feeder, but it was either very small or at an angle that the EUS cannot target it. The technical success in terms of GV obliteration was achieved in 96% of patients, and the rebleed was seen in around 7 out of 52 patients. These were irrespective of the site of bleed, and 2 among them had evidence of gastric variceal bleed. Total deaths encountered were 17%, out of which 5% were related to bleed. And there were no adverse events which we could encounter in our patients, and 2 patients lost to follow-up. So comparing the data between those who received the glue and those who received the combination of glue and coil, 78% had received glue and 22% had received the combination of glue and coil. The median size of varices was 30 millimeter in the glue group, while it was 35 millimeter in the glue plus coil group, with the amount of glue being used 2 ml and 2.5 ml respectively. The rebleed was encountered in 12% of patients who received glue, while it was 18% who received the combination. So there were no significant differences between the two groups. Out of the total patients who bled, 7, the 2 patients had gastric variceal bleed, one of which encountered the bleed at least 1 year after the procedure was done, and this was a bleed from a newly formed gastric varices. And the another patient who experienced the rebleed, unfortunately he couldn't make up. So EU's guided gastric variceal occlusion appears to be a safe and effective treatment modality with minimal complications. In contrast to standard endoscopy, we are able to delineate the anatomy of gastric varices better, localize the feeder, target the feeder, and this concept of using undiluted glue in expert hands can actually minimizes the complications such as systemic embolization. We also see that there is no significant difference in the clinical outcomes of these patients in which the coil and glue is used, or in the other group in which the only glue has been used. So we can actually use this treatment modality to obviate the need of coils, which might be a issue with the cost. So once validated in larger studies, we can potentially bring down the cost and time, especially in the resource deficient settings and in the Indian setting where the patient may not be able to afford every time. Thank you.
I can't help but wonder what would be the element of bias in this. It's very difficult. If you have a patient who comes to you with a large varix and it's a moderate varix, it's the operator. You're counseling, you're giving everybody the option of glue. But how strongly are you giving that advice often matters as to how much it will be followed by the patient.
So conventionally, what is to be done in a case of large varus is the use of coil followed by glue. But since we gave the options to our patient, those who were not affordable, we went ahead with the glue, and we initially inject the 2 ml of glue. We see the response. If not, we additionally added 2 more ml of glue.
I agree.
So the previous
that's all right. My point is, how strongly are you advising for the coiling matters as to how much the patient will take it up.
So we advise coiling in almost every of our patients, sir. Those who were not, where the cost was a factor, we went ahead with the glue, and where the cost was not the factor, we used the coils.
Patrick?
Just a few things about the study itself. So one of the things we have to know how stable the patients were before they came in. All in antibiotics, whether on a vasopressor, in addition, or was it just, so those details are required. And second, death depends. Is it 7 days? Is it 6 weeks, which we typically take for varicose episode? So the number of deaths are important. The main question I have here is, I think the knowledge gap here is, what do we know? Glue is probably the best endoscopic method. People describe success rates about 90%. So the question then is, how much more does EUS add? I'm not talking about coils. That's an additional stage. I think the knowledge gap is EUS guided glue therapy better than blind glue therapy? I'm not saying blind, without EUS. That is the knowledge gap. If you show that glue is better with EUS, then the next step is, now what if I add on coils? Does that become even better? The problem to me here is, if you have 90% success, to show a statistically significant difference, you will require, I did a quick calculation, 1,200 patients totally. So it's a difficult study to do to show the efficacy of EUS. I don't know how common it is. We don't use EUS because the success rate is very good even without EUS. So why add on something, especially in an emergency, control the bleeding. So that is my position here. I'm not sure we know whether EUS is that much better for glue therapy than just without EUS.
The problem is that you are not offering coils because of cost, but you're using a EUS needle and you're injecting through that needle, which means that needle is gone. So what are you saving the money?
So needle we can use in up to 2 to 3 patients. We can use the same needle, and so basically coils are adding the further cost.
So just one more follow. So the two groups are unbalanced. I think there was only 22 in the group. So the difference between the group is those who could pay versus those who could not. So when you do the analysis, you have to do what we call propensity matching. Don't take the whole group. Take your 22 and find patients who had the identical, so age plus minus 5 years, gender, same etiology of liver disease, that then balance, then you should have the analysis. With this unbalanced analysis, the p-values don't make much sense. Okay, so I think your next steps, to me, if you really want to make a big impact and get something in a high quality paper, it's glue with EUS versus glue without EUS. Make sure you've got every patient, stabilized or whatever. Very clear endpoints. There's bleed and there is mortality. And you take mortality, procedure related, 7 days and 6 weeks. That is a good study to me. So that I think should be a future.
We have one question from there.
Just a comment. I've been asking the same questions to Sahaj for a long time, that why are we using EUS? So I think the difference is, in the case of large varices, the number of sessions required. EUS requires you to, allows you to put a lot of volume at a single go. That is the basic difference that we find, and I think over our large experience in pediatric patients, we have hardly needed to use EUS. The only advantage we find is that you can tackle it at one go. You can put in a large volume at one go, which you feel a little you withdraw your hand when you're dealing with a kid with a large virus, and you don't want to inject more than 2 ml at a time. It often can create trouble.
I think to me, I thought the great utility of EUS would be to see whether you've got a large spontaneous gastrosplenorenal shunt, because those patients are the biggest risk, and EUS might help there because you
May
can
also tackle it.
Yeah, so you can, I think that's where it helps. Without that, I don't know.
I think if you get US guided injection of the glue, just find the feeder vessel from the velocity. What is the input vessel, what the output vessel? You can inject directly to the input vessel and get the good result.
I think we'll close the session here. Thank you, because we're running out of time. Question.
So we move on to the next part. Maybe invite the panelists to join us. Dr. Sadhna Lal, Dr. Vandana Midha, Amit Mandot, Dr. Malika Bhattacharya, and Dr. Jimmy Narayan. So we'll need one more chair here. A simple chair will also do. No, please join us. No more paper. You are supposed to be part of the panel. So these are panelists. You are here. So please come up. Can we get those chairs? Will also do. Those chairs. Yeah. Dr. Puri will not ready. So one more chair. So we'll start with this case discussion, and may I request Dr. Pallavi to just present the case, and then Dr. Puri will take over. All of us are.
So, good morning, everyone. So, this is a very common case coming to our OPD almost every day. So, this is a case of obese diabetic with CACLD. So we had a 58 years female, diabetic since 10 years with poor glycemic control on oral hypoglycemic agents, including metformin, glimepiride, and pioglitazone. She was also hypertensive on amlodipine for that and dyslipidemic on rosuvastatin. At the time of presentation, she did not have any symptoms. Clinical profile included a BMI of 30.88. Physical examination was within normal limits. On investigations, we found her to have a platelet count of 1.45 lakhs. AST-LT was slightly deranged of 65 and 49. Her lipid profile, KFT, INR were within normal limits. Ultrasound showed coarse ecotexture of the liver and borderline splenomegaly. FIB4 was calculated and it came out to be 3.46. Fibroscan showed a score, a CAP value of 308, and LSM of 22.8. Her SMI was 50. MR showed a fat fraction of 16%. HGS was 20 kgs. And endoscopy showed no evidence of varices or portal hypertension. So now, can I request Dr. Puri to please take over?
So we have a August panel here. So a few questions. How many would do endoscopy and what cutoffs would you look at if you have a LSM value of 15, 18, 20? At what cutoff values you say endoscopy is required, not required?
Good morning, everyone. Okay, so in a patient who, as such, we would think of NAFLD, related cirrhosis with a LSM of 22. And in a patient, it is seen that, a patient having an LSM of more than 20, and we do not know about the platelet count about this patient, a platelet count of, 1.48. So the LSM of less than 20 and a platelet count of more than 1.5 usually rules out clinically significant portal hypertension. More than that, we would think of portal hypertension, especially if the LSM is more than 25 in that patients, or if the LSM is between 15 to 20, as in this patient, a platelet count of less than 1.10, we would do an endoscopy, screening endoscopy.
So identifying high risk varices, we have many things. Any other comments from the audience regarding this?
This patient had an MR, right?
Sorry, I didn't get that.
It looks like the patient had an MRI.
Yes.
And as far as I know, with MR elastography, none of this holds good because we don't know the appropriate cutoff for MR elastography.
True, true.
If we did a fibroscan, then the question is, would you do an MR elastography next, or would you manage just to the fibroscan? So I'm just talking about the workup, because the common thing, we would go for a fibroscan first. Unless the patient is obese, then we'll go to an elastogram. I don't know if the cutoffs are different based on the etiology of disease. That study has not been done. So we take the usual standard cutoffs for everyone. But I think the main thing here is the study is, do we require separate cutoffs for steatotic liver disease or not? Do we require separate cutoff for alcohol-related liver disease or not? That's a study that needs to be done. Right now, it's just one etiology.
So I wonder how many people are using MR primarily. I don't. So I know you are using.
Yeah, we are using it regularly in our unit. As in, it combines. It gives you a lot of more information than just a fibroscan. So we, as you said, we have cut down the cost of an abbreviated MR, and we get the information about the vessels, about the collaterals. So it's actually a combination of ultrasound with ultrasound Doppler and fibroscan, which we would do in a complete workup. All this information can be.
I guess there, if you're picking up collaterals, my question is, we are not doing a abbreviated MRE, only looking at the MRE, then would you look at doing an endoscopy? Because as Dr. Patrick has said, there's no
I think
such
we would
data.
be doing it. So if there is a patient with cirrhosis, I think I agree that Bavino guidelines say that you can do away without an endoscopy, but I think most of the colleagues probably we still end up doing an endoscopy because it's quite a simple way to find out about the presence of varices, and there are always patients who do not fit in this criteria. So if the patient has cirrhosis, I think most of the times a diagnostic endoscopy to screen for varices is done.
Suppose his fibroscan value is coming as 16. What would be your cutoff if we had a fibroscan?
More than 20 would go for a endoscopy to screen for varices.
Anybody in the audience, how many people use MRE? Few of us. It just adds
So
to
I
the
think
cost. Caution.
MRE is quite expensive, and actually most of the centers don't have it. Even large tertiary care centers don't have an MRE. So I was surprised in the first presentation they did an MRE but did not have a fibroscan available with them. So that was a bit surprising. So most of us would be having a fibroscan but not an MRE. And yes, it will take a lot of time before we define those cutoffs in MRE. Second, I agree with Professor Kamath that I think these cutoffs have not been validated so strongly in non-viral etiologies, especially steatotic liver disease.
True. Conventional, most of us are using.
And there I would agree with Amit that as a gastroenterologist, the way we are trained, if there is a doubt, we would prefer doing an endoscopy rather than.
That's because endoscopy is much cheaper in India. So you're invariably doing endoscopy without sedation as well. Yes.
So the acceptance for MRI is really very poor amongst patients. So that's the reason to use fibroscan and endoscopy if it's required. And I think in India, let me be honest, that the compulsions to do endoscopy are much different from what guidelines say.
I'm Dr. Srinivas.
Can we have the volume a little higher, or maybe I'm.
Yeah. As far as this patient is concerned, I think he has splenomegaly. I think he has splenomegaly. Splenomegaly. If there is splenomegaly, I think we should not have too much of thoughts about doing an endoscopy, because even if fibroscan, sometimes we are getting variable results. Sometimes it is coming 16, in some centers it is coming 22, some 10. Sometimes so much of variation there with fibroscan. I think somebody has a feature suggestive of cirrhosis with splenomegaly, it's worth doing an endoscopy.
I think fibroscan, we go by just what the value is. I think we need to analyze that results a little better, Dr. Kaushal.
Regarding?
So we get such variation in fibroscan values. Analyzing the fibroscan is more than just looking at what the number the operator has given us.
Right. So I think they also give a IQR by median ratio. I think that has to be less than 30% to be able to say that the reading is more dependable. And they also there are 10 graphs which come with that. So I think the slope of those graphs and how regular those slopes are also makes a difference whether those readings are reliable or not.
True.
So in the alcohol world, we know that if you stop drinking at 3 weeks, the stiffness changes. So it's a question of what was done between the two readings. So in the European study that I'm part of, they did a fibroscan, and people, they said, you need a biopsy. And so it was scheduled 2 or 3 weeks after that. So when they did the biopsy, at that time it had changed, because meanwhile patients had lost weight because they got so scared they have fibrosis, they work on weight loss. So there are many things which change. How much you've eaten before, whether you've got inflammation. So I wouldn't discard fibroscan right away. You have to do it properly and make sure standardization, and the requirement is that whoever does it has to be trained in at least 100 before you can be confident about the interpretation. So whether it was part of the learning curve, again, I don't know. And everything, so endoscopy is not that great either, because there's enough published data to show that there's a lot of variation between observers, which I just spoke about before. And so people talk about HVPG. So the results of the NAFL study have come out where HVPG was an endpoint. The variation between the two was about 30% between HVPG, between experts. So even HVPG is not, so it's a meticulous observer who does it will give you better results. But I personally don't discard anything. You use what you can and make the best use of it, and don't use a single test to make your diagnosis. It's the overall picture that makes you decide should this patient be treated for prophylaxis or not.
So, what more would you like? We have a patient who has chronic liver disease, he's got no varices, he's got cirrhosis. What more investigations would you like?
Just want an alpha fetoprotein also, because one of the issues with NASH cirrhosis is the risk of HCC. So alpha fetoprotein, we have I think an ultrasound imaging was done. So
Ultrasound is done. We
yeah.
need anything else? Would you like look for other etiologies?
Yes. So I think every still goes by the principle that NASH is probably a diagnosis by exclusion unless it's biopsy proven. So we would always like to look at viral markers and autoimmune markers also in these patients. Though we know that autoimmune markers can coexist in almost 30% of patients with NASH, but I think as a routine for every patient with cirrhosis, we would do hepatitis B, hepatitis C markers and autoimmune markers as well.
So you said autoimmune markers. If autoimmune markers are positive, when do you decide that you should go forward? Let's look at the same patient. BC is negative, his ANA is positive, his IgG is 1.6.
Yeah, so IgG is near normal, ANA is positive, which is known with around 30% of patients with NASH. So I think liver biopsy in this setting, in clinical practice, I won't know.
So if ANA is positive, what stage would you say, I think we need to biopsy?
So if the patient does not have a clear-cut phenotype of a NAFLD patient, if the enzymes are higher, disproportionately higher, say 3 to 5 times AST, ALT, and the phenotype is not classically matching that of a NAFLD, and those are the patients where we would probably, this is a BMI of 30, I think elderly patient with enzymes being normal, bilirubin being normal. So with only ANA positivity, IgG is normal, I would not do a liver biopsy. So it's more of a clinical decision, and I would like to know what others would also be doing in this situation.
Love to hear what the others would say.
So this patient's ALT was 90, AST was 40 or something. So trivial elevation of ALT.
65 and 49.
How much was that?
65 and 49.
Correct. So trivial elevation. So the question here is, what do we call it? Second is, what we do about it. Even if we say this is NAFLD plus autoimmune or autoimmune, I would do nothing about it. I'll still ask her to work on weight loss. She's got poorly controlled diabetes. Her risk of death from cardiovascular disease is high. She's overweight. That would be the focus of my recommendations in there. So I always work backwards. Will I treat if I make a diagnosis of autoimmune hepatitis? So there are 3 treatment criteria, out of which you have to fulfill 2. One is symptomatic. Doesn't look like she has symptoms related to autoimmune hepatitis. Second is AST, ALT, and gamma globulin criteria. She doesn't fit that criteria. Third is histological criteria. But even if histology shows a little inflammation, 30 kilogram per meter squared for an Indian would be 35 for a Westerner. Poorly controlled diabetes, I wouldn't give a steroid. I'd be really worried about steroids. So I would not do a biopsy at this stage. I'll focus on controlling her diabetes and working on the weight loss. I think that will help her more.
I agree with you, sir. So it's not uncommon to see ANA positive, and we shouldn't jump in and look for AH. We should focus on managing the fatty liver and obesity and control her diabetes, and those are more important.
So echoing the same thought, I think what I would do is ask the patient to try and lose weight, come back after 3 months, control her diabetes. If the enzymes have come back to normal and you are also showing some improvement in her fibroscan values, I think that would be a sign that you're in the right direction and you can avoid a biopsy.
I agree. I think we are, most of us, on the same thoughts. So once we sort of screening of complications, what would you do? How many people would do PIVCA? as a screening? Anybody? Some centers are using PIVCA regularly, so I'm wondering how many here
As a
would.
screening, we don't do, but if the patient is suspected HCC based on AFP or USG, we additionally do PIVCA. So as a screening, no.
Yeah. So endoscopy we've already discussed. What would be the frequency of screening? How would be the screening for HCC and what should be the screening for varices?
Regarding screening for varices, if the patient has initially no varices and there is, ongoing liver injury in the form of either comorbidities like high BMI, obesity, hypertension, or say any patient with alcohol or HBV, HBC, in those patients, we would do it every 2 years, and if there are no ongoing liver injury, I would like to do it every 3 years. And if there are small varices, then again, depending upon whether there is ongoing liver injury, if there is ongoing liver injury, we would do at 2 years or else every yearly.
And AFP screening? How many would do CT as screening? How many people would do a CT scan for screening for HCC?
Well, routinely CT scan we need not do for screening of varices. We have
No, not for varices, for HCC.
For HCC, yeah, every the guideline says now, like every not CT scan, at least initially if there is no, you do an ultrasound and an alpha fetoprotein, which is according to the guidelines, you do it every 6 months and then follow them up, and if there is any suspicion, only then for CT scan, not routinely CT scan initially.
Anybody else? How many would do a CT scan?
So just in terms of terminology, screening is for the general population who's not at risk. And if it's a risk population, that is surveillance. So this is really surveillance.
Should be surveillance. Agreed.
For varices as well. So the ultrasound, again, the same LIRADS people classify as A, B, and C. A is very clear, no problem at all. We'll stick with ultrasound. If they say C, meaning they really don't get anything, well, that's when we'll go to something else. Depending on the age group, it's either CT scan or MRI. If it's B, we'll still repeat with an ultrasound because they say some parts we may not have seen too well, so 6 months later, we would do that. So it depends on how well you could see it. If you see it really well, there's probably no need to do a more expensive test.
So many of the centers, including ours, would do CT at least the first time.
Yeah.
When we diagnose, and subsequent follow-ups, of course, is not possible.
One baseline CT we always do once they are diagnosed, but not as a follow-up.
So as practice in our center also, I think this we started doing from AIMS. There was a study also we published that we were able to pick up patients who were first diagnosed as cirrhosis. We were able to pick up 30% of them, or I don't know the exact number, having a small HCC in the initial presentation. But I agree, at those times, most of the patients were symptomatic cirrhosis. Now we are talking about CACLD. We moved to a stage where we are diagnosing cirrhosis very early. Whether we really require CT at the onset, at the time of diagnosis of cirrhosis or not, we're not clear. But we are doing at least one triple phase, either MRI or CT, once we diagnose these patients with cirrhosis.
Just one. I think the knowledge gap here is whether it's 6 months even for the Indian population. Because over the course of this, I've seen these huge tumors. People have showed huge tumors, portal vein thrombosis. For us, it's a killer. These people don't survive. But here, they seem to do well. I think biologically, this tumor may be a little different. And someone said yesterday in their screening program, they've never seen any HCCs. So whether HCCs that you see here are slower growing, are they biologically different? I don't think we should straightway say, okay, in the West they recommend 6 months, so that's what we're going to do. I think there's enough information here. You can collect people together and find out what's the best interval for you.
True, very true. It's surprising, like you land up nothing and suddenly you find a large tumor. Maybe our need is different. We need to do an evaluation of that.
If it's something is different, I don't agree they are slow growing. I think in our experience, I don't think our tumors are slow growing.
No, what I'm
Catch
saying
many
is,
patients who are, way beyond BCLCC, and many
so,
of them.
so
Yeah.
probably ours are faster growing. Our frequency may need to be more and not extended over 6 months, because invariably your screening program is not picking up small tumors, and by the time these people suddenly land up, you have huge tumors. So the need for endoscopy, as per Bavino, is also dependent on how whether we are finding clinically significant portal hypertension. I think we have discussed some of these already. So is there a need for beta blockers? Not a cirrhotic. I mean, he's a cirrhotic, doesn't have varices.
This is a patient who has cirrhosis, but no varices. There has been trials, a trial of 6 RCTs which have been done with the use of beta blockers, and for the, whether they prevent the development of varices as a primary prophylaxis. So in those patients, it is seen that they have not, definitely shown to protect from the development of varices. Rather, the side effects are more. So in patients with no varices, I would rather, put them into monitoring to do serial endoscopies rather than starting beta blockers. That's my opinion.
But the newer evidence also says that it may prevent the decompensating events if they have clinically significant portal hypertension, even without the presence of varices. So if there is evidence of CSPH, then beta blockers may be considered, not just for the varices, but overall for the decompensation.
Another factor in these type of patients, beta blockers use also depends upon the underlying cardiac, because the patients have a diabetes. So we need to get thorough cardiological evaluation prior to starting the beta blocker.
True. But per se, the basic heart rate is okay. The patient not in clinical failure. Need for echo? I don't know. Maybe I would not do. Unless the patient is symptomatic, just before starting a beta blocker, how many people would do a echo and cardiac evaluation? I wouldn't.
Maybe I missed something. Based on this information that we have on the patient, the question is, are we starting beta blockers, or did we have an endoscopy which showed?
We have an endoscopy which does not show beta varices. Should we start beta blockers or not? That's the question.
Yeah, so we have to see how the data was derived. And so the Bhavin, I think it was a bit too aggressive. It was patients who had varices were started on beta blockers, or they had high pressures and were started on beta blockers. In that selected group, there was better survival.
True.
And that has now been applied to everyone who has never been screened. I don't know if that evidence is strong enough. I think the future will tell us whether the recommendation was right or not, whether more harm or benefit was done. In this patient, I'll be a little careful about starting on beta blockers just based on the information I had. This is something you really need to discuss with the patient. Go over the side effects. Beta blocker side effects are not trivial, especially in a diabetic. Does she have peripheral vascular disease? Does she live in Delhi? Because if it's cold, they get really bad, cold extremities. All these are difficult things for patients. So this requires a discussion. So I wouldn't straightway say I would put on beta blockers.
So I would not. Similarly, again, I would not start. And at the same time, in a diabetic, my concern would be that it would mask the hypoglycemic symptoms. And that would be of concern as well.
So the question here is, had the endoscopy not been done, so the LSM cutoff of 22, is it enough to push you in starting beta blockers? That should have been the question.
Yeah.
Had the endoscopy not been done. So I think the cutoff defined for clinically significant portal hypertension LSM is 25. But again, I agree that has not been validated in non-viral etiology, so we have to take that into account.
There has been a study using timolol where in clinically significant portal hypertension, when they have given it for 1 year, there is a reduction in the portal hypertension by about 20%. But of course, because of the side effect profile of the drug, it was not used. But in other beta blockers, they have not shown any benefit of progression of varices, even if there is a clinically significant portal hypertension.
So tell me, drug selection for NASH. So how many people, besides controlling diabetes, weight, obesity, how many people would look at specific drugs for NASH?
The question is, would you give specific drugs for NASH to every patient, or
in this patient?
I would start vitamin E with whatever retrospective evidence available in compensated cirrhosis. The only available evidence is with vitamin E. That was a retrospective study on compensated where they found a survival benefit. So I would start with vitamin E, specifically for NASH.
Anybody else?
Sorry?
Anybody else? Any other comments?
I'm again speaking from the US standpoint. We have no drugs approved for NASH, so we won't treat for NASH alone. But you take advantage of drugs that may help diabetes and weight loss, which may also have some benefits. So that's the GLP-1. So no drugs, as far as I'm concerned. Try and work on the weight loss and the diabetes.
Kaushal, any comments on
I agree
saroglitazar?
with Amit. I will at least start the patient on vitamin E and maybe a combination of vitamin E and saroglitazar. Saroglitazar is an approved drug, at least in India. It has shown to reduce significant amount of fat, mobilize a significant amount of fat from the liver, significantly reduces AST, ALT levels. And now there are some studies which suggest that ALT reduction, if it's more than 30%, that may be taken as a surrogate for improvement in NASH. So yes, I agree, there are no drugs approved for use in NASH, but these two drugs can definitely be tried.
Okay, so go back to choice of anti-diabetics. This patient was on pioglitazone. Sorry, yes.
Will you still use vitamin E because the patient is a diabetic?
You're asking that because the randomized control trial did not include diabetic patient. Is that
there are some bad outcomes with vitamin E in diabetic patients? So
there are some.
I think bad outcomes in a patient with diabetes with vitamin E.
There are now there was I think another randomized control trial of vitamin E and pioglitazone in diabetics by Brill et al., which showed that vitamin E does improve histology, although it was not significant. The combination of pioglitazone and vitamin E worked better. And then there's a large retrospective data from I think Dr. Chalasani's group, in which they have used vitamin E for almost 5.6 years, the median duration, and 70% of patients had diabetes and 2/3 were cirrhotics. And they found that it reduces all-cause mortality as well as improved histology.
So evidence is only with vitamin E.
I must say I share your same cautions because that was a subgroup analysis. From the initial analysis, they excluded diabetes. Then they looked at a subgroup, and in them, it seemed to be beneficial. So subgroup analysis typically is not used to make recommendations. It's used to generate hypotheses saying, should we actually do a study in this? So diabetic vitamin E, I don't use.
Dr. Madan, is that natural vitamin E or the synthetic vitamin E which has been used?
I think we need more data on that, and I think for ages we've been using the synthetic one, and now the tocotrienol fraction vitamin E also is coming, but we need more data before we can say this one is better or that one is better.
So while the debate has been on vitamin E, the question was the safety of vitamin E, not the efficacy, if I'm right. I think the data there have been concerns on the safety of vitamin E, but they have not been substantiated so far. So that per se is not a reason not to start. So the last, I think we're running out of time, is choice of anti-diabetics. My problem with endocrinologists treating patients with NASH is they are only looking at making sure the sugar is under control. What happens to the patient, be damned. And this patient is on pioglitazone, she's obese. What would be the choice which would help in improving the NASH in this patient? What drugs would you like? Often I would prescribe drugs on our own. Last question.
I think they should be enrolled in a semaglutide trial for cirrhosis, which is ongoing in the sense that.
So the two drugs which have shown to have a little bit of benefit are the GLP-1 receptor analogs and the SGLT2 inhibitors. The SGLT2 data on fibrosis reversal is not there. The GLP-1s are better. The longer acting GLP-1s like semaglutide is nicer. The oral ones have just been marketed in India, and that's something we all look forward to as well. I think at this we will close the session as the time is up.
No, true, but I didn't understand what the question. The question is, would you, based on that, would we recommend it as treatment? No, I think we have a lot to work on her. She's overweight and
The SGLT2 inhibitors cause about 2 to 3% weight loss. Data so far shows efficacy in improving steatosis and enzymes, but no data on fibrosis reversible, which is good enough. I think we should wind up here. Thank you.
I think we're running short of time. We thank the panelists as well as our experts. Thank you so much, sir. And since we don't have time, we were planning that we'll present two studies which we will be doing through INASL, and we'll send you, Dr. Pallavi will be sending you the details of the study, and whoever wants to participate in that as a multi-center trial can do that. I think whoever is interested in doing those studies, I think you can have names of people who are present here, the centers who are present here. If they're interested, the details can be sent. Thank you so much.
Okay, so now we start with the very prestigious Dr. N. Madan Gopalan oration. The chairperson for the same are Professor Dr. S.P. Singh, Chairman Kalinga Gastroenterology Foundation, President INASL Dr. Ajay Duseja, PGIMER Chandigarh, Secretary General INASL.
Good morning, everyone. Welcome to the prestigious Dr. N. Madan Gopalan Memorial Oration. Few words about Professor Madan Gopalan. He was born on 25th October 1933 and called as Dr. NMG to all his colleagues and students. He obtained his MBBS degree in 1955 from Stanley Medical College, winning medals, prizes, and certificates of honor in most subjects, and achieved the first rank in the University of Madras. He passed MD Medicine in 1959, received MRCP with elementary diseases as a special subject in 1960, and he was trained in UK by Doynes in the field, including Shri Francis Avery Johns. On returning to India, brimming with confidence, the rising son from South joined his parent department at medicine at Government General Hospital, Madras, and under the guidance of his mentor, Professor Ratnavelu Subramaniam, the Department of Gastroenterology was established for the first time in Madras Medical College in 1971. He continued to head the department until August 1986, and during his tenure, he nurtured the department with untiring, unsparing dedication, breathing life into nascent specialty, grooming the department not only into a premier national academic center, but also creating awareness, emphasizing the importance of gastroenterology and hepatology amongst both medical fraternity and democratic hierarchy. In 1986, Dr. NMG handed over a well-established center to his students and started another department of digestive health and diseases at Government Peripheral Hospital, Anna Nagar, attached to the Kilpauk Medical College Hospital. His love for teaching drew no bounds. His clinics including Sunday classes, attracted large number of students from various institutions, including postgraduates from Department of Surgical Gastroenterology. Apart from teaching, Dr. NMG passion for research knew no bounds, and the symbiosis of passion for research, uh, mainly in the area of viral hepatitis, hepatocellular carcinoma, subacute hepatic failure, and role of adulterants of edible oil and tea leaves and carcinogens for HCC and adulteration of edible oils and rubber seed oil as a cause of increasing prevalence of chronic calcific pancreatitis. The Indian Society of Gastroenterology elected him unanimously as its president in 1975, and later in 1988 he was elected to the post of president of Indian Association of Study of Liver Diseases. His services and expertise were liberally used to planning and structure the curriculum of National Academy of Medical Sciences. Some of his close associates included Professor B.I. Mathan, Professor B.N. Tandon, Professor N.C. Nayak, Professor Solomon Victor. Professor B.I. Mathan said, far more than erudition, what impressed me was his concern that the best in the students should be brought out. The fraternity of hepatology salutes the father of hepatology, and INASL started the oration in the name of Dr. An Madal Gopalan in the year 2010. And some of the earlier recipients of this oration include Professor Andrew Burrows, Professor Vijay Shah, Professor Chawla, Professor Deepak Amrapurkar, Professor Rakesh Agarwal, Professor Sareen, Professor Acharya, to name the few. And last year, this was given by Dr. S.P. Singh. So for this year's orator, I'll now invite our president, Professor S.P. Singh.
Good morning. What a pleasant surprise it is to introduce today's orator, the dynamic Anil Arora, my friend. I don't think he needs any introduction. He hosts us all every year in and around September. But still, I have to do some justice to my duties here. So he's a gastroenterologist par excellence. He's a complete package. He did his liver transplantation fellowship from Queen Elizabeth Hospital, Birmingham. After his DM in gastroenterology from the prestigious AIMS, New Delhi. He's got all the FRCPs there are in this world. Edinburgh, London, Glasgow. He might be having more. These are all I know of. He's set up in Sir Gangaram Hospital. He's heading a nice Department of Gastroenterology, Liver Transplantation Center. And he's got a large number of publications to his credit, somewhere around 230, 40, 50 in that range, on varied subjects. As I said, he's a complete package. He's known for hepatology practice, research in hepatology, but in addition, he's involved in the other facets also. He must have done probably somewhere around 400 or 500 poems. And the ERCP does everything, and in addition, guides people in research and conducts his famous gastroenterology meeting, which has taught many how to organize meetings. That is also an art. And his meeting, it has an international flavor. You have people from all around the region, not just from India. More foreigners attend that meeting than this meeting or ISG probably. So, besides one of his greatest contributions to hepatology, Indian hepatology and INASL is his contribution in the field of hepatitis B. My unfinished job work he has completed, what I had dreamt of, guidelines for management of the Andaman guidelines for management of hepatitis B in India. In addition, he's gone one step further, and hepatitis B has different sets of problems. So, a lot of guidelines related to Hep B and other. It is he who has conceived them and got them for us. So, with these words, I now request Professor Anil Arora to come join me here and start his oration. Professor Anil.
Thank you, Dr. Singh and Dr. Ajay, for these words of appreciation. At the outset, I feel humbled and honored to be bestowed this prestigious oration for a person who was so humble, down to earth, and a good human being. He had been our teacher and had been having our regular classes in the AB2 wards of the All Indian Institute of Medical Sciences. I wish we could imbibe only 1% of his humility, honesty, and sincerity and dedication to the work. I thank the INASL and its organizing team for giving this opportunity. Thank you, Ajay and Dr. Singh. The topic which I have chosen today is lessons learned in management of hepatitis B. Where have we gone wrong? How do we de-learn them? And then what do we do to relearn the lessons from whatever we have learned and de-learned? Your slides are not moving. Yeah, WHO has set up a goal of eradication of hepatitis B by 2030 with the aim of preventing the target, testing around 90% of the targets, and trying to eliminate 80% of the infections. So forget about a country like India. Even in country which has a low prevalence and incidence of hepatitis B, that is US, even over there, it is a far-fetched dream that we'll be able to get rid of hepatitis B by even 2040. We have to understand what are the lessons we have learned over the last 50 years since the discovery of hepatitis B. There are some of the lessons which we have to de-learn by choice, because I think we have been making a lot of mistakes in managing, and going forward we have to relearn what needs to be done about hepatitis B. Starting with the lessons which we have learned till now, the virus which was discovered way back in 1963 by Professor Bloomgard, the credit of celebrating his birthday goes to Professor S.P. Singh. To his credit, the whole world recognizes his birthday as a hepatitis day virus, and I think I am sure all of you know the Herculean efforts made by Professor Singh in trying to inculcate this habit of celebrating his birthday. Since then, over the last 60 years, there have been advances in diagnosis, various aspects of diagnostics in hepatitis B, and the development of the various antiviral agents like nucleoside analogs and the receptors like anti-CP, which have tried to give us the basic biology of hepatitis B and the way forward. But still, in 2023, it continues to be a global problem with India being in the intermediate range of the endemicity. We have also learned over the last many years that 15 to 20% of those infected chronically with hepatitis B will develop cirrhosis, and those with cirrhosis are likely to decompensate at a rate of 10 to 15% per minute per year. And we also know that those with decompensated cirrhosis are likely to die of complications of hepatocellular carcinoma. With passage of time, we have understood the pathobiology of hepatitis B. As the virus enters into the cell, it tries to envelop itself, goes and makes a sweet home in the form of cccDNA, which is the culprit against which we are having a big fight. And this cccDNA is the template for producing billions of the copies of the mRNAs, which are translated, assembled, and reassembled into the virions, which are extruded at a brisk pace to keep on perpetuating the replication of the virus in the blood. We have also learned over a passage of time, when we are trying to define and redefine the various patterns of hepatitis B presentation, that there are patient may be having E antigen positive or negative state, and depending upon the degree of elevation of ALT, you may be having E antigen negative hepatitis or E antigen positive hepatitis or infection. We have also learned that if it is an acute infection, you do not need treatment. In adult, 95% of the patients will have spontaneous resolution. You do not need any treatment. It is only the patient who are stuck up with chronicity, which is variable depending upon at what stage of the age do you develop infection, and this chronicity may vary anywhere from 95% in the at the time of the birth if you have acquisition of the infection, to only 5% if the infection is acquired in the adulthood. And I think this is one of the most quoted studies to my knowledge in field of hepatology. This is a study which possibly will never be repeated. This is the evolution of hepatitis B in the natural history of the disease without treatment. And I'm sure this study clearly showed that there is a direct relationship between the DNA levels and the occurrence of the cirrhosis over a period of time. Because this was a natural study, it could have been done only in countries like Taiwan, it will never be repeated, and hence is one of the most important studies to remember. We have also learned over the last few decades that there is a availability of the effective vaccine. So we were fooled. Say here is a vaccine which is totally preventive, has side effects, it's pretty cheap and effective. So would hepatitis B be eradicated? But even though the vaccine was available in 1981 as a plasma derived vaccine with newer modification landing up even in 2021, we still know that the coverage of the vaccination, at least in the developing countries, is pretty poor. But if you see the lessons from both South India and the Western Pacific region, as the vaccination coverage goes up, you have a substantial reduction in hepatitis B prevalence and incidence, both in the Taiwan as well as in the Western Pacific region. Again, to the efforts of the INSL, especially Dr. S.P. Singh, we have been able to push this universal vaccination for hepatitis B in Indian scenario only in 2009, and it was quite almost 20 years after Taiwan had done the same in the Indian scenario. We have learned over a passage of time that there are three parameters which decides what happens to hepatitis B, that is ALT, DNA, and E antigen, and there is a direct relationship between the presence of the virus in the liver, occurrence of inflammation, and development of hepatocellular carcinoma. Again, coming back to the same study from published in JAMA this is a REVEAL study, that not only the cirrhosis, but there is a direct geometrical relationship between the amount of the HBV DNA in the blood and occurrence of hepatocellular carcinoma. So the mere presence of the replicating virus is not an innocuous event. There is something called a quiescent phase. So something is going at the background, which more often than not we are missing because of the lack of the tests which tells us what wrong is going on inside. I'm sure if Dr. Acharya, Dr. Vivek, and my seniors are available in this gathering listening to this talk, they had taught us way back in 1987 when I was doing DM that if you have a low HbS-Ag level, if your DNA is low, if you have a raised ALT, this is the subgroup of the patient who will respond best to the antiviral treatment. And 40 years down the lane, I'm sure most of you would agree that these simple observations have stood the test of the time. We have also learned in the past that if your patient is immunocompromised, even if HbS-Ag gets eliminated from the blood, there is a risk of reactivation whenever the immune system gets plummeted and the immune system gets compromised. So we, with the help of the INSL and Dr. S.P. Singh, we had these guidelines for management of the patient in the immunocompromised patient, especially with the advent of new biologicals, which are going to be part and parcel of therapy for not only hepatitis B, but other agents, other illnesses like ulcerative colitis, bronchial asthma, and other conditions in which the hepatologist comes into being repeatedly. We have learned a large number of the drugs which are available in the market, and fortunately we are able to filter down to only two drugs, entecavir and tenofovir, with various combinations, and realizing with passage of time, at least in North India, there is hardly role of any interferon in this. Again, as Dr. S.P. Singh said, his dream of writing the guidelines were fulfilled by his blessings from INSL, in which in 2018 we published our own guidelines on management of hepatitis B. But we realized that with passage of time, what hepatitis B is doing is it is only trying to reverse the fibrosis in 50% of the patient, prevent the decomposition in about half of the population, reduce the risk of the hepatocellular carcinoma and decrease the mortality. So the addition of antiviral agent in patient with chronic hepatitis B was always a welcome relief because a sustained HBV suppression is the hallmark of ongoing response in therapy. But even in 2023, I'm sad to inform you that of the total pool of hepatitis B, only a portion are eligible candidate for management, and of those who are eligible for management, the chance of losing E antigen is only 50%. And of those who are treated, the chance of losing HBs antigen is very minuscule, with hardly ever reduction in the culprit called cccDNA. We have also learned with passage of time that if the patient has pregnancy, so the last trimester of pregnancy, if the patient's DNA, HBV DNA is more than 2 lakh international units per ml, so this is the subgroup of the patient who requires antiviral therapy. Again, INSL gave us the opportunity to write this guideline on management of hepatitis B in pregnancy, which we did efficiently. So this is the current status, that even though hepatitis C, which was discovered almost 20 years after hepatitis B, and which is almost on the brink of extinction by 2025, here is a virus which was discovered 20 years prior, and still we are trying to grope in the dark, trying to redefine different types of cure: partial cure, complete cure, functional cure, sterilizing cure. That is the unfortunate part of the story. And ladies and gentlemen, we continue to swim in this dark tunnel, trying to understand the basic nuances of what is hepatitis B, how to manage it, what is the best way to get rid of it. That is where we switch on to what are the lessons we have to do de-learn. These are the lessons we have learned till now. There are, I think, some lessons which we need to de-learn before we start eradicating hepatitis B from the world. First and foremost, we have too many guidelines: APASL, INSL, EASL, the incorporating various components of management like different types of ALT, DNA levels, presence or absence of the cirrhosis, absence or presence of immunosuppressive agent. And if you look at these guidelines, I'm sure most of us will have wobbling head and vertigo. And the reasons for this is that major chunks of the patients still remain untreated if you follow these guidelines blindly. And 30% of these patients who are sent away because you do not fit in the guidelines, they are refused treatment, they will die of liver disease. And the majority of these patients will ultimately relapse. The reasons for strict guidelines is lack of the potent drugs, gap in the understanding of the basic pathophysiology of the virus, and guidelines tend to be too restrictive. We also had wrong impression. That is something which we have to de-learn. That if a patient has a normal ALT, if there is low viremia or E antigen is clear, we should sit pretty about it and do nothing. That is where we have to change the mind. This is a recent publication which shows that if you strictly follow the guideline and exclude these patients as per the recommended guidelines, 30 to 50% of these patients will develop hepatocellular carcinoma or dying, because you have flimsy reason, ALT is not elevated, DNA is low, and patient has not long-standing hepatitis B. So this is what happens. Earlier, it was a belief which we have to de-learn: a normal ALT is safe. But let me give you this data. Are we sure what is the normal ALT? Different guidelines tend to give you different answers, varying from 19 to 40 to 50. So we do not even know what is the normal ALT. So how do we keep on excluding these patients? In fact, too many criteria for normal ALT. Is it really required though? There is a good study from Korea, which has shown that even in immunotolerant group, there is a high 6 times more chance of dying compared to a placebo if your patient is immunotolerant phase. So immunotolerant phase is not an innocuous phase. Even though the chance of complication in the form of development of chronic liver disease and cirrhosis are low, it is not negligible. And there is the occurrence of cirrhosis as well as the progression of the cirrhosis is a function of the age and time. It is not a mind, it is not a function of the ALT. So with increasing age, you are more likely to have cirrhosis, and with increasing passage of the acquisition of the infection, you are more likely to have cirrhosis. So cirrhosis is a function of time and age, not the ALT. That is something we have to de-learn. It was believed that if you are a normal ALT, do not do anything, but then even in patient who is E antigen positive, the chance of developing chronic liver disease and complication are high. There is data both from the India and the Western countries that if you do liver biopsy in patient with normal ALT, 26% of the patient may have substantial fibrosis giving you the problem. So why ALT level may not be a good parameter for treatment? Because it is a virus. It is a long-term risk of complication which is related to the viremia. Moreover, HbEAg seroconversion may be a useful parameter for duration of the therapy. It cannot be a surrogate marker to stop the therapy. If the long-term treatment is needed, so be it. Long-term treatment is also needed in diabetes and hypertension. Do we ever think of stopping the drugs? Fortunately, we have drugs which do not have any resistance. Is normal DNA level safe? In fact, it has been shown clearly that hepatitis B is a unique virus which has a twin problems, are not only causing first cirrhosis and then HCC, there is a direct mutagenicity, because even in the absence of the cirrhosis, the virus integrates into the human genome causing malignancy, and has been amply clearly shown again by the study from Taiwan, that is reveal study, that there is a geometrical relationship between the amount of the DNA in the blood as well as the occurrence of hepatocellular carcinoma. The cumulative incidence of HCC is 14 times after 13 years of acquisition of the infection. Does HbE antigen positivity or negativity matter? It used to matter in the era of interferon. So interferon era, it has no negativity. And if you look at the negative and the relevance of hepatitis E antigen in the natural history of hepatitis B, almost all patients beyond the age of 30-35 years will clear E antigen spontaneously. So whether it is positive or negative in today's era, it does not have much relevance. Hepatitis B is also known to go through phases, and we tend to put them in boxes. We should realize virus has not read these guidelines. Virus is not something which can be packed into boxes. It has its own way of multiplication. So we should not be restrictive in trying to see, 40% of these patients. If you look at the natural history of the disease, if we keep on excluding our patient for treatment, we'll be missing out 40% of the patients who will be in the intermediate phase of hepatitis B. So prophylactic vaccination, we have been doing wrong. We have been saying that vaccination should be given only to the high risk group. I think the time has changed. Even in WHO bursary recently says that now vaccination should be given to all eligible patients all over the world. So this change is something which is new. And these are the lessons which now need to be relearned after de-learning a lot of lessons. Guidelines have to be more liberalized. And I'm happy that Chinese guidelines have given clear answers. You treat everybody unless there is a contraindication not to treat. Short of that, in fact, if you look at the green bars, it is covering up almost all types of patients who need to be treated. I'll request Dr. S.P. Singh that I think down the lane, we had published this guideline in 2018, and 6 years down the lane, we should be writing our new guidelines to be more liberal. Now, with liberalization, INASL also believes anybody who is more than 30 years, LSM more than 10, family history of hepatitis B, concomitant morbidities, and those with NSAIDs should be treated. We also have to relearn and re-understand the basic pathobiology of hepatitis B. We have been missing two important targets, cccDNA and the immune system, which was totally left unattended. That is the reason if the virus continues to make merry at our own cost, at the peril of our hapless patient. We have to go back and understand the biology of the virus as it enters into the cell, gets into the nucleus, tries to make transcripts of the various RNAs, reassembles and get out of the cell. We may have to be acting at the different levels of the cell cycle to get into something which may be more curative. Two things which we have missed till date are the integrated cccDNA and the cccDNA, that is covalently closed circular DNA. So we have to keep changing the goals. At the moment, the present goals of maintaining a normal ALT, DNA, or absent AC is not enough. See, we have to keep changing our goals. Our initial goals were normalization of ALT, loss of A antigen, and DNA. I think we have to switch on to clearance of the SC antigen and cccDNAs. What we have achieved till now with the current antiviral therapies, ALT normalization, loss of E antigen and HBV DNA. 5 years down the lane, we have to go and achieve S antigen. But the futuristic goal should be to get rid of the virus, and hence we are trying to redefine what is a partial cure versus a functional cure. Because we know even if we clear the antigen, the chance of development of HCC still remains, and hence we have to look for something which is a goal called a sterilizing cure, in which we should make all efforts to get rid of the HBV DNA. So we need to start the treatment at early stage of hepatitis B, and the drugs which are available at the moment have no significant control on losing hepatitis B virus cccDNA. We have to think beyond antiviral agents by incorporating drugs which will act on the immunity, and a combination of the drugs, new drugs which we talked yesterday, may be the answer. Therapeutic vaccination is something which will have multiple sites of action and maybe the future therapy in hepatitis B. And in addition, we may have to look for the newer markers of HBV replication, as was mentioned by Dr. Nora, in the form of HBC correlated antigen and HBV RNA. So, ladies and gentlemen, time has come when we may be seeing the light at the end of the tunnel, so that we have some hopeful insights into management of hepatitis B. To sum up, we have learned a large number of the lessons from hepatitis B over the last 60 years. These include the epidemiology of hepatitis B, the immunopathogenesis of hepatitis B, reliance on ALT, HBV DNA, and E antigen for control of the virus. We also know the predictors of the response. We also know the limitations of the current therapy. We have learned about the history of the disease, natural history of the disease, vaccination, and immunosuppressing agent. But there are some important lessons which we need to de-learn. And these lessons which need to be de-learned are that we have too strict guidelines. We should be liberal about it. We should not believe that normal ALT means safe patient. We should also realize that absence of the DNA doesn't mean the virus has been got away from the body. We should also realize that negativity of HBe antigen is not enough for us, and we should start giving vaccination to all, not to the restricted to the high individual group. Finally, a time has come, ladies and gentlemen, when we have to relearn lessons. We have to re-understand the basic biology of the disease. We have to look for newer drugs. We have to look at stimulating and trying to invigorate the newer immunotherapeutic agents. We have to look for a good therapeutic vaccine with more liberal guidelines, changing goalposts, new antiviral drugs, and polytherapy. We may be able to do some justice to this vicarious agent which has been giving us a problem. To sum up, and finally, optimism is the faith that leads to achievement. Nothing can be done without hope and confidence. That is by Helen Keller. With that, I'll end up my presentation.
Thank you, Dr. Arora, I think, for that wonderful oration and taking us through the journey of hepatitis B, the lessons learned, de-learned, and what we need to relearn. Kindly please come here for the felicitation.
Thank you so much, everybody on stage. Now we move to the next session, State of Art Literature, and the chairperson for the same are Dr. Abraham Koshi, Director of Hepatology and Research, VPS Lakeshore Hospital, Kochi, Dr. K.T. Shenoy, Professor and Head Gastroenterology, Sri Gokulam Medical College, Thiruvananthapuram, Dr. M.S. Khuro, Director, Dr. Khuro's Medical Clinic, Srinagar.
Thank you very much. Good morning to each and every one of us. The topic which we are going to discuss is the future of hepatology.
Yeah, good morning, dear Chairman, dear organizers, SP, AJ, again. Thank you so much for inviting me to give a brief overview on our thoughts about the future of hepatology. And you know, how will be the future? This is always a big question, and you know, prediction is always difficult, particularly when it involves the future, as Mark Twain said once. But Alexander and I, as Secretary Generals, we took the opportunity to look into the future, and we wrote an editorial that is now available, and it's open access in the Journal of Hepatology. And I can give you, in the time I have here for this presentation, only a couple of views on what we thought about could be important for the future. I will first want to talk about one major trend in healthcare that affect all disciplines in medicine, not only hepatology, but of course will also influence the way we are working in the future. And this is all what is summarized under the umbrella term of artificial intelligence. And I think here are great opportunities, but also challenges. And of course, all the data you are collecting in clinical routine, all the imaging techniques, pathology, all these could be employed by these new technologies. And I would like to give you two examples to highlight a bit on the topic. The one is an artificial intelligence assisted prediction model for HCC risk in Hep B. And you see with this model, AI-based model, it outperformed other models that are established. But it also shows you the challenges and the downsides, perhaps, because it depends on the data that are included in the model. And if you look what factors are included influencing or be predictive within these models, these are the factors we know already quite well. So we have not really learned something new about these, with these new AI-based models. However, it can be different if you go less, if you have a broader database. And here is an example, and I think this will become more and more important, that we do go non-invasive in terms of staging of liver disease and also predicting what will be the outcome, treatment responses, and so on. And here you see a paper on non-invasive proteomic biomarkers. So what the authors did, they had liver biopsy in alcohol-related liver disease, and you can also think about non-alcoholic liver or steatotic liver disease here. And they tried to predict with a plasma proteomic approach based on a machine learned model, can we predict fibrosis, inflammation, steatosis? And you see this proteome model based on machine learning outperformed all the models we have involved so far to predict these things. There are also challenges and opportunities, and I think the practice of hepatology will significantly change over the coming years as advances in AI and machine learning continue to accelerate. But the challenges are that the current state of this technology and the future possibilities, we need to understand these so that can be incorporated in our future practice. And we will see more and more papers coming. And it reminds me a bit on the early days of the human genome studies, where we had so many studies evaluating certain SNPs and all found a very significant correlation with disease. But we have to learn, and also as a reviewer, to understand what is really the methodology behind it to rate the quality of this study. And perhaps we need more validation of these models in the future, perhaps randomized trial, and also to include more diverse population to mitigate inherent biases that are linked to these new approaches. And we may consider whether, if these algorithms are developed, whether they should be treated as medical devices and thus means also regulation by medical agencies. So please let me move forward to some more disease-specific trends. And it was already a couple of years ago when former Secretary Generals Tom Carlson and Frank Tucker thought about the future landscape in hepatology. And they predicted that NAFLD will increase, Hep C will decline, cirrhosis may increase a bit, especially public health may become a more important part, and hepatocellular carcinoma. In our editorial, we looked in publication trends over the last 10 years. And indeed, and it's no surprise, fatty liver disease has the hugest increase among all the disciplines. But I think we were really a bit surprised, and probably you are too, that liver cancer was one of the fastest growing field in hepatology publication. Hep C, of course, is declining, and we see that alcohol-related liver disease is largely understudied. And this is also reflected by research trends when we looked as a factor of clinical trials being depicted in clinicaltrials.gov. This is an algorithmic scale, please be aware. So the highest numbers of actively recruiting studies you see in liver cancer, cholangio and hepatocellular carcinoma, then followed by fatty liver disease, still hepatitis B. Again, alcohol-related liver disease, although so common, very much underestimated. I would like to give 3 examples on liver disease or disease-specific trends. And of course, it's just an example, but as I mentioned, I cannot touch on everything. But what I think it's will change in the future and become more and more important is really the field of liver tumors. You see that we have more and more drugs available. There will be the field of combination therapy. And of course, we have to go in more a precision oncology, and herefore defining subtypes of hepatocellular carcinoma is just starting. We get more and more data, and I think this will change the field towards precision medicine, that we know better who will benefit more from a TKI, local regional or combination therapy, immune checkpoint inhibitor therapy, and so on. And with cholangiocarcinoma, we are even a bit more advanced here, that we have already classified many druggable targets in the tumor biology. And I think this will further develop. Another point, and it was also mentioned by Professor Arun Sanyal, is that perhaps we have underestimated sex dimorphism in our understanding of the pathophysiology of certain liver disease, but also perhaps treatment response and outcome. And the liver is an organ with the highest sexual dimorphism of all our organs in the body. So 70% of all pathways in the liver are different between the sexes. The next disease I want to talk is steatotic liver disease, or metabolic dysfunction associated steatotic liver disease. And I think with the advent of understanding fatty liver disease as a multi-organ disease, we really started as hepatologists to understand the crosstalks between the tissues and the organs. It all started about the gut microbiome, the liver-gut axis, the axis between liver, fat, and the fat tissue, the adipose tissue. And this, I think, will further help to better understand what is going on, and to see also the liver more in part of an holistic approach. So it's quite clear that we do see now NAFLD as a systemic disease, affecting that on how the fatty liver can affect all the other organs. And it's just really to start that also other disciplines are realizing this. And it was really funny to see that last year a book was published called Cardiohepatology, clearly telling us that for us as hepatologists, there will be a huge opportunity to look on these crosstalks and to be more open to an interdisciplinary approach to understand better how an affected liver may affect other organs within the body. A brief word about the nomenclature. And you may think, well, a nomenclature is a lot about a name, but I think it's much more than a name, and it's, for me, really a starting point for a new way of looking into fatty liver disease. We are all aware that we have not fully understand the pathophysiology of fatty liver disease because there are so many subtypes. There are subtypes, of course, that are part of the metabolic syndrome, but we have it in children, we have it in the lean population. There's a genetic distribution. There might be fatty liver just because of a leaky gut. So the new nomenclature with the subclassifications that so far is not, let's say, fully explored because we do not have all the evidence for the different pathophysiologies behind the different subtypes. But this can be easily incorporated, and by giving these schemes, our community has now the chance to really study more specifically what will be the outcome in these different forms and subtypes of fatty liver disease, and to further elaborate this concept that can be then easily implemented into this algorithm. The last point is cirrhosis and ACLF. And of course, there's an increasing trend also in publication here. And for me, a game changer and a landmark study is really the PREDICT study. Well, you may say, well, the practical consequences of the PREDICT study are currently not so high, but I think it will become important. You know, we all dealt for many decades with patients coming to our ward with a decompensation. But now we have a concept. Of course, there's a decompensational event, patient entering the ward, but now we know there are 3 different trajectories, and these 3 different trajectories are associated with a major difference in outcome. This means mortality. And it could well be that with the help of AI also, we will be able in the future to better understand what will the trajectory be, and then to go for specific, more preventive treatment in order to improve survival. And the second landmark, way of thinking about cirrhosis and decompensation and ACLF is the systemic inflammation hypothesis. In the former years, the progression of cirrhosis was mainly driven by our view of a portal hypertensive disease. But you can see it in a similar way as a disease with tissue inflammation, systemic inflammation, immune paresis, recurrent bacterial infections, and leading to organ dysfunction. And this again gives you a different hint also towards treatment approaches, and it's no surprise that now with toll-like receptor inhibitors being studied, or removal of these danger and pathogen-associated molecular patterns with different dialysis or plasmapheresis system may become important. And I also would like to add that the millions of drugs, well, the many drugs that are evaluated in non-alcoholic fatty liver disease, addressing important parts that are associated with fibrogenesis, also leaky gut and so on, they could become important also for patients with cirrhosis. A brief mention of the role of hepatologists. I have learned here that in India the situation is different, but in many countries there's a kind of a concern that there might be a kind of a worst case scenario that the hepatologist is only a consultant, and that major tasks in hepatology will be managed by others, like liver failure by anesthesiologists on the ACU, the ACC, CCA by oncologists, bleeding by gastroenterologists, TIPS by radiologists, fatty liver disease by GPs, cardiologists, endocrinologists, and so on and so on. So I think it's important for the future, and hepatology societies can become an important pulse generator here, that hepatologists are actively involved in all these tasks. They have the skills that we train them in hepatobiliary oncology, in intensive care unit of these patients, in these testing with TIPS, HVPG, hepatobiliary endoscopy, having an idea about imaging techniques. And when it comes to the big data, with a completely new model, that trends now can be directly learned from the data itself, I think we have to come to a new way of also working together, because now it becomes even more important that we have a collaborative network with sharing samples, data, and methods. And building bridges to less traditional collaborating specialties such as engineering, computer science, and industry will be crucial for the future. And our vision of the future of clinical role of hepatologists in interdisciplinary patient care is depicted here, and you can read it again in the I need just a minute more, no concern. In the editorial, that we feel that the hepatologist rule is rooted in interdisciplinarity, patient centricity, and also the global and national hepatology societies. And there are several futures where great opportunities for hepatologists in clinical and basic science, building bridges here to understand AI and precision medicine, to have a new mindset of working together with data sharing, a multidisciplinary management, the liver care training, as I mentioned, with skills, and especially with computational science and systems medicine. And I think really we have perhaps also for the undergraduate education have to think about to get out of our silos that we only teach liver disease, but more in a holistic approach and understand all the concept of inter-organ crosstalk and have a closer relationship also to policy and public health, that what we are doing will also become operational in a broader scale. I come to an end, and just a couple of words to the role of medical societies. And here's the subheading of the Future of Hepatology editorial. And this is, according to the words of Abraham Lincoln, the best way to predict the future is to create it. And I think this is what we have to do. We started with the EASL Lancet Commission with the aim of protecting next generation of Europeans against liver disease complication and premature mortality, with the idea of this holistic approach, if you also look at fatty liver, that the liver is a window to the 21st century health of the European working population, and that we should come to a management change and a transformative change, that we go more towards prevention, screening, early diagnosis, early therapy, instead of treating the complication. Sorry. And I think we already started together. So who will be the guarantor for a promised future of hepatology? I think these are the INASLs. We are all together here, and I really would like to thank you all. It was a wonderful evening also yesterday. Thanks for the invitation, and thank you very much for your attention.
Thank you, Professor, for the excellent talk. Look into the future. I think only one question I have, with artificial intelligence taking a lot of, but I'm a little scared about this unsupervised, independent logic of the artificial intelligence, a logic which we have no clue about. Is that dangerous?
I do think so, and this is what I tried to mention, and therefore we have to train also ourselves. You know, we are the reviewers of these papers, and if we do not understand the methodology, you know, we might be impressed by what's going on there, but it might be in the end not, you know, a lot of biases and so on. And we also learn statistics, right? And we can deal now basically with these programs. And also for these artificial intelligence, there are programs, and you can train, you can send your fellows to these to get a basic understanding, and you can even work a bit with these models, and then you get a sense for it. Yes, I think it's very important, and there is certainly a risk about it. And this is what I meant, that we need really proper evaluation, and you have to build teams also with people you know, you trust, that can tell you what's going on here and on what basis they created these models. Yeah.
Sir, what is the future of hospitalization versus non-hospitalized management for cirrhotics? Because as we go, it is likely that cirrhosis will increase very progressively, more like geometrical proportions. Do you think hospitals and intensive care is the only remedy, or do you think that other forms of therapy at domiciliary level will take up?
Yeah, well, I think really if a patient has a serious complication and of course he feels ill, so we will treat him most likely on the ward, or we have kind of daycare facilities where a patient can be treated for shorter time, but in a bed. But I think what will come, and again, with the help of these AI devices, you know, whether it's with a watch or so, that we can in a way monitor what's going on in a better way. You know, there are already models out that can be already now used, where you can see whether you get jaundice by just taking a photo of your eyes and all this information, you know, and if you have perhaps an increase in your heart rate, this can tell you that there's a bacterial infection in the patient with cirrhosis, something like this. I think this is very likely to come, that we have in a way a more closer monitoring of our patients.
Thank you very much, Professor Thomas Berg, and for this excellent overview of the future of hepatology.
Thank you very much.
And we now begin with session 3, Young Investigator session. Chairperson and the judge of the same are Dr. Ajay Kumar, Chairman, Gastroenterology and Hepatology, BLK Institute of Digestive and Liver Diseases, Dr. Govind Makharia, Professor, AIIMS, New Delhi, Dr. Manas Kumar Panigrahi, Associate Professor, AIIMS, Bhubaneswar, Dr. Premashish Kar, Senior Director and HOD, Max Super Speciality Hospital, Vaishali.
Good morning, everybody. So we have 5 papers for this Young Investigators oral session, and instructions to the presenters: please stick to your time. If you step over your time, you will be automatically disqualified. It will be 9 minutes for the presentation and 3 minutes for discussion on the paper. With that, I invite the first presenter, Dr. Bilal Ahmed Mir. The study on prospective, randomized, comparative forearm intervention study of efficacy and safety of saroglitazole and vitamin E in patients with NASH swing trial.
Good morning to everybody. I'm Dr. Bilal from IGMC Shimla. And at the outset, I would like to thank you, INASL, for giving me this opportunity to talk on this platform. Let me straight go to the topic of my, the title of my study is a prospective randomized comparative forearm intervention study with efficacy and safety of saroglitazole and vitamin E in patients with NAFLD. So a brief introduction. NAFLD, as you all have learned here, it should be regarded as a systemic process because it should not be restricted to liver only. It has a different metabolic drivers which actually perpetuate this disease. It has a different phenotypic spectrum which involves from NAFL to NASH to cirrhosis to HCC. The pathophysiology basically lies on the insulin resistance, which is the main perpetuator of the disease. But there are recent insights which suggest that chronic low-grade inflammation and oxidative stress plays a role. They cause imbalance in the metabolic hemostasis and insulin resistance. NASH, you know, is a histological diagnosis, but histology being invasive, we have non-invasive assessment like transient elastography, which reliably diagnose the steatohepatitis and fibrosis. The cornerstone of treatment is lifestyle interventions in the form of diet modifications, exercise, and weight loss. The major limitation with lifestyle interventions is inability to sustain this behavior, which is very difficult for most of the patients. So If you see the background of the study, vitamin E is widely prescribed for non-diabetic NASH. It has studies to back up, and saroglitazar, being a novel dual PP alpha gamma agonist, is approved in India for the NAFLD. So with this thing in the mind, we thought that there is no head-to-head comparative study of vitamin E and saroglitazar. There is scarce data on the saroglitazar plus vitamin E combination, and the non-invasive assessment has not been studied too much in this regard. So we hypothesized that the combination of vitamin E and saroglitazar is better than the individual drug alone when compared to the control group. So this is the profile of my study. It was carried out in the IGMC Shimla. It was a prospective interventional open label trial with randomized allocation. The assignment was parallel. Primary purpose was treatment and duration was over a period of 1 year. The trial acronym is SWIN trial, and it was registered in the CTRI. So the primary outcome measures were the improvement in hepatic steatosis, the improvement in liver stiffness, and the improvement in the liver enzymes, especially ALT. And the secondary outcomes were glycemic parameters and lipidomic parameters. So if we see, these were my inclusions and exclusion. We involved the patients with age more than 18 of either sex and NAFLD to diagnose on the basis of ASLD criteria using ultrasound. We excluded patients with chronic diseases. We excluded patients who had on the drugs which cause the steatosis. We excluded patients who had recent surgery or on TPN, pregnant females, lactating mothers. Yes, this is important. We excluded patients who were recently diagnosed with diabetes or they have a recent change in the medication of diabetes or dyslipidemia. We exclude patients with the LSM of more than 13 and patients who did not consent. So this is the methodology. At baseline, we did anthropometry, weight, height, calculated BMI, blood work, different parameters. We did ultrasound, abdomen, fibroscan, and we started the patient on intervention and follow-up after 6 months. We repeated the same parameters. We used the fibroscan EcoSense Touch 502 Paris, France model. Both M and XL probes were used depending upon the BMI of the patients and the manufacturer requirement. We took the valid measurements as I already discussed in this forum. Less than 30% of IQR were considered as valid. So the enrollment was done from December 2021 to July 2022. Patients were treated and followed for 24 weeks, randomized into 4 arms, and 3 arms received the drug, vitamin E, saroglitazar alone and in combination, along with the lifestyle interventions, and 4th arm received lifestyle interventions only. So this is the consort of the study. We screened 500, eligible by 275, and we randomized 175 patients. And subsequently, we subsequently divided the patient into different arms and started the treatment. And luckily, there was one important thing in the study, that we didn't lose any of the patients on follow-up. So these are the baseline characteristics of the study. The mean age, if you say, was 46 years, and the majority were in the 5th and 6th decade of life across all study cohorts. Males outnumbered females across all study cohorts, and almost over 2/3 of population were males. 2/3 of the patients across all arms and overall were obese. If you see the comorbidity distribution, particularly with regard to the diabetes was slightly more in the saroglitazar arm. Overall, 14%, means 25 out of 175 were diabetic patients. So if you go with the lipid parameters, they are distributed in the different arms. If you see, the dyslipidemia was seen in more than 90% of all the limbs, and overall also, and most common component of metabolic syndrome. And hypertriglyceridemia was the most common dyslipidemia which was found in these patients. If we go with the glycemic parameters, you see the pre-diabetics and significant insulin resistance almost equally distributed, and overall 47% of patients who were pre-diabetics and 45 had a significant insulin resistance. So CAP and LSM revealed that 2/3 had severe steatosis and 20% had significant and advanced fibrosis. So primary outcome, if you see, there was a saroglitazar arm significantly improved CAP and ALT. Vitamin E improved only ALT levels, and combination therapy improved all the 3 primary endpoints.
You are exceeding time.
So subgroup analysis revealed that CAP more than 29 and advanced fibrosis more than 80, the combination therapy was better and significantly improved advanced fibrosis and severe steatosis, which is a prognostic indicator. Cyroglids significantly decreased TG levels and LDL levels, and the combination therapy decreased LDL and increased HDL levels. So it was better. So on glycemic secondary outcome parameters, cyroglids significantly improved HbA1c levels. Combination therapy improved HbA1c, HUMA-IR, and there was a trend towards reduction in HbA1c with vitamin E, but not statistically significant. So on further subgroup analysis, nothing was significant regarding pre-diabetes and significant HUMA-IR between the arms. So to summarize, saroglitazar significantly improved HbA1c, TG, LDL combination, improved HbA1c, HUMA-IR, and LDL and HDL-C. So the limitations of my study, we accept our limitations, the lack of histological assessment, single center, single ethnicity, lack of data on calorie intake and physical activity, the lack of long-term follow-up. So again, the combination therapy improved all primary outcome measures. Secondary outcome measures were improved by saroglitazar and combination limb. The only combination therapy improved the significant fibrosis and severe steatosis. Adverse events were comparable except body aches, which were more in the saroglitazar arm. We need a bigger multi-center, multi-ethnic study to validate these results and to extrapolate this data to larger population. Thank you.
This paper is open for discussion. Dr. Duseja.
I think congratulations. I think very nice work. Just 2 or 3 queries. One is what was the mean LSM? You did say what percentage had advanced fibrosis, but what was the mean LSM in general? That's number one. What was the mean BMI? But more important question is, lifestyle interventions were given to all the groups.
Yes, sir.
So we know that lifestyle interventions work in fatty liver and they were all non-cirrhotics. So what was the reduction in their body weight in each arm, and was it different between the groups, say combination versus the others, right?
The first question, if we see the mean LSM was 7.2 in these patients and mean BMI was 26.4. And regarding the lifestyle interventions, yes, we had one thing, there was weight reduction in all the limbs, but it was slightly more in the control arm, because probably those patients would take it more seriously that this is the only treatment we have. So there was, but it was not statistically significant. And after doing the regression analysis, on multivariate analysis, we just removed those confounding factors, and despite of that, it came significant with the combination arm.
Did you analyze the different result, patients with the high triglycerides or with the normal triglycerides? How did they respond in the different groups? Did you compare that?
Yes. We compared the different arms regarding the triglycerides, and saroglitazar was doing better, statistically significant, and combination was also doing better. But otherwise, vitamin D did not have any significant results.
Any quick question? Well, thank you very much.
Thank you, sir. Thank you.
Now it's my pleasure to invite Dr. Aditya Burma to present his paper entitled Tumor Elastography and Novel Predictors of Tumor Response to Transarterial Chemoembolization in HCC.
Thank you all the honorable judges, teachers, and my dear friends. At the outset, I would like to thank INASL for bestowing me this opportunity to present my research work. My topic for today's presentation is tumor elastography, a novel predictor for tumor response to TACE in HCC. So as we all know, HCC is the main line of treatment for intermediate stage HCC. It's the first line that is used for BCLC-B subtype B. It can also be used for BCLC-0, A, and stage B1 if other treatment modalities are not feasible. The basic principle of using TACE is that 95% of tumor is supplied by the hepatic artery. So when we embolize it, it induces tumor necrosis with little damage to the background liver. And the response to TACE is assessed using MRECIST criteria, which is broadly divided into 4, and it's a complete response, partial response, stable disease, and progressive disease. So elastographic characteristics have demonstrated to correlate the histology and the vascularity of HCC. In recent past, few studies have demonstrated that higher stiffness using AFRI and MR elastography was associated with poor response to TACE. 2D shear wave elastography was associated with good accuracy and positive predictive value in measuring liver fibrosis. And also 2D shear wave elastography has been found to determine elastographic characteristics of HCC and also differentiate it from the other hepatic focal lesions. So the aim was to determine whether 2D shear wave elastographic characteristics of HCC is associated with tumor response to TACE and to study the factors associated with post-stage decompensation at 3 months. So it was a prospective observational study conducted in Department of Medical Gastroenterology, Government Medical College Trivandrum. 54 patients diagnosed at CC and undergoing TASE as per standard recommendations were included. TASE was performed by a single experienced interventional radiologist, and patients were assessed at 3 months for post-stage decompensation, the decompensating events being ascites, hepatic encephalopathy, upper GI bleed, and worsening of child status. 2D shear elastography of tumor was measured, and of the background liver parenchyma 2 centimeter away from the tumor. And then we reassessed the shear wave of the focal lesion 48 hours after TASE. At 6 weeks, tumor response was assessed using the MRSS criteria, and the tumor response was broadly divided into two. Objective response, which includes complete and partial response, and no response, which includes stable disease and progressive disease. So 3 patients had to be excluded, 54 patients included. Total 30 had objective response and 24 no response. 20 had complete response, 10 partial response, and 9 stable disease, and progressive disease 15. So these are the baseline characteristics. Mean age was 59. Maximum patients we had in the HAP B subgroup 37. HAP A had 6, and there were no patient HAP D. 52 of the patients had a state score of more than 18. Maximum patients in LB grade 2. BCLC A had 40 patients, B had 14 patients, no patient BCLC C. The mean MELD was 11.8. So we found that the tumor elastography was not associated with the size of the tumor, the etiology of the underlying disease, tumor burden score, and AFP. The tumor burden score was calculated by putting a square of the maximum size of the tumor plus the square of total number of tumor, and then we square rooted the product. Then we found that the shear wave elastography of the tumor was lowest in patients who had a complete response. It progressively increased, and the maximum was seen in patients with progressive disease. And shear wave of liver was not associated with response to TASE. And delta shear wave, the increase in the TASE, shear wave 48 hours after TASE was seen the highest in patients who had a complete response, and least in patients with progressive disease. So these are the univariate analysis, and we compare responders versus non-responders. We calculate all basic parameters and the tumor characteristics. So to summarize, scores of liver function such as child score and MELD were not associated with tumor response. Scores used for classification of HCC like state, BCLC, and HAP score were also not associated with tumor response. The tumor burden score was significantly higher in patient with no tumor response. Patient with objective response had a slightly lower tumor size. However, the number of tumors were not associated with tumor response. AFP levels were lower in patient who had objective response. As seen previously, shear wave of tumor and delta shear wave was significantly higher, was associated with tumor response. We found the ratio of shear wave of tumor to the liver parenchyma less than 1. That is, in patients who had a shear wave of tumor lesser than the surrounding liver parenchyma, they had a much better response. The patients who were on chemotherapy alongside TASE did not have a significant better response. So shear wave of focal lesion less than 26 predicted tumor response with a sensitivity of 95.2, specificity of 79.1, and a delta shear wave of more than 20 predicted tumor response with a sensitivity of 83.3, specificity of 66.7. When we did a multivariate analysis, we found AFP and shear wave to be of the focal lesion to be independent predictors of tumor response. Both these parameters had a negative beta coefficient, means the lower values of these parameters was associated with tumor response. Then we assessed for decompensation. 18 of the 54 patients had decompensation at 3 months. Tumor response to TASE was not associated with decompensation post-TASE, either by the objective response criteria or by the MRSS response criteria. We again did a univariate analysis of various parameters for predicting post-TASE decompensation. So we found that patients who had a decompensation post-TASE had a higher liver shear wave value. Also, they had a higher tumor shear wave, but this was not statistically significant, with a p-value of 0.06. Decompensated patient had lower serum albumin and a higher tumor burden score. Tumor size and AFP was not associated with decompensation. Scores like state score and LB were predictor of decompensation post-TASE. However, other scores like HAP and BCLC did not predict tumor response. So did not predict post-TASE decompensation. Also, the addition of chemotherapy did not improve post-TASE decompensation. So we found that the liver shear wave elastography of more than 31.3 kilopascals predicted post-TASE decompensation with a sensitivity of 94.1 and specificity of 66.7. On multivariate analysis, we found shear wave of liver and the total tumor burden score to be independent predictors of post-stage decompensation, both having a positive beta coefficient, meaning higher values associated with post-stage decompensation. So, to our knowledge, this was the first study that assessed 2D shear wave response to the of tumor to TACE. Gorlick and colleagues showed that using MR elastography, pre-treatment tumor stiffness was associated with a poor response. Michael and colleague found that as early as 3 days after the treatment, stiffness of responding HCC was significantly higher, and also addition of chemotherapy did not improve tumor response, which was similar finding to Joy, Varghese and group. We found no association with tumor stiffness to the size of tumor. Similar findings were noted by Thompson and group, and shear wave of tumor was independent and did not correlate with AFP and tumor burden score. These findings could be explained as higher stiffness of tumor associated with poor degree of differentiation. Also, patient who had a higher tumor elasticity is associated with very high vascularity, hence poor response to TACE. Jin Wong and group found that using MR elastography, poorly differentiated tumors had a higher stiffness. And the work of Ling and colleagues showed that patients who had a higher stiffness, tumor with higher stiffness were more hypervascular and poorly differentiated lesions. Joel Silva found that higher tumor burden and lower albumin were associated with post-TACE decompensation. Liver stiffness by 2D shear wave elastography. This was a novel finding, and we couldn't find any other studies using this as a predictor for post-TACE decompensation. So to conclude, baseline tumor shear wave elastography and AFP levels are associated with tumor response, and tumor shear wave of less than 26 can predict tumor response in HCC with an accuracy of 90.74%. And also we can use liver elastography and tumor burden for predicting post-TACE decompensation. This was the limitations. Obviously, we have some limitations. This was single center study, and due to the COVID pandemic, the sample size were restricted. We would want to multi-center and larger sample size for validating the study. Also, our institution did not provide depth TACE. Hence, we would like to validate the study in depth TACE. Just a quick dip into the future perspectives. We all know all HCCs are not alike, and currently we don't use biopsy as a routine. So 2D shear wave can be a non-invasive marker that correlates with the histological activity and a response to locoregional therapy. 2D shear wave of tumor for predicting post-stage adverse events and decompensation must be studied. And we also all know hepatology is full of scoring systems. However, current scoring systems do not predict a response to TACE, and hence new predictors need to be studied and standardized. Thank you for your kind attention. I would like to thank the teachers at my college, Medical College Trivandrum, for their constant support and help. Thank you so much.
Thank you. The paper is open for discussion. Dr. Duseja.
Nice work, Aditya. The only issue is if I can see your inclusions and the patient characteristics, 75% of your patients were BCLC-A.
Yes, sir.
So typically for BCLC-A, we don't do TACE.
Yes, sir.
You know, TACE is done for BCLC-B, right? Or sometimes in C. In A, you would do it only in exceptional circumstances where, you know, look, because of the location and certain things, you know, you're not able to ablate them or something, right? So why did you choose to do TACE in 75% of your, who are BCLC-A?
So all these patients on BCLC-A were actually in a waiting list for transplant, and in these patients the tumor size and the location was not feasible for doing an RFA. So they are listed for LT, but meanwhile to provide them a downsstaging or a therapy, we provided them TACE. And regarding BCLC-B, we considered many patients with BCLC-B. However, because of poor HAP score status and child status of more than 8, we couldn't enroll most of them for TACE.
Thank you, Dr. Aditya. Excellent, that is thing.
Thank you, sir.
Well, two things I'll ask. One is all the patient that is enrolled, these are all decompensated liver disease. But there is no, liver TACE that was used only decompensated. So what is I'm saying that stiffness about the disease, that is the hepatocellular carcinoma, area of hepatocellular carcinoma and the surrounding stiffness. And the normal tissue, there are three things will come. If it will be correlated with a normal tissue with diseased tissue and the cirrhotic liver, So it will be better correlated than that surrounding tissue. What I mean to say, if you correlate the stiffness with the disease liver with the stiffness with the carcinoma, the non-responder I am taking, and the carcinoma that is a non-responder with a normal tissue. What is your idea that? And
Normal tissue mean non-cirrhotic, sir?
Stiffness.
Non-cirrhotic.
Yeah.
So,
Is
sir,
there
there
any
are, to answer your question, sir, there have been studies which show that the tumor elastography associates is useful for differentiating benign and malignant focal lesions of liver. So, benign usually have a lesser shear wave, malignant focal lesions have a higher shear wave. And also, there have been studies where they have compared tumor elastography with the background liver elastography.
Which is normal.
Background, no, cirrhotic, sir, cirrhotic. This is exclusive cirrhotic patients that I've taken.
Excuse me, in interest of time, can we stop here? You might discuss with him right away.
Anything about that endoscopic ultrasound using the stiffness?
We don't have that, I don't have any idea, but we don't have the modality at our institution, sir.
Thank you so much, Agalite, wonderful paper.
So next presentation is Sonu Kumar, tumor suppressor gene promoter methylation as liquid biopsy biomarker to differentiate hepatitis B virus induced SCC from chronic liver disease.
Good morning, everyone. First of all, I would like to thank to INASL for providing me this opportunity. Today, I am going to speak about tumor suppressor gene promoter methylation as liquid biopsy biomarker to differentiate Hep B virus-induced hepatocellular carcinoma from chronic liver disease patients. So, a little bit introduction. Liver cancer is the 7th most common form of cancer and 2nd leading cause of cancer-related mortality worldwide. As per recent reports, by 2025, more than 1 million people will be affected by liver cancer. And by the year of 2040, 1.4 million people will be diagnosed with liver cancer annually. 5-year survival rate of SCC patient is only 18%, and males are more affected than females. The major risk factor for Hep C, hepatocellular carcinoma is Hep B and Hep C viral infection, chronic alcohol abuse, and nowadays NASH-related SCC are coming more. So for early detection of this SCC, there are a lot of biomarkers are available, and majority of those biomarkers are in 3 categories. There are tumor proteins, there are microRNA markers which are subject of debate in labs, and immune markers. And apart from all these markers, most of them are in development phase. AFP is the only available marker that is in routine practice in clinics, but the major drawback is that sensitivity and specificity of AFP is low, and about 40% of SCC patient don't show this AFP elevation. So there is a need of exploration of more biomarker for early detection of SCC. So as we know that epigenetic changes in DNA are responsible for the various events in hepatocarcinogenesis, and there is a plethora of studies that methylation pattern in DNA of this SCC patient can be a useful biomarker in early detection of hepatocellular carcinoma. So here we are interested in the estimation of this methylation pattern in cell-free DNA. Why we are interested in cell-free DNA? Because it's non-invasive nature and it can be reproduced again and again. So a little bit about liquid biopsy. So liquid biopsy is a form of test done on blood sample to look for cancer cells from a tumor that are circulating in the blood, or pieces of DNA from the tumor cell that are circulating in the blood. That is called cell-free DNA or circulating tumor DNA. So liquid biopsy holds a great promise for early detection, prognosis, and prediction of response to various cancers and cancer treatments. And there are various factors of liquid biopsy. The one is cell-free DNA or circulating tumor DNA. Other is serum microRNA or exosomal microRNA, and circulating tumor cell. Here we will focus on this cell-free DNA aspect of liquid biopsy. So our group basically is interested to know the capability of the cell-free DNA, whether it can be proved as a early prediction biomarker for hepatocellular carcinoma in high-risk chronic liver disease subjects. So in cell-free DNA, we did this DNA integrate index study, and we published it into Frontier in Biosciences. Then we estimate somatic driver mutation in cell-free DNA of SCC subjects, and we published this also. Now here I will talk about the cell-free DNA methylation as early prediction marker in SCC. So what is DNA methylation? DNA methylation is simply addition of methyl group in 5' carbon of cytosine in DNA molecule, and it is an enzymatic reaction that is carried out by methyl transferases. The cytosine methylation mostly restricted to CpG sites, and the major function of this DNA methylation that it silence various genes, basically because this when there is this hypermethylation is there, this RNA pol will not work, and this activates the proto-oncogenes. So there are various methods of this DNA methylation in cancer cell. There it has been seen then hypermethylation in promoter region, and there is hypermethylation at CpG island shore, and there is hypomethylation in gene body of cancer cells, and in repetitive sequences like that ALU line 1, there is hypomethylation in cancer cells. So we will talk about the CpG island on promoters. So in previous studies, it has been told that in certain genes are hypermethylated in CHB-induced SCC liver tissues. These genes are APC, GSTP1, and CDH1. So what we did that from the literature we chose several tumor suppressor genes that are highly relevant to this SCC, and these genes are CDH1, RSSF1A, APC, HOXA9, GSTP1, P21, and P16, and these all are tumor suppressor genes, and they play key role in various cell signaling pathway that leads to hepatocarcinogenesis. So the aim of our study is to study the potential of tumor suppressor gene based methylation as an early biomarker to differentiate SCC from CHB patient. We did this CpG mapping, and we estimate. So we got ethical clearance for this study. And the patient, in liver tissues, we took 10 healthy tissue and 20 SCC tissue, and in serum samples we took 10 healthy, 40 CHB CLD, and 80 SCC. DNA, we extract DNA, and from 500 nanogram of DNA we did this bisulfite treatment, and BSP and MSP PCR was done, and then Sanger sequencing was done, and real time was done. So this is the mapping of this CpG island in various gene promoters, and these are the BSP and MSP primer that was done by Eurogene software. So in the analysis was done in tissue samples by delta CT method, and in serum sample by double delta CT method. These are the clinical details of the patients, and here we can see that most of the SCC patients they are AP producer. So in BSP PCR we did PCR, and then we did sequencing to know this to estimate this methylation pattern, and in 60% of patients we find methylation at particular promoters. So in tissue MSP PCR we find that except of except of RSSF1 gene, all other were methylated in SCC tissue, but there was no as such hypermethylation in SCC healthy tissue. So we did this comparative study, and we find that this methylation can in tissue can differentiate between SCC and healthy tissue, and the ROCs curve for the CDH1, APC, GSTP1, P16, and P21 significant among these genes. So in cell-free DNA, we find that we did double data CT analysis, and we find that there is significant differences. There was significant hypermethylation in CLD as well as SCC patient, and in when we did 4-group analysis, we find that there are significant differences in CDH1 gene that can differentiate among SCC and CLD, and in 3-group analysis, we find differences in P16, CDH1, and GSTP1 genes, and similar we can see that ROC curve can differentiate among CLD and SCC in this group, the methylation pattern. Similar the case in cell-free DNA, we can see that there are some significant differences in P16 genes, and in case of this double delta CT analysis, there was differences between P16 and CDH1 genes. And the ROC curve can also significantly differentiate between SCC versus CLD of these methylation pattern for the genes of this CDH1, GSTP1 and P16. So here are the conclusions. There is hypermethylation in gene promoter of tumor suppressor gene in tissue DNA as well as cell-free DNA of SCC subject. GSTP1, CDH1 and P16 genes are significantly hypermethylated in SCC, and there is the ROC curve can differentiate between the methylation pattern of this SCC as from CLD groups. Cell-free DNA methylation has the ability to be a potential biomarker for early detection of SCC in high risk of chronic liver disease subjects. So thanks. I would like to thank INASL 2023 for giving me this opportunity. I would like to thank Department of Gastroenterology for providing me adequate support. I would like to thank ICMR for providing me financial support, and thanks to my supervisor, Pope supervisor, and laments. Thank
Good study, Sonu. And what is healthy tissue here? From where you get healthy tissue?
Sir, basically, these healthy tissues these are disease controlled healthy tissue. They were operated from some other GI tract disease, and we took these liver tissue from the health there. There was no liver element in those patients. They were operated for other etiology like that, for other disease. So we took it from
you have excluded that fatty liver, any liver disease in that. Yeah.
Yeah. Yes, sir.
So, any question from the?
Yeah. Hi. Nice study, Dr. Sonu Kumar. Just one, sorry, I could not. There was no time to go through the clinical details. But how many were BCLC A, B, and how many were C? So, like, how many were metastatic disease or with portal vein thrombosis, and how many were limited to the liver?
1 second. There was BCLC A patient were 17, B were 24, and C were 29.
So was there any difference you found in the?
Yeah, we did analysis. Basically, we did this methylation status analysis in A plus B in early SCC plus C plus D in advanced SCC. So unlikely we didn't find any significant difference between the methylation status of those patients. Maybe the probable reason may be that when we did this stage-wise analysis, the number came very down. So if we will go with more number of patients, that there will be certain differences.
Thank you.
Yeah.
Just 2-3 issues. One is within the CHB, which was your disease control, did you have any cirrhotics there? They were all non-cirrhotic, number one. Secondly, again within the HCC group, we know that in hepatitis B, HCC can occur even without cirrhosis also. So were they again all cirrhotics, or did you have a non-cirrhotic group within the HCC also? And what was the difference in the markers which you studied between the cirrhotic versus non-cirrhotic disease group as well as the HCC group? That is number one. The secondly, did you also look at the correlation of this methylation, because you have taken a tissue from the HCC and you have a liquid biopsy? So what was the correlation between the tissue biopsy and the liquid biopsy in the methylation? And finally, what do you think could be the clinical relevance for this?
So answering to your first question, in CHB group there were both cirrhotics and non-cirrhotics were there, and we did analysis. I showed that in 4-group analysis there was healthy CHB cirrhotics, CHB non-cirrhotics, and SCC. And in SCC as well, 90% of our patients were cirrhotic in nature, and only 10% were non-cirrhotics. But in SCC we did not did any analysis between this SCC cirrhotics and SCC non-cirrhotics. And here in CHB group there was differences between cirrhotics and non-cirrhotics. In cirrhotics, the hypermethylation was more. And this second question, that is there a correlation between this tissue DNA or cell-free DNA? Yeah, definitely. We started with tissue DNA, and we find that there are hypermethylation in tissue DNA. So we want to know that whether we are getting in that cell-free DNA or not. For these 3 genes, CD, H1, P16, and GSTP1, we find the same pattern, the hypermethylation in these disease patients.
Excellent study, Dr. Sonu. You can take this to
think,
the next
I think
level.
we should stop the discussion here. Time is up. Please.
Just
You
one
can talk
question.
to the
Can you, did you correlate with the AFP level? From AIMS itself, there's a data that in India only 50% people have AFP elevation.
Dr. Sonu, you can answer it down there, please.
Okay.
We can't skip over the other people's time.
Thank
Phenotypes in end-stage liver disease and their association with one-year post-transplant mortality. Can I invite Hiteshi Dhami Shah to present the paper?
Yes, sir. Yes, sir. I'm here.
Hiteshi Dhami Shah.
Sir, I'm here.
Yeah.
Good morning, everyone. I would like to thank INASL for giving me the opportunity to present our study titled Identification of High-Risk Sarcopenic Phenotypes in End-Stage Liver Disease and Their Association with One-Year Post-Transplant Mortality. Liver transplant offers hopes to patients with end-stage liver disease. However, challenges such as organ rejection, infection, and CVD persist in the post-transplant period. One of the challenges is sarcopenia, which has been known to be a risk factor of mortality in end-stage liver disease, which is characterized by loss in muscle mass and strength. Radiometric measures for sarcopenia uses indices which will measure the muscle area, transverse thickness, and muscle density. And in our study, we have used the psoas muscle, which is a core muscle which reflects the status of the skeletal muscle of the whole body. An axial CT scan image was used to measure the psoas muscle mass, density, and thickness at the third lumbar vertebrae. As you can see that the red area marks the psoas muscle area, which is normalized by height in meters square to get the PMAI. Similarly, the transverse psoas muscle thickness was measured as seen in the yellow arrow, normalized by height in meters to get the transverse psoas muscle thickness index. And the blue circle marks the psoas muscle density, which is the maximum portion in the psoas muscle, which was estimated in Hounsfield units and normalized by weight in kilograms to get the PMDI. Also keep note that both the right and the left side of the psoas muscle was taken and the average of what was taken for all the parameters. PMDI also marks for myosteatosis, and more fat a muscle contains, lesser dense it becomes, leading to poor muscle quality. And a low PMDI is also representation of the muscle fat infiltration. Since end-stage liver disease is heterogeneous in terms of etiology, and in our study, we found that each of the patient has a different phenotype presentation. In our study, we have used age, body mass index, MEL, Child-Pugh score, PMAI, TPMTI, and PMDI, characterized using a mathematical clustering approach and evaluated for one-year mortality post-transplantation. So the study design was that around 229 patients who had undergone liver transplant at global hospitals from 2014 to 2021 were screened, and all the patients below 18 years of age who had acute liver failure were excluded, and a final of 86 samples were included. Also, the CT scans which were used for evaluation of the muscle mass and density were not more than 3 months prior to the transplant. The data set was normalized by Z-score so that you can ensure comparability. The phenotypes were grouped using the k-mean clustering method, and heat maps were developed to visualize the clusters and the phenotypes. And then the mortality was evaluated across these clusters to identify the high-risk population. So here you're looking at the baseline characteristics of these 86 patients, where 84.8% were males, 15% were females, 38.3% were having type 2 diabetes, 19% were having hypertension, 33.7% were having NASH. Also, the 1-year post-transplant survival rate was 80% in these patients. Using the k-mean clustering method, 5 distinct clusters were identified, and the 0 in the bar graph represents the baseline values. The bar above 0 includes values in clusters above the baseline, and the bar below 0 includes values in clusters below the baseline. And you can clearly see that each of the cluster is showing a different phenotypic profile. For example, cluster 1 is showing a baseline age, high PMAI, low PMDI, high TPMTI, baseline CTP, baseline MELT, and high BMI. What I would like you to focus is on the PMDI and MELT across these clusters, as it has shown to correlate with mortality in our study. So here is a heat map which is giving you a visual understanding of the characteristics of the patients across these clusters. And it is clearly evident that the phenotype of cluster 1 is different than that of cluster 3, 4, and 5. What we found is that the cluster 1 showed a mortality of nearly 41.7%, whereas cluster 3 to 5, the mortality ranged from 15.8 to 17.9%, and the best outcomes were seen in cluster 2 with a 0% mortality. So as you look at these slides very closely, you can see the phenotypes of the cluster 2 having the best outcomes with a high PMDI, a lower MELD, and a younger age. On the other hand, cluster 1 had the worst case situation with a low PMDI, a baseline MELD, and a baseline age. So a low PMDI also suggests myosteatosis and also represents a high-risk phenotypic profile contributing to mortality. Cluster 3 to 5, on the other hand, had phenotypic representations in between. So when you look at cluster 3, it had baseline PMDR and also had a younger population, but here the high MELD contributed to mortality. Cluster 4, on the other hand, had high PMDI, but your age influenced mortality. And cluster 5 had low PMDI like cluster 1, but here it was the contributor for the mortality. Thus, using a mathematical clustering approach, we were able to characterize the phenotypes and also assess its impact on outcomes in this heterogeneous group of patients. And we found that low PMDI is an independent risk factor of mortality. And in conjunction with a high MELD, it increases the mortality risk exponentially. The future scope lies in studying this in a larger cohort, which will strengthen the predictive value of these phenotypic clusters in assessing the mortality risk post-transplant. It would be also worthwhile to look at the muscle cellular mechanisms or even the biological mechanisms that will link the phenotypic clusters to sarcopenia and mortality. This in turn could also help identify therapeutic targets, and intervention studies can also be planned. It would be also good if we could include frailty as an assessment in the phenotypic clustering method in assessing mortality, taking use of advanced imaging modalities, which will give deeper insights into the muscle density, and along with machine learning algorithms can also create predictive models which will again identify the high risk patients, and this in turn will help in risk stratification and also creating personalized treatment plans. I would like to thank all the authors for their contribution and guidance in the study, and I would like to thank the liver care team at Global Hospitals for their support. Thank you, sir.
So any question? Thank you, Hiteshi, wonderful paper. Any question? Before any question comes, let me ask, you had 60, 70 patients. What was your 1 year mortality overall?
Sorry.
What was 1 year mortality post-transplant overall?
What was the total mortality rate? It was 20%.
1 year transplant free?
1 year transplant, yes, sir. The percentage, yeah, 20%.
Right.
Yeah, I can show you.
So is that
Yes,
too high?
17.
Is 20% mortality at 1 year post-transplant? Is that not high?
I can answer that. Yes, this was a sick group of patients, but I think most importantly, what Hiteshi was trying to see was that in this group of patients, which are the ones which having sarcopenia, you have a sort of cohort which by clustering we can find out have the sickest and the highest mortality versus a zero mortality even in this sick group of patients. So that was the thing which we brought out.
One group I have, what C has shown, PMDI is more and mortality is also more in that group. Cluster 2, I suppose.
No, wait, sir. So cluster 2 has 0% mortality. It's high PMDI, so there is no fat infiltration in the muscle. So the low PMDI is a marker for myosteatosis.
0%.
It is 0%. There are no
0%.
patients who died, yeah. That's high PMDI, good muscle density.
Nice work, Hiteshi. Where did, in all this analysis, where did the etiology of the liver disease fit in? You had maximum NASH, then alcohol and virus. So did it affect your sarcopenia, the etiology I'm saying, and the myosteatosis and ultimately the clinical outcome? Did etiology had any impact on this?
So at the end, sir, this was a cluster study. So everything was normalized to a Z score. So then it wouldn't matter because it was a non-biased approach. And at the end, the cluster would give that thing. So it's...
Sorry, which software did you use for this calculation? And
Sorry?
which software did you use for the calculation of this?
SPSS.
Does the
And it is the method. So this is a statistical method. The k-means clustering method is a statistical.
No, I mean for calculation of the source index.
Okay, so this was a radiological measurement which was done.
How did you
So
measure? Because
it was by a single technician which was done for all the measurements, who had done it manually.
So it was done manually, right?
Yes.
So how did you excluded the fat content in the muscle? Because when you do it manually, you include fat as well as muscle mass in that.
So this is density estimation which was done. So for the mass, we have measured the area, and we have taken the transverse thickness also as one of the marker for mass. But for density, we have measured we have measured in Hounsfield units. So that's a density estimation. So the density, if it is lower, that means there is more fat infiltrated in the muscle, and which is visually also seen in the radiology images.
Is it the best method to measure fat? And
That's
muscle
you're
within-
right. So MR, that's where I had put up the future scope also in the study. If you see as advanced imaging modalities like MR, definitely it will give more accurate results, but it is not bad to start off with something like a CT scan where whatever is available to start off with that. So
I
yes.
think we've come to the end of the time, and thank you, Doctor.
Thank you, sir.
Wonderful presentation and a good discussion. With that, we go on to the last paper of this session, which is Dr. Prabir Maji on a splenic stiffness by 2D shear wave elastography and platelet count to predict varicose bleeding, varicose needing treatment and bleeding in extra EHPBO. Over to you, Doctor.
Good morning, respected chairperson, esteemed faculty and dignitaries, and my colleagues. I thank INASL organizing committee to give me the opportunity to present our study, splenic stiffness by 2D shear wave elastography and platelet count to predict varices needing treatment and bleeding in extrahepatic portal venous obstruction. We all are aware of EHPBO, which is a vascular disorder of the liver, resulting in obstruction and cavernomatous transformation of the extrahepatic part of portal vein. And in children, it is the commonest cause of upper GI bleeding and contributing 70% cases of portal hypertension in them. And in adults, it accounts for nearly 1/3 of cases of portal hypertension. Primary prophylaxis of varicose bleeding has been the main focus of management, considering the morbidity and mortality caused by it. In cirrhosis, guidelines have evolved from endoscopic surveillance for all patients in cirrhosis to, at present, only selective patients based on non-invasive marker of portal hypertension. The concept of clinically significant portal hypertension is primarily based on HBPG, which is invasive, and it's a gold standard. But non-invasive marker is sufficiently accurate in predicting varices and compensated advanced chronic liver disease and CSPH. Thus, Bhubaneswar 7 has recommended screening for endoscopic varices in CLD patients when LSM values increase by more than 20 kilopascal, or platelet count goes down below 1.5 lakhs. Bhubaneswar 7 further extended its recommendation to include SSM value to rule out or rule in CSPH in CLD patients, and also recommended a SSM value of less than 40 kilopascal to identify those at low probability of high risk varices to avoid endoscopy. But at present, we do not have any guideline to recommend non-invasive parameters for endoscopic surveillance in EHPBO patients. There are few studies with ambiguous results in evaluating SSM as non-invasive predictors in EHPBO patients. So with the scant data on non-invasive parameters for variceal prediction in EHPBO, also we do not have any validated age-wise normal values of splenic stiffness available with us by 2D shear wave elastography. So with this background, we felt an unmet need to search for a suitable non-invasive marker for prediction of varices in EHPBO patients, just like in cirrhosis. So we hypothesized that SSM values in patients with EHPBO should correlate with the grades of esophageal varices and variceal bleeding, considering the fact that pathophysiology of portal hypertension in EHPBO is primarily prehepatic, and the criteria for platelet count in cirrhosis may not be applicable to EHPBO because the distinct mechanism of thrombocytopenia in non-cirrhotic portal hypertension. So with this, we conducted this study with the primary objective of to assess the role of platelet count and SSM in predicting varices needing treatment in patients with EHPBO. Two secondary objectives are to assess the role of platelet count and SSM in predicting bleeding in patients with EHPBO. Simultaneously, we also compare the LSM and SSM values in patients with EHPBO with respective normative values generated in healthy controls. So it was a cross-sectional observational study. Both children and adult with USG Doppler and or CT photography showing findings suggestive of EHPBO were included in the study. Isolated patients with isolated obstruction of splenic or superior mesenteric vein, associated hepatitis B, C infection, HIV infection, portal biliopathy, hepatotoxic drug exposure, splenectomy, previous shunt surgery, or previous endotherapy were excluded from the study. Varices needing treatment were defined on endoscopic presence of varices which are large with or without RCS or small grade 2 varices with RCS. Additionally, gastric varices with large gastric varices were and medium gastric varices with RCS were also considered as a VNT. Sample size of 73 was calculated based on the previous study by Madhusudan KS et al. From AIIMS New Delhi. So we screened total 96 EHPBO cases and subsequently 89 healthy matched control was also screened, and 21 cases and 17 controls are excluded due to various reasons to finally have 75 EHPBO cases and 72 controlled for analysis. In our EHPBO cohort of 75 patients, 27 cases were pediatric and similar proportion of control were there in control group. So based on endoscopic findings, we classified our BNT group, total 63 patients as needed BNT and 53 patients presented to us with bleeding, which constitute the bleeder group. So when we compare the baseline characteristics of EHPBO cases with controls, all the parameters are significantly different, and particularly LSM and SSM, AST, ALT, and everything was significantly different. Although the clinically significant liver dysfunction is not common in EHPBO patients, but we found a higher LSM and higher liver enzymes because of prolonged chronic hypoperfusion, probably due to hypertrophy complex as described previously. When we analyze the various strata of EHPBO cases, VNT versus no VNT or bleeder versus no bleeder, no significant differences noted in platelet or SSM and any other parameters. When we analyze the data in adults EHPBO and pediatric EHPBO separately, there was also no significant difference in any of the parameter, particularly in splenic stiffness or platelet count. And also 5 patients which constitute 6.5% cases of who require variceal treatment and 7.5% cases which require who presented with bleeding has a platelet count more than 1.5 lakhs, signifying that if you use the cutoff value of platelet count 1.5 lakhs, a significant proportion of EHPBO cases will be missed. So coming to the key findings of our study, both the SSM and platelet count are poor predictor for varices needing treatment. SSM and platelet count fail to differentiate variceal bleeding in cases of EHPBO. We also generated a normal value of SSM and splenic size in our control population, which were at par with the previous available data. I will have a very quick review of available data on EHPBO with SSM evaluation. And a study from ILBS has shown that their EHPBO bleeder group have a higher SSM value than non-bleeder group, but this was subsequently refuted by two different studies by Madhusudan KS et al. From AIIMS New Delhi, who concluded that the SSM is by 2DC or elastograph is not a good predictor of variceal grade, bleeding, or portal pressure. We have 3 pediatric studies available with us, with one study from JIPMAR, which shows similar result to our study, and one study from PGI Chandigarh, and one study from ILBS New Delhi. They showed that SSM is a good predictor of variceal in EHPBO patients, but these two studies primarily evaluated CLD patients, and their EHPBO subgroup has very minimum number of patients. So we have some limitation also in our study. The number is still small to call it as representative. We did not evaluate the invasive portal pressure or intrasplenic pressure to correlate our findings with our variceal grades. And also there might be inter-observer variation to classify BNT versus non-BNT. And thus we propose a large sample size of EHPBO cases with portal hemodynamic measurement would be more helpful to generate robust conclusive evidence. So I conclude both the SSM and platelet count are unreliable to predict BNT and variceal bleeding in EHPBO, unlike in cirrhotics. Hence, surveillance endoscopy may be necessary in every EHPBO cases in order to identify patients with the need of treatment until we have a better predictive marker. Thank you all.
Thank you, Dr. Praveen Mazi. It's a wonderful paper. I think we have any question from anyone in the audience? Ajay?
I think, again, nice paper, but then could your negative results be related to two things? One is, as you said, there's very sparse data. Most of the people, those who use SSM, will use the FibroScan 630 expert, and you have a special probe, with special frequency, and that's used for splenic stiffness. 2D, we don't have much data. So could that be the reason, number one? The second reason, which I think is, the one, splenic stiffness is coming up in a big way, it's very good, but then the only factor it gets affected is that if you have lots of spontaneous shunts, then the splenic stiffness gets affected. So did you look for the spontaneous shunts in your patient which could have affected your SSM here?
So to answer the first question, so most of the data that available on splenic stiffness in EHPBO and NCLD, they use transient elastography primarily, and some studies also evaluated point CRF elastography. Only one data available from AIMS New Delhi, that is by 2D CRF elastography. And the next question, it is our limitation of our study. We did not evaluate also the presence of shunts and also intrasplenic pressure or any invasive portal pressure. It is our limitation, but we are working in a limited resource set.
So, what is the timing of your measurement, endoscopy and your splenic stiffness measurement?
Endoscopy is those patients who presented with bleeding. Splenic stiffness measurement was conducted after 4 to 6 weeks of bleeding, and those who do not present with bleeding, we simultaneously evaluated SSM and endoscopies.
On the same day?
Same day, because the splenic stiffness was evaluated, both splenic and LSM liver stiffness was evaluated on a fasting status, that we same day evaluated both the parameters.
Okay. Thank you, Praveen. If no more questions,
thank you, sir.
Nice presentation.
I think we had 5 wonderful papers, and that shows that many studies done from peripheral medical colleges. That's one thing very, very reassuring, that we are likely to have good science in coming years. Thank you so very much for your kind attention.
So we now have a short tea break. We resume back at 11:15. We'll be requesting all of you to please join us inside the hall. We'll be starting the session in next 2 minutes. Humble request to all of you, kindly be seated. We are about to begin the session. Okay, so we are all good to go with session 4, vascular liver diseases. The chairperson of this session are Professor Dr. Yogesh K. Chawla, KIMS Bhubaneswar and AIMS New Delhi, Dr. S. K. Sinha, PGIMER Chandigarh, Dr. Tarana Gupta, Pandit Bhagwat Dayal Sharma, Postgraduate Institute of Medical Sciences, Rohtak, Dr. Asha Shubhalakshmi, Care Hospital, High Tech City, Hyderabad, Dr. E. Umakant, Sri Hashita Gastroenterology and Diabetes Super Speciality Hospital, Rajamundari.
Good morning, everyone. So we start with this session on vascular liver disease. And the first speaker is Professor Akash Shukla. He's going to talk to us on the INASL guidelines for portal vein thrombosis. Akash.
Good morning, everybody. At the outside, I must thank INASL and the chairpersons for this opportunity, and must congratulate all of you who have stayed back for this last session of the whole conference. It's always a challenge. So this INASL consensus conference, the consensus guidelines were drafted for the first meeting was done on 5th February 2023, and the second meeting was done on 4th of June. So we started with the nomenclature because there was a lot of confusion about what is EHPVO, what is acute, what is chronic, what is PVT. Especially with Bhubaneswar using the words EHPVO and PVT interchangeably, it was confusing for everybody. So we have classified portal vein thrombosis as acute with or without cirrhosis, and chronic as EHPVO and chronic PVT, and chronic PVT again with or without cirrhosis. So we first defined EHPVO. EHPVO is an entity described in the Indian subcontinent with distinct clinical and radiological presentation, in contrast to the chronic portal vein thrombosis described from the West. EHPVO is typically characterized by presentation in childhood or early adulthood, with replacement of the native portal vein by a cavernoma and portal hypertension, variceal bleed, splenomegaly, hypersplenism, PCC, etc. So EHPVO is what we see routinely, young child or a young adult coming with cavernoma and portal hypertension. There is no clear timeline distinction between acute and chronic thrombosis. Presence of extensive portosystemic collaterals or a prominent cavernoma suggests a chronic thrombus. A functional-anatomical classification may be better than anatomical classification for portal vein thrombosis. The prevalence of portal vein thrombosis is about 1% of the population. This was based on large autopsy studies. The prevalence of portal vein thrombosis in cirrhosis varies depending on diagnostic modality used, stage of cirrhosis, and or inclusion or exclusion of HCC. Around 1 in 10 patients with cirrhosis are likely to develop portal vein thrombosis, and the prevalence of portal vein thrombosis is higher with increasing severity of liver disease. Coming to the etiology, non-cirrhotic portal vein thrombosis should be evaluated for etiology for both local as well as systemic thrombophilic disorders. In cases of EHPVO, routine evaluation for thrombophilia cannot be recommended and has to be individualized. Cirrhosis in itself is a local risk factor for portal vein thrombosis, and need for extensive alternative etiological evaluation is currently not recommended. It needs to be individualized based on extent of the thrombus, symptoms, prognosis, and course of the disease. Any patient with a coexistent or past thrombotic event in systemic circulation or a symptomatic acute PVT with no underlying local cause needs to be evaluated for a procoagulant condition. Myeloproliferative neoplasms are common and treatable cause of thrombus in these patients. Other procoagulant disorders, especially those needing a separate treatment strategy, need to be evaluated on a case-to-case basis. Majority of portal vein thrombosis and cirrhosis are found incidentally during imaging. Among those who are symptomatic, the clinical presentation of PVT in cirrhosis varies with the duration of thrombus formation, degree of involvement, nature of thrombus, and the underlying liver condition. PCC is present in more than 90% of patients with EHPVO based on ERCP or MRCP studies. Majority of the patients are asymptomatic for this PCC, and symptoms such as pain, jaundice, and fever develop only in a minority, around 5%, on long-term follow-up. A proportion of children with EHPVO may have growth retardation. Coming to pregnancy, pregnancy in cases with EHPVO is associated with good maternal but poor fetal outcomes, and they should be managed in a tertiary care multidisciplinary unit. The risk of variceal bleeding in pregnant EHPVO is higher than in pregnant cirrhotic patients. While the maternal outcome following a variceal bleed in pregnant EHPVO is good, the fetal outcome is poor. The incidences of abortion, prematurity, small for gestational age babies, and perinatal death are high in pregnant women with EHPVO. For diagnosis, Doppler ultrasound is the initial investigation of choice in cases of portal vein thrombosis. However, For further evaluation, a cross-sectional imaging is needed. In cases of EHVVO, the decision to do cross-sectional imaging may be individualized. There is insufficient data to recommend splenic stiffness to predict presence of esophageal varices in patients with portal vein thrombosis. Splenic stiffness may predict variceal bleeding, but cutoffs require further studies. Coming to natural history of portal vein thrombosis, spontaneous resolution rate of portal vein thrombosis in non-cirrhotic patient occurs in less than 30% of cases. A major proportion of these patients without resolution go on to develop varices and symptomatic portal hypertension on long-term follow-up. More than 80% of the patients with non-cirrhotic chronic portal vein thrombosis develop portal cavernoma cholangiopathy, but less than 1/3 have actually symptomatic PCC. Portal vein thrombosis in cirrhosis has modest, that is around 30% rate of spontaneous recanalization, most of which is partial more than complete, and recurrent thrombosis after recanalization can further develop in approximately 1/4 of cases. The rate of spontaneous recanalization is higher in cirrhotics as compared to non-cirrhotics, while cavernoma formation is higher in non-cirrhotics. The presence of portal vein thrombosis in cirrhosis adversely affects liver transplant outcomes. Non-resolution of complete thrombosis or progression of partial thrombosis in cirrhosis is associated with deterioration of liver function and increases the incidence of liver-related events. Ascites can be seen in around 20% of patients with portal vein thrombosis or EHVVO on long-term follow-up, but is usually precipitated. Coming to management, and here I have taken only selected statements for want of time, and some of the obvious statements which are very well known have been omitted. So, role of non-selective beta blockers. There is insufficient data on whether beta blockers or endoscopic therapy is better, and either could be preferred for primary prophylaxis of portal hypertension related bleeding in patients with chronic portal vein thrombosis or EHPVO. A combination of non-selective beta blockers and band ligation is recommended for secondary prophylaxis in patients with chronic PVT or EHPVO. Coming to primary and secondary prophylaxis in PVT in cirrhosis, non-selective beta blockers, carvedilol or EVL is recommended for primary prophylaxis in patients with large varices. The choice of treatment should be based on availability, expertise, and patient preference. Non-selective beta blocker is the recommended therapy for patients with high-risk small esophageal varices. Secondary prophylaxis, combination of non-selective beta blockers or carvedilol with endoscopic band ligation is the first-line therapy in prevention of rebleeding. Interval of screening endoscopy in patients with acute and chronic portal vein thrombosis. In acute portal vein thrombosis, endoscopy should be performed at baseline. Subsequent screening endoscopy should be performed at 6 months if there is no evidence of recanalization. Endoscopy should be performed every 2 to 3 years in adult patients with chronic PVT or cavernoma without varices. Patients with small varices should have endoscopy every 1 to 2 years, and patients with big varices should have one endoscopy at least every year. Role of portal vein recanalization procedures. Anticoagulation is very standard, so we have not talked about it here. In patients who do not develop complications of portal vein thrombosis, despite the absence of portal vein recanalization, after optimal anticoagulation, interventions other than anticoagulation as indicated are not required. The aim of portal vein recanalization is to achieve 1. Alleviation of clinical symptoms and 2. Portal vein recanalization. A multidisciplinary approach with early image-guided intervention, thrombolysis, and surgical intervention should be considered in select patients at referral centers. Portal vein recanalization, along with TIPS, improves outcomes of controlling refractory bleed as compared to recanalization without TIPS. Portal vein recanalization with TIPS is recommended in patients who are listed for liver transplantation with thrombosis of portal vein trunk without recanalization on anticoagulation. Avoiding portal vein stent placement is recommended in patients undergoing TIPS if they are transplant candidates. Portal vein recanalization may be considered in acute symptomatic portal vein thrombosis with persistent symptoms despite adequate anticoagulation. Portal vein recanalization may also be considered in acute symptomatic portal vein thrombosis with persistent thrombus if the main portal vein is thrombosed despite adequate anticoagulation, but the primary and secondary branches of portal vein are patent even in presence of mild symptoms. So if you have just main portal vein thrombosis, but the branches are free, the intrahepatic radicals are free, and you have anticoagulated and the patient has not improved, even in the presence of mild symptoms, we can consider doing portal vein recanalization. Patients with refractory complications of portal vein thrombosis or EHVVO should be referred to expert centers to consider percutaneous recanalization of the portal vein or other vascular interventional procedures. Coming to the last slide, TIPS is more effective than standard therapy in preventing rebleeding and in recanalizing portal vein thrombosis in cirrhosis without increasing the risk of hepatic encephalopathy and adverse effects. TIPS with portal vein recanalization with embolization of varices may be done in patients who have failed standard therapy for varices. I have not presented today the statements on anticoagulation and surgery, but I'll be happy to answer any questions related to that as well because they have been finalized. I thought that we won't have time, but I think we have finished well in time. So I'd like to thank all the task force members. In addition, we must thank Professor Dominic Wala, who graciously helped us frame these guidelines, and I would like to thank the girl power in the young, brilliant hepatologists who participated in this formation of these guidelines, Rakhi, Madhumita, and Ankita, and my other team members, Siddharth, Arun, and Aditya, who helped write these statements and write the proceedings. So I think we have around 6 minutes, so I will be happy to take any questions at this stage.
Thank you, Akash, for coming out with these guidelines. I think we can have some comments from the panelists and the audience before we discuss further.
Sir, in a patient with patent main portal vein and with the involvement of either right or left branch of portal vein, but if the patient is not symptomatic, but sometimes it shows a small hypodense area in liver, what should be done in such cases with an intact main portal vein?
So that's a good question. So usually if you have just an isolated branch portal vein thrombus in presence of cirrhosis, I'm assuming.
Yes, sir.
Because this situation occurs usually in cirrhosis. If you look at the literature, spontaneous recanalization rates are very high if you have isolated thrombus formation. What you usually do is you look at the flow in the main portal vein. If the flow in the main portal vein is less than 15, then it is a good idea to anticoagulate this patient, because then it is likely to have progressive thrombosis. But if you have a good flow and it is more than 15, usually the chances of reconstruction are much higher, and you can just get away without doing any intervention in these patients.
So regarding anticoagulation.
Yeah, you can get away without if the flow is good.
Even if we have a small hypodense area in liver, which suggests that there is some infarction.
Yeah, so with branch thrombosis, it's very unusual to have a real infarction. What you are usually seeing on a CT scan is a perfusion defect. You'll have a delayed filling up in that particular area. So if you look at the delayed images in those patients, you'll find that it is filling up. It's rare that you'll have a isolated branch causing infarction.
So the main decisive factor is the flow in the main portal vein.
Absolutely. The main determinant will be the flow in the main portal vein.
Akash, I have 3 points to suggest. One is, in the guidelines, if you can add portal vein velocity, which predisposes to portal vein thrombosis, if that can be added. Second, we don't see portal cavernopathy in cirrhotics with portal vein thrombosis. So that needs to be mentioned somewhere. And third would be the natural history of EHPVO. Our own study from the department, even after 10 years, there was no extension of the thrombus.
Absolutely,
and
sir.
that needs to be brought in somewhere.
Yes, sir. That has been mentioned in the main text. Absolutely.
Right.
Perfect. Thank you, sir. Points well taken.
Excellent presentation, Dr. Akash. Are there any guidelines for looking for myeloproliferative disorders in EHPVO in the Indian context? And the role for mutations like Janus kinase mutations, are they included in the recommendations?
So I think, again, excellent questions. So in pediatric population, the typical EHPV that we see, there is no data to suggest that they have myeloproliferative neoplasms. But the portal vein thrombosis, especially the adult onset, the ones which we are talking of, which is like the West, in them there is a significant proportion of patients who have JAK2 mutation. And therefore, in them, we have recommended that we should look for. We cannot go by the conventional cutoff, what the West suggests of splenomegaly, because I think almost all our patients will have significant splenomegaly with EHPVO. But if you have a EHPVO with a high platelet count, more than 2 lakhs, then those are the patients where you should definitely look for a myeloproliferative neoplasm.
And any recommendation for shunt surgeries in our guidelines for children?
Yes, actually, we have mentioned about it, but for want of time, I did not present it today. So shunt surgeries are indicated in patients who have EHPVO with symptomatic hypersplenism. That is one indication, or those who have recurrent bleeds, or patients who are unable to reach an endoscopy center in time. So those are the indications for doing a shunt surgery. So,
hi Akash. I mean, it's a wonderful presentation. Many congratulations to you and your team and INASL to make guidance for EHO, which is so common. My only question was, you said the prevalence is 1%. 1% is too big a number. In a country like ours, means we'll have a 1.4 crore patient with PVT. What are the basis for that? How strong is that data to infer this number?
Absolutely, sir. So it is just one study, one large autopsy study of around 80,000 patients by Professor B.D. Pimparkar. So that was one autopsy study based on which, that's why it is, we have written level of evidence as weak. And in fact, if you read the text, it is mentioned that we require prospective data from across the country to make any strong conclusions based on this. So absolutely, I agree with you on that particular point.
Because 1% means we will also have to think about that how do we find these patients. It's not 1% in any population become a very important public health problem, and that will require different strategy. So what we do in EHO, patient comes to us and we look forward and then we work up. 1% means we have to go to them and find out who they are.
Absolutely. I agree with you, sir, completely on this.
At times we need to do thrombophilia screen in these patients. The question comes, it's a costly affair. Will you have a small kind of panel, which could be helpful, cost effective?
Absolutely.
When
so
we need to do thrombophilia screen.
Yeah, so I completely agree with you. So where we think that it is required to evaluate, I think one thing that we should look for is a myeloproliferative neoplasm. So a JAK2 mutation is definitely warranted. And then if the other things clinical, the thrombophilic disorders which have a separate treatment strategy, like antiphospholipid antibody syndrome, PNH, or hyperhomocystinemia, or your MTHFR gene mutation. I think these are the ones which require a different strategy for management. So I think these are the ones which we should recommend. All others will be taken care of by just anticoagulation, and they are weak prothrombotic states.
Thank you.
I think we stop here. Thank you, Dr. Akash.
Thank you very much.
And for the next talk, I invite Dr. Mithun, and he is going to talk on the issue of approach to a nodule in Budd-Chiari syndrome. Dr. Mithun, please.
Yeah, thank you so much. So after a very consensus statement, it's difficult to talk on a topic where there is no consensus. So I went through the literature, talked to the radiologist. Nobody is very certain how to go about these nodules in patients of Budd-Chiari syndrome. So Budd-Chiari syndrome affects quite a significant amount of the young population. And despite doing a procoagulant workup, underlying risk factors are not found in around 15 to 30% of cases. They most commonly present with the classical triad of abdominal pain, discomfort, hepatomegaly, ascites, and the level of obstructions in this patient varies either in the hepatic veins or a thrombus in the inferior vena cava, or sometimes isolated webs are present either in the hepatic veins or the IVC. So whenever we look into a scan of a patient with a Budd-Chiari syndrome, we should remember there are some vascular changes which are expected to be seen in these patients. The most common is that there could be a partial and or a totally non-visualization of the hepatic veins. And when we look into the IVC, we can see narrowing with an enlarged caudate lobe, which sometimes may be not enlarged also, and there can be a narrowing due to a web, and in around 1% of patients, there can be associated aneurysms. So the topic of the discussion is nodules in Budd-Chiari syndrome, which is present in around 40% of cases, are usually small and multiple and hypervascular and spreads throughout the liver. So why do these nodules develop? So the basic pathology is that there is an outflow obstruction. Because of the outflow obstruction, there is sinusoidal dilatation and there's infiltration of the interstitial fluid. And when the capacity of the lymphatic drainage exceeds this amount of fluid, it leads to the development of ascites and hepatomegaly. Along with this, there is hypoxic injury and development of portal hypertension due to outflow obstructions. Both of these leads to parenchymal changes like parenchymal fibrosis, which in turn leads to areas of hyperarterialization and hypertrophy. These are the areas where the hepatic outflow is usually preserved, and this leads to nodule formation. So this is the basic pathophysiology, what is being taught, how the nodules develop in Budd-Chiari syndrome. They are better renamed as large regenerative nodules, or some people label them as FNH-like nodules. Both these terms are used synonymously. This is how it looks on macroscopic appearance. So you can see the nodules here on the cut section. These nodules appears usually as yellowish and are spread throughout the liver, and you will see patchy areas of vascular congestion. And when we go for a microscopic analysis, we will see that most of these nodules will have absence of portal vein and very prominent arteries, because that is what the supply comes from. So why do we want to run after nodules in Budd-Chiari syndrome? Our concern possibly is obviously ACC. So this is a recent study published last year where they included patients with BCS, classified them into BCS with cirrhosis and BCS without cirrhosis, and they had a huge control subject. And they followed them up at 1 year, 5 year, 10 and 20 years. This is a study from Sweden. So the cumulative incidence of ACC at 5 years was around 3.11% with an absolute risk of around 0.6%. And when these patients were followed up for 20 years, the cumulative incidence was around 7.58% with an absolute risk of around 2.3%. So, the median time to development of ACC was around 7.5 years. The median age was 50. Most of these patients were around 40, 45 when they were enrolled. The presence of ACC was 1.3 versus 0.1 per 1,000 person years in patients who had and who did not have Budd-Chiari syndrome, and the hazard ratio was around 11. And all the patients who developed ACC had cirrhosis. So this brings into consideration whether these patients of Budd-Chiari syndrome without cirrhosis also needs to be screened for development of a malignancy. Can we identify a cohort of patients of Budd-Chiari syndrome who develop ACC? So this is again another study which was published last year of 113 patients, where they found that patients who had inferior vena cava block with a stricture of the hepatic venous outflow had more prevalence of ACC, and majority of these ACCs were found in the right posterior lobe. Whether we can extrapolate this to the larger population still remains to be seen. So coming to, as a clinician and with the help of a radiologist, how does the nodule on a Budd-Chiari looks on a CT scan? So if you look into the arterial phase, you will have a homogeneous arterial enhancement, and then you have to have a close look on the IVC. If it is narrowed, you can find a dilated or enlarged caudate lobe, and then we can see sometimes a hypoattenuating ring around the nodule, which is due to the altered blood flow dynamics and the congestion around the lesion. But the majority of these cases, an MRI is the preferred modality. In the next few slides, I will go stepwise. So when we see a T1 image on an MRI, you will see a hyperintensity on a fat-suppressed T1 imaging. This hyperintensity has been explained in some studies as deposition of copper, and it could be also due to the perinodular parenchymal congestion. And in the T1 images, in around 15 to 20% of patients, there will be a low intensity central scar. When we go to the T2 images, the T2 images are very variable. They will not give us much information on these nodules. They can be hypodense, which has again been attributed to these mineral deposits. Since these are basically hepatocytes, it can be iso-intense, and if there is an infarct, there can be hyper-intense also. What is more important is that if we see the diffusion weighted images, there would be absence of diffusion restriction. Now we come to the dynamic enhancements. We are given contrast to this patient. So in the arterial phase, we'll see a hyper-intense lesion with a hypo-intense ring around some of the lesions, and a scar is present, is hypo. So hyper-intense mass with a hypo-intense scar in the arterial phase. In the delayed phase, they continue to be hyper-intense or iso-intense, and the scar will also gradually may become hyper-intense. So with this background, we are to differentiate between two things clinically. Whether it is an FNH-like nodule or is it an adenoma, because it's a young female in front of us. So we have to bring our clinical part as well as the radiological part here. Usually adenoma, we may have a history of estrogen exposure present and younger females than the mean age of a Budd-Chiari syndrome. When we look into the fat suppressed images, sometimes adenoma can have fat and hemorrhage and necrosis, which are usually not present in these large regenerative nodules. As we showed the pseudo capsule that was present, it is not seen in patients with adenoma, and associated vascular abnormalities can be present in both these scenarios. So to differentiate between these two is not so easy, except if we can have a clinical history which is very strong. Now the most important is how do we differentiate between an FNH-like lesion, an FNH, and an ACC? So we start with the findings like it would be multiple in FNH, like lesion. In FNH, it's usually solitary. In hepatocellular carcinoma, it can be either. The size of these FNH-like lesions are usually less than 4 centimeter. In FNH are usually bigger. The surrounding parenchyma in these lesions, in FNH-like lesions, are abnormal because of perfusion defects. In FNH, it is normal. In SCC, it can be, it is usually abnormal unless we are dealing with a NASH or a chronic hepatitis B ACC in a non-cirrhotic liver. Ascites is usually absent in patients with FNH, and we can look for clinical signs of Budd-Chiari syndrome on patients with FNH-like lesion. Once we have established this part, we should keep in mind that the Lyrat system of reporting for ACC is not to be used in patients with Budd-Chiari syndrome because it gives a very high false positive values and it decreases the positive predictive value. So now we come to differentiate between the three. First, we are looking into a film, which is a pre-contrast imaging. I'll keep it very simple. An FNH-like lesion will be a hyper-intense lesion with a hypo-intense scar. FNH would be a hypo-intense lesion with a hypo-intense scar. And ACC, we don't comment too much in a pre-contrast T1 imaging. What is important is that in the T2 imaging, ACCs will be moderately hyperintense. The other two will still be variable. When we do a diffusion-weighted images, we should remember that we have to see both the diffusion-weighted images and the ADC. So to keep it again simple, if a diffusion-weighted images is showing hyperintense and the ADC is showing hypointense, it's an ACC. If a diffusion weighted image is showing hyperintense and the ADC also is showing hyperintense, it could be lesions like a cyst, or the clinical significance of it is uncertain. Then we go to the contrast phase. In the contrast phase, if you see in the arterial phase, in FNH-like lesion, you will have a hypointense scar and there will be hyperintense lesion. Same, hyperintense lesion, hypointense scar. FNH, same, hyperintense lesion with a hypointense scar, but the differentiating point is that as you go to the delayed phase and the hepatobiliary phase, a FNH will become a hyperintense lesion with a hyperintense scar, and the FNH-like lesion will be hypointense lesion, and which will gradually become hyperintense in the later phase, not in the initial phase. ACCs I won't discuss because all of them are aware of the classical late arterial enhancement and washout with rim enhancement. So chairperson, it's a very tough job. Majority of the time, I sat down with the radiologist. The radiologist also appeared not to give a very clear consensus on these lesions. Many of the time, we have to biopsy these lesions. If the clinical suspicion is high, there is a paper which says that alpha-fetoprotein of greater than 15 should raise a high suspicion of ACCs in patients with Budd-Chiari syndrome. So as the clinicians, we need to keep on looking for hepatocellular carcinoma because it do happen in around 6% of patients. We are not supposed to depend on the Lyra scoring system for these nodules. And even in patients of Budd-Chiari syndrome without cirrhosis, whether monitoring them for ACC is justified, it's open to the house, and there will be both under and over diagnosis of ACC in this patient population. Thank you so much.
We can have questions and comments from the house.
Dr. Mithun, that's a wonderful talk. Is there a role of biomarkers in differentiating these nodules, especially in Budd-Chiari syndrome? Whether we should start screening HCC in patients with Budd-Chiari, and how frequently and when after the first diagnosis?
So that's the exact thing that the last paper in 2022 has suggested, that since the risk of SCC is still higher in patients of Budd-Chiari without with or without cirrhosis, though majority of the patients are with cirrhosis. So what they recommend is that anybody, and the majority of this patient cohort was above 50 years. So it's not there in guidelines, but they say that anybody above 50 years who has a median duration of disease of around more than 5 years should be subjected to screening for HCC. Though as of now, all the reports of the nodules with HCC are on patients who have developed cirrhosis of liver. There's no clear guidelines on that, on how frequent to do it. But if you ask me in a real life scenario, I would prefer to do it same like a child has cirrhosis 6 monthly. That's what we do.
Dr. Mithun, it's excellent presentation. So in a T1 image in the MRI, that's showing some ring around this, and you said that is due to copper deposition. Copper.
The ring is not due to copper. The hypointensity is due to copper. That was one study by Casalis.
Most of the liver that metalloprotein is related to zinc and magnesium. Why is specifically any pathology?
So this is based on just one study by a scientist called Casalis who has done it, and they examined this and they found copper in these deposits. The ring around it is not copper. The ring around is vascular congestion and fluid. It's interstitial fluid.
Okay.
Mithun, Doctor, hi.
Yeah.
So excellent. My one question is, when you have those FNH-like nodules or adenoma-like nodules, and you're doing a biopsy, when will you decide to send for beta-catenin mutations?
Yeah, that's a very tough call, but yes. So I think if you're suspecting an adenoma, that's when we think of a beta-catenin. If the size of the lesion is a little larger, I would probably ask for a beta-catenin. But routinely, we are not sending them for beta-catenin mutation. I don't know the practice elsewhere, but we are just sending them for routine biopsies without asking for specifically for beta-catenin.
Dr. Mithun, one more question. For the diagnosis of cirrhosis in patients with Budd-Chiari syndrome, if we go by LSM, then it may be fallaciously high because of the hepatic congestion. So should we biopsy all the patients?
To biopsy to prove cirrhosis?
Yeah. So how should we, what criteria should be placed for proving, liver cirrhosis in patients with Budd-Chiari, where even imaging may show nodularity, which is actually secondary to the, Budd-Chiari syndrome itself. And then LSM values are fallacious because of hepatic congestion and they are false positive.
Yeah. So there are guidelines. There are some studies which have taken higher cutoff of LSM up to say 18 in patients with vascular disease to diagnose as cirrhosis, not the 14 that we use. To biopsy all of them, I don't know what clinical extra benefit we are going to get. So I'm not sure about biopsying all of them unless we are suspecting some conflicting etiologies going on in these patients.
Dr. Mithun, here.
Can I ask one question?
Yeah.
I think it's wonderful talk, Dr. Mithun.
Go
Yeah,
Sorry.
Yes, ma'am.
Yeah, so this point about copper, I think is quite true, because even in Wilson's disease, if you see, you often get a lot of nodules in the liver, much more than you would see in any other etiology of cirrhosis. So I guess it is copper which makes these nodules form, which may be true for Budd-Chiari also. Now, why copper should be high in Budd-Chiari is something which we need to look at.
Yes, sir.
So I think if I heard correctly that you said 40% of Budd-Chiari will have these lesions.
Nodules.
40% is a large number.
Yes.
And therefore, it's very relevant to see as a clinician that what are these lesions are. Leaving them uncharacterized, may not be a great thing to do. Are there any data to show that after revascularization, what happens with these nodules? As it appears that most of them, if every second person has this nodule, only few go HCC, it means they're likely to be benign in nature. If they're benign, then what is the pathophysiology? As you rightly said, there are certain hypotheses. But are there any data, or is it good to see these patients on long-term follow-up, that what happens to these lesions once you revascularize the hepatic veins or so?
So these nodules develop as early as 1 month after the hepatic vein obstructions. And the basic reason why they changed the name from regenerative nodule or It is because there is some amount of fibrosis inside these nodules. So if the revascularization, there is only one study which says if you have early revascularization, which actually we don't do. So when a patient comes with ascites, we try to first wait till some time to see if it resolves, because there is what the radiologist feels is that there is a half-life of the stent that they put in. So, but once I think it becomes chronic and fibrosis starts, these nodules would remain. Whether their progression would be different is something we need to, is an interesting point to see.
Thank you, Dr.
Mithun, would platelet counts and splenomegaly go in favor of cirrhosis?
Yes, so those would be additional points.
I think that needs to
in
be
favor
kept
of
in
cirrhosis, definitely, clinically.
I think we close here and we move to
Thank you.
The next talk.
I invite Dr. Sunil Dadich to kindly come over and deliver his talk on the management of pregnancy and vascular liver disorders and portal hypertension. Over to Dr. Sunil.
Thank you. Thanks, Chairperson. And at the outset, I would like to thank the INASL committee for giving me this opportunity. And I'll be speaking on something different from the routine, how to manage pregnancy in patients with vascular liver disease and portal hypertension. These are the figures from King's College. The incidence of pregnancy in women with chronic liver disease. If you see over last decade, more than a decade, there has been increasing incidence of pregnancy found in patients with liver disease. So pregnancy is becoming increasingly prevalent in patients with CLD, maybe due to awareness, monitoring, and better management of underlying liver disease, or maybe due to certain assisted concepts and techniques. So pregnant females are going to be very common in our clinical practice. Although the management of pregnancy and treatment of portal hypertension more or less would remain same in these two, in these patients, but there are certain caveats and differences. The next 12 minutes or so, I'll discuss those differences and caveats. This is the outline of my talk. I will divide them into management of pregnancy in VLD and as well in the portal hypertension, because there are certain differences between the management of these two conditions. In VLD, first the assessment. Female patient with vascular liver disease, childbearing age, constitutes around 50% of patients with Budd-Chiari syndrome, around 20% in ESPVO patients, and with PSVD, they are around 15%. If they want to become pregnant, because of their life expectancy is long, the pregnancy is not contraindicated. So how to approach these patients? When these patients comes to you, if they desire to become pregnant, you should subject them for preconception consultation in the form of telling them the risk of underlying liver disease, how it will behave when they become pregnant, and the risk of mother to fetus and the outcome during pregnancy with liver disease. If they are desired to become pregnant, you should consider that disease should be stabilized. You should inform them the risk to risk of mother and fetus, screen them for esophageal varices, apply proper prophylaxis as per the indications, and obtain your opinion from gynecologist and hematologist for the management of underlying coagulation disorders. So in these group of patients, management of anticoagulation is very important. How to manage anticoagulation? What are the coagulation changes in pregnancy? Pregnancy is a procoagulant state because of increasing VWF, fibrinogen, increasing factor 5 to 7, 9, 10, and increasing plasminogen activator inhibitors. And there is a decrease in protein C and S values. So because of this procoagulant state, there will be some changes in the interpretation of prothrombin time and other time test for the coagulation disorders. How to manage pregnancy in with for anticoagulation? Warfarin derivatives are teratogenic in 4 to 6% of pregnancies because they cross blood-brain barrier between 6 to 12 weeks, and they can cause fetal hemorrhage, warfarin fetal syndrome, or warfarin embryopathy. So all these patients should be switched to LMWH before the 6th week of pregnancy. The therapeutic doses of LMWH should be maintained throughout the pregnancy. Nentropirin and the tinjaparin are the ones which have the advantage of giving a single daily dose as a therapeutic treatment. The unfractionated heparin can also be used, but it necessitates dose adjustment with activated PTT, and there is a risk of heparin-induced thrombocytopenia in these group of patients. So, a person who is already on anticoagulation, yes, discuss the switch to LMWH in the preconception period. If they are not on anticoagulation, discuss the use of prophylactic LMWH if indicated because of underlying liver disease, because of a prothrombotic state, or because of obstetric history. If the person is on LMWH while pregnant, discontinue the LMWH more than 24 hours before the delivery. Prefer vaginal delivery over the obstetric, unless there are obstetric contraindications, over the cesarean section, and then resume anticoagulation after more than 24 hours. In prophylactic, continue them up to for 6 weeks, and others it is lifelong. Coming back to the management of pregnancy in vascular liver disease, in the antenatal period, there should be monthly follow-up with gynecologist and 3 monthly with hepatologist. Endoscopy should be repeated in the 2nd trimester. Look for varices. Appropriate management should be performed. High risk of cesarean section because of postpartum thromboembolism, because of bleeding directly from the injury to the portosystemic collaterals present in the skin or subcutaneous, and there is a risk of post-op decompensation following cesarean section. Unless there is contraindication based on the obstetric indications, vaginal delivery should be performed after 36 weeks. The second phase of vaginal delivery can be enhanced with the help of certain maneuvers like forceps and vacuum, because during this state there is a high risk of variceal bleeding. In the peripartum, epidural anesthesia is preferred unless there are contraindications. You should stop the LMWH if the person is given epidural anesthesia in prophylactic dose less than 12 hours, therapeutic dose less than 24 hours. If there is a contraindication to epidural anesthesia, the short-acting narcotics can also be used. This is very important. The cutoffs for platelet counts for various procedures. For LSCS, it is more than 50,000. For vaginal delivery, it is 20,000. For epidural, it is more than 75,000. For spinal anesthesia, it is 50,000. How to manage in the postpartum period? There is a thromboembolic risk during the postpartum period. As high as in the first week, it is 21-fold. Up to 4 to 6 weeks, it is around 4-fold. Anticoagulants should be resumed as soon as the obstetric indications conditions are appropriate. Warfarin now in the postpartum period is safe, and it is not contraindicated, and is not excreted in the breast milk. Contraception by barrier devices and the progesterone only pills can also be discussed. What are the prevalence and outcome of pregnancy in vascular disorders? Early studies from India revealed around 47% of patients having pregnancy-induced Budd-Chiari syndrome. This is the early study from PGI Chandigarh, MS Guru, Dr. D.V. Datta. Around 16 cases, pregnancy, Budd-Chiari syndrome, very bad prognosis, 8 out of 16 died within 1 year of diagnosis. Later study, 177 patients, again from the PGI. Out of 177, 30 had pregnancy-induced Budd-Chiari syndrome. So pregnancy might be a relatively common cause of Budd-Chiari syndrome. A woman who had pregnancy with some kind of thrombotic disorders are more likely to develop Budd-Chiari syndrome. But the later studies, even from India and abroad, didn't show that pregnancy is a cause of Budd-Chiari syndrome. And there has been a meta-analysis. Even in Indian later studies, there has been a lot of variation regarding the prevalence of Budd-Chiari syndrome in pregnancy. And even among the Indian studies, there is a lot of heterogeneity. So the overall global prevalence of pregnancy-related BCS is around 7%. But there are a lot of heterogeneity all over the world. What about the outcome? Retrospective study, 24 pregnancies. Most common outcome is premature birth, but these babies do well. Other common is variceal bleed, LSCS, they said there is indication. and miscarries, especially before 20 weeks. Another trials on outcome, 16 pregnancies. Fetal loss, very common in less than 20 weeks of pregnancy, but in later weeks of pregnancy, the babies do well. What about EHPBO patients? Again, Indian trial from PGI. 104 pregnancies, high risk of variceal bleeding, anticoagulants are well tolerated, and no deaths. So EHPBO patients do much better compared to the Budd-Chiari syndrome patients. Coming to the management of pregnancy in portal hypertension, these are the outline. I'll be discussing the effect of pregnancy on portal hypertension, then the prevalence and the outcome, risk stratification, and the approach. Physiological changes in pregnancy are in the form of increased cardiac output, plasma volume, stroke volume, as well as reduction in the systemic vascular resistance. All these changes are commonly seen in patients with portal hypertension. So what happens to portal hypertension in patients who are pregnant? There is worsening of portal hypertension because there is increased blood volume, increased cardiac output, increased portal pressure, decreased systemic vascular resistance, and increased flow in collaterals. This worsening of portal hypertension make the person prone to develop variceal bleed, prone to develop decompensation. So around 50% of pregnancies suffer from portal hypertension associated complications, and the severity of these complications will depend upon the underlying liver disease. What about the variceal bleeding? It occurs in around 50% of patients with portal hypertension, 1/3 with cirrhosis. Associated mortality in early studies are 50%, but now it is around less than 20% because of better management. Variceal bleeding does occur in non-cirrhotic portal hypertension, but the mortality is significantly less. Second and third trimester and the second stage of the labor are the time of greatest risk of variceal bleeding. The predictor of variceal bleeding during pregnancy, apart from the size of the varices and the presence of red colored signs, are the very important history of preconceptional variceal bleeding or a varices which have not been seen or not been tackled earlier. So how to manage the varices in the preconceptional period? During first visit, whether it is a preconception, you screen them for varices. In the antenatal, also you screen them varices. Again, re-screen them in the second trimester of pregnancy. And if there are VLB varices likely to bleed, like they are, if they're large varices, small with red colored signs, subject them for EVL. Small varices with a history of variceal bleeding, give them beta blockers. The management of variceal bleeding during pregnancy is more or less same as we do in a non-pregnant patient. Resuscitation, vasoconstrictors, endoscopic therapy in the form of EVL for esophageal and glue for gastric varices, and the secondary prophylaxis with beta blockers. This is very important complication I would like to highlight in one slide. Splenic artery aneurysm in pregnancy, very common. Occurs around 2.6% of pregnant females with cirrhosis during pregnancy, and is thought to be because of high estrogen levels and the increased blood flow in the splenic artery. Up to 25% of these patients experience the double rupture phenomenon, means there is a small self-contained rupture earlier, before and after that there is a significant rupture leading to acute abdomen, significant drop in blood pressure and the hemoperitoneum. So most commonly these rupture occurs in the third trimester, and they require the transcatheter embolization surgery in some cases where there is not availability of IR or failure of these therapy. What is the outcome of pregnant females in cirrhosis? Very busy slide. This is from Nora Trewal group. There has been significant increase in females becoming pregnant who are cirrhotic. In 2000 it was 2, and 2016 it is around 15 per 1 lakh. So there is 7-fold increase in pregnancy in females. The common etiologies in all these cases are, most of them were NAFLD related, few were virals and alcohol. Very important, rates of childbirth compared to general population, there is significant increase, 17% in patients with cirrhosis, but there is a decrease in decompensated cirrhosis, as we know. And there are significantly higher number of complications seen in these pregnant females in the form of ICP, early induction of labor, preterm and other. The deaths and liver-related events 1 year postpartum, very less. In compensated, death is very less, decompensation is less than 2%. The most common decompensation, variceal bleeding, 60%. Others are ascites and encephalopathy. A prior history of decompensation, they're likely to decompensate around 13%. No history of decompensation, it's only 1.2%. Another study, multi-center study, Akash is one of the author. So female with non-cirrhotic portal hypertension, they remain alive up to 27 months of last delivery. 1/3 developed liver-related events in the form of ascites, varicose bleed in others. Pregnancy loss is higher before 24 weeks, around 20%. A fetal outcome was favorable in pregnancies who are reaching 20 weeks or beyond. Pregnancies reaching 20 weeks and beyond, there is a high risk of preterm delivery, but most of these fetus do well. Obstetric bleeding is most common because of anticoagulation. How can you risk stratify these patients? MELD score less than 6 predicts minimal complications, more than 10 predicts decompensation. LB score less than minus 2.7 predicts live birth. Preconception pre 0.84 predicts term pregnancy. Similarly, platelet less than 110 predict presence of varices in second trimester. So how to manage pregnancy in portal hypertension? There are 4 steps: preconception, antenatal, peripartum, and the postpartum. Preconception counseling, patients should be oriented about the risk of mother and fetus, complications of liver disorders during pregnancy, should undergo surveillance endoscopy in appropriate management. Prior history of variceal bleeding is the most important risk factor. I'll just take another 1 minute, yes. Endoscopy is the time to be done in second trimester of pregnancy, and if not done early and then before delivery. Propofol is the preferred method. Beta blockers, they have a risk of congenital malformation, fetal growth restriction, fetal bradycardia, as well as neonatal hypoglycemia. But the benefit of beta blockers outweigh the risk, so they should be continued in patients with large varices and small varices with red color signs. Anemia needs to be treated, and monitoring should be done. Peripartum, vaginal delivery is preferred. We have discussed earlier. Epidural anesthesia, analgesia is preferred. Postpartum risk of PPH is high in these group patients because of thrombocytopenia. Management is same as we do in other non-pregnant females. There is no contraindication for breastfeeding. So the take-home points are: pregnancy is increasingly prevalent in patients with vascular liver disease and portal hypertension. These women undergo a high-risk pregnancy, at 50% risk of hemorrhage, 25% risk of hepatic decompensation. They are associated with adverse maternal and fetal outcomes. A pre-pregnancy counseling, use of predictive scores, and appropriate variceal screening during pregnancy can risk stratify these patients and improve the outcome. And you need a multidisciplinary approach to manage these group of patients. Thank you very much.
Thank you, sir. So the topic is open for discussion.
Can I ask a question? Yes. Excellent presentation, Dr. Darij. So I think you missed out on the largest study on pregnancy from India. So in Budd-Chiari syndrome. So this was Abhishek Sadalaga's study from KEM Hospital. 80 pregnancies, and they showed that it was 100% safe for the mothers, so zero mortality, and more than 50% of the pregnancies were successful pregnancies for the fetal outcome. So the fetal outcomes were modest. So this was published in Liver International in 2017. 80 pregnancies, which is greater than all other published papers put together. Budd-Chiari.
Yeah, patients in the second trimester of pregnancy who has been on warfarin, they present to you. How would you counsel them? Is there any question of advising abortion to such patients?
During the first, I think in pre-pregnancy counseling, preconception counseling, they should be told that.
In real world, we do see patients who present in the mid-second trimester.
I think before 6 weeks, they should be switched over to LMWH because there is a risk of teratogenicity.
My question is, if they present in the mid-trimester, will you advise them abortion? Because fetal embryopathy is pretty common when patients are on warfarin.
Can I answer that question?
Yeah, please.
So basically, you can do an anomaly scan at 18 weeks. And if the anomaly scan is clear at 18 weeks, you can actually ask them to continue the pregnancy. So this is recommended also. But if you find that and of course, the mother has to understand the risk of being on warfarin. So many of these are not really fatal malformations. So once they understand all the risk, then a combined decision can be taken. Up to 20 weeks is what is legally allowed. So there should not be a problem. even up to 20 weeks.
Thank you.
Is IVF going to make any difference in IVF and Bacchiari?
Pardon?
IVF and Bacchiari.
IVF, I think if there are no other contraindications, should not be a problem.
So this is an ongoing study actually. Again, one of the Waldeck studies, multicentric, where assisted fertilization in patients who have Budd-Chiari syndrome and prothrombotic states. The interim analysis was presented recently around 2 months ago, and it has been found to be safe as long as sufficient anticoagulation has been maintained in these patients.
So one thing that Dr. Sunil, about non-selective beta blocker in a pregnancy. If suppose patient is taking carvedilol before conception, whether will you continue that carvedilol or will you stop it?
I think it's a.
I think we should
yeah.
continue. The risk as compared to non-selective beta blocker.
Yes, it is higher with carvedilol compared to propranolol. So given the choice, they should be on propranolol. But if they are already on carvedilol, and I think they can be continued on carvedilol.
That's what we, yeah.
Yes.
So, sir, is there any data regarding use of DOACs in pregnancy?
Use of?
Direct acting oral anticoagulants?
No. No. They should not be used.
Good presentation, Sunil. I don't know, we used to see about 30 years ago Budd-Chiari patients following pregnancy, and now
Yes,
we
sir.
don't see.
Yes,
So, I don't know what is the mechanism, what is the reason. Ajay, you would bear me out.
I think this is from your institute only, sir.
Yeah, and I think it used to be very common
Yes.
that time, but now hardly we see these cases. I have no explanation for that. Pregnancy is a hypercoagulable state,
So what literature says, around 28% of them, if they have procoagulant state along with pregnancy, there is a risk of BCS. So one disorder with procoagulation, and then pregnancy, there is a risk of BCS.
Yeah.
Without that disorder, there is a risk. I don't.
That's right. So we don't have an answer, although we did all the procoagulant workup that time. None of them turned out to be positive in them. Well, I think we need to close the session. Thank you very much, Sunil.
Thank you.
Thanks to all the speakers and my co-chairs for a wonderful discussion and wonderful talks. Thank you.
Swami Dispur Hospital, Guwahati. Dr. Pankaj Puri, Fortis Escort Liver and Digestive Diseases Institute, New Delhi. Dr. Charles Panagal, Astricity, Kochi.
Next talk will be by Dr. Ashok Chaudhary, who's from ILBS New Delhi. He's a well-known person. I really don't need to introduce him. Dr. Chaudhary, please.
Thank you, sir, for your introduction, and also at the outset, I thank INASL and the whole team for this opportunity. So this is a little bit difficult topic for me, I can say, and a huge area. So just I tried to give the justice. I think most of the fellows are there. We need a little bit of introduction rather than a lecture. So we know a person comes to you when you go for a routine screening, HPS or anything, they have a hypoxemia. So what are the things we should think of? First is ascites, hydrothorax or anemia. If you think, then comes the HPS, which is up to 1/3, POP is little 1/10 is possibilities, and some particular disease where you find the lung issues in association with the liver disease, and they are not immune from systemic diseases. So at the same time, you have to think of heart, lung, and infections too. And as we have discussing in this area, but as we see the patients, we have to see all the spectrum for a cirrhosis or a person with portal hypertension in a broader terms, because we see also without cirrhosis. And they typically present like this: a person to you who will have a very visible spider navi, he is having cloving, and you may get some cyanosis. And you can see that the color change in the skin and nails is very sensitive in the clinic, and may be sensitive to suggest you thing in the line. And portal hypertension, spider nevi, cloving, and if your HPS is most likely you are done the diagnosis of HPS in your clinic. And these are the few can say the disease which are more you can find in relation to hypoxemia to have a HPS, which I'm not going in detail. And then why we need to think of HPS in the natural history of cirrhosis. As we discussed, nearly 1/3 of the patients who are likely transplant candidate, they may have HPSs diagnosed or incipient. And the survival goes drastically, and you can see the transplant survival without intervention is only 23% in a cirrhosis. And there is a PO2 decline 5 millimeter per year. This is a very interesting thing that you see there is a decline of the times. And if they got transplanted properly, the survival is nearly comparable to the non-HPS indications. And what is HPS? It is the three triads. You can see it is establishment of IPBD, intrapulmonary vascular dilatation. You have to see that there is hypoxemia is established, and there is diagnosis of portal hypertension with or without liver disease. And this is how we go for the most common gold standard will come subsequently is the contrast echo. Then we see that a alveolar gradient of more than 15, or when there is elderly we go up to 20, and for which we need a AVG analysis. So this is what needed for the diagnostic confirmation of HPSs is there. And as we see the cirrhosis, there is two things going on. One is systemic circulation and is cardiopulmonary circulations. And you see there's two paradox. In a cardiopulmonary circulations, you can see that there is changes in hemodynamics, but these people have a relatively preserved systemic hemodynamics, and most of the HPS patients are relatively preserved as far as cirrhosis child ABC is concerned, whereas the systemic circulation goes parallel to the liver disease severity. More is decompensation, you get more systemic hemodynamic derangements, particularly vasodilation. And in case of pulmonary, we get three things we can see here. There is diffusion perfusion mismatch, and there is a shifting from right to left. And this is the intrapulmonary vascular dilatation for which ENOS is a pathophysiology, and there is alteration in the endothelial functions. And then this leads to two ways you can see of type 1 or type 2. There is one is presence of perfusion defect, that is because of ventilation perfusion mismatch, and another is existence of a shunt artery bypass, that is anastomosis, you can say like that we can see. And the mediators for this intrapulmonary vascular dilatation are is increase in the dilators, these are the various products we can see which goes on, and decrease in the vasoconstrictors, that is angiotensin or prostaglandin F2. So these parallel of the systemic cytokines is there. So these are can say common thing, most commonly targeted for the therapy is the endothelin, it is the ERAs, it is the cytokine stimulation set, and the proliferations. And now it is considered to be originating from the gut. Everywhere we discuss about the gut. See, the endotoxin is considered to be the primary mediators which causes release of toxins to the systemic circulation, and they get preferential to the pulmonary. That leads to the changes in hemodynamics as we discussed, leading to the dilatations. Hence, we think that it is an inflammatory excess in a person of cirrhosis, and there is analysis of the various particularly S10, and recent evidence is coming on ANXA. So these are the parameters which shows a parameter change, liver injury, TNF alpha, and changes in the vasoconstriction, vasodilation balance with pulmonary circulations. And now it is now reconsidered the sphingosine. Sphingosine, which know it is a normal phenomena, is present in the blood, and this prevents this mismatch of the transfusion across the endothelium, and its receptor is S1P R1 and R2 to R4, and they are basically vasoconstrictors. And this is a study from ILBS recently published in JHEP this year, where says so that as we see the HPS, the PO2 decreases, the sphingosine is decreasing, and this is also shows a parallel correlation as the HPS severity is there, S1P is also decreasing, and it's likely a candidate for therapy. And similarly, why not all persons who are prone to develop HPS? We see everyone is getting HPS, so there is little bit of genetic predisposition. This is few studies shows for about 21 SNPs are related to these groups. Then after knowing this, that these are the risks, then how we evaluate in clinics. This is a very interesting that in OPD, simply pulse oximetry is nearly equivalent to PaO2 and calculations, and you can see ABG is difficult, particularly in cirrhotics or in OPD. But when there is saturation cutoff 96% or below, means 97 and above, it is okay. If it is coming down, it is a very sensitive marker for this, but is having a more of its limitations. Then ABG we do need, and that is how the gradient and the PO2 has defined needed for the diagnosis. Then next is to calculate the IPBD. I think we have discussed about these three modalities, that is bubble or the saline contrast echo, macro aggregated albumins and angiographies. And I think everyone is aware of this technique, and this is the most common should be considered. And then this perfusion scanning we do with micro aggregated albumins, and this normal abnormal is more than 6%. And this is quantification, and in all severe HPS for the transplant we need this. And then another interesting that in our ABG you calculate a PO2 by PaO2 ratio, and this is also shows a significant correlation to the shunt, and this value is very easy to calculate 0.528, 0.25 or less than 0.25, and this is also parallel to the MS shunt fractions. So simple ABG can tell three things: saturation you can get, PaO2 can get, gradient you can get, and a ratio you can get. And irrespective of the position change also you can diagnose a HPS with very accuracy. Then angiography, what you can see here, just see the diagram. Here this is the type we see normally, that is the type 1 and is most common, and this is type 2. This type 2 is the direct shunt between the pulmonary arteriovenous communications, which are the potential candidates to go for angioablation. Hence, any cirrhotic person or any person severe HVS who is compromised, there needs to be a pulmonary angiography just to rule out this, not for the diagnosis. If it is there, you can help by doing angioembolization. And obviously, I am not going, this is the severity we discuss. Then why you need any persons, particularly in a transplant center, if I think most of there, we think that some persons are not fit to go for the transplant, and that is on the PaO2. If your PaO2 is going to below 50, there is a increase in mortality irrespective of the transplant related services grafts you can go, and is close to 45 to 48. So below 50 PaO2, even they getting reversed on oxygenation, are still high risk for the post transplant complications. So how to offer a transplant, and before transplant there is a basket of therapies we consider, because transplant is, we know it is definitive, but the most problem in a public sector hospital is that this person relatively preserved as far as the liver synthetic function is concerned. If you tell them to go for a transplant, it is very difficult to convince. Same happens for the SCC also. So here we need that, we need counsel, you suggest, at the same time how we can go for the managements. This is the pentoxifylline we give, but pentoxifylline is the biggest problem is that despite you are using rampantly, data are very limited, results also limited, and tolerance or side effects happens nearly half of the patients. Then most commonly you use the garlic. The garlic is the drug which has component is this one, I forgot the name, it is Allium sativum. The composition is aluminate bismacylate. So this is basically a IPBD, pulmonary vasoconstrictor, and this is only one RCT, this is also from India, from Calcutta, which so they have been good response. So I think garlic is a common in our diets we can give. Now it is comes as garlic pulse to give, and now because we thought that the gut is the pathogen for HPS, now rifaximin and norfloxacin are coming up. Limited studies, you can see one patient publication, 11 patients, they shows some improvements, but this is a food for thought that gut microbiome modulation can be a futuristic therapy for the group of therapies. Then what we discussed previously is the finding any drugs. So this is a SPR1 analog fingomolet. So it is data from ILBS. We have seen that CRT patients are nearly comparable, but when you go over this sphingomyelin level is decreasing, and this is EV. EV is extracellular vesicles. So these extracellular vesicles are increased. So when you see that a person of HPS mild, moderate, and severe, the oxygenation is going down, the EVs are going up. So the basically now the concept is that whether this EVs can be considered as a vehicle or the cargo, and this drug fingolimid can be used. So this is where, so this is a proof of concept experimental study in HPS. If sphingomyeloprid can be used, it is already a repurposing drug, and it is cargo with AV for a therapeutic option, and it holds promise for the future. If we treat them, how will assess the response? This is, we have to see that PO2 has improved or if his response is low, and this will guide to you for the future therapies. Then comes the tips. Tips data is only 2009. I think after that is not there. They thought that they cause a preferential systemic redistribution of the circulations to helpful, but most of the studies are not considered to be a routine. However, it is a suggestion for all. Then we have done pulmonary embolotherapy, as discussed, it may help or more. Then comes most of the transplant. But before considering transplant, we have to see that when, whom, how to manage. These are the more important things. The transplant has outcome before 2005 is poor. It is after 2012 there is a improvement in transplant related survival for HPS is compared to those with non-HPS, and this transplant has led to 80% reversal of in a period of 15 months. And this paradigm shift, before considering, we have to think that these people are a different pathophysiology. They are more prone for the fluid overload and cardiac symptoms, and these persons we need to go for transplant outcome only with his proper selection and management in critical care, particularly the yearly extubation protocols, and this chance has leads a dramatic improvement over the times. And then with this, I think we know that is smelled exception. This smelled exception is like this: when you calculate the 96 saturation in the routine, then go to HPS, then calculate the PaO2, then follow and go for this. And this is smelled exception criteria. I think everybody aware of coming down. And they need in follow-up, their meld points every 3 months to be revised and added 2 points to be considered, and still it is data quite old and is followed for HPS. So when you think of LT, the real life problem is the lymph node transplants. We need that how to go for, but disadvantage, the study shows that they are more prone for little bit of biliary complications and also vascular complications the higher side in this group of patients, and they suggested that pre-transplant oxygenation should be considered as a risk factor and that can help in a better outcome. So with what we have discussed, nothing much has changed in HPSs over the last 10 years. It is time to think of considering an important area for your investigations and research publications. And with this, I think we are not able to go for POPs if time permits, and otherwise I'll close here for the discussion. Thank you.
Thank you, Dr. Ashok. Any questions from the audience?
Is there any role for fecal transplantation?
I think fecal transplant has not been considered for any treatment till now. Even alcoholic hepatitis still on the called as emerging therapy or experimental therapy. And the concept of gut microbiota for the HPS, as we discussed from the rifaximin or fluoxetine. So it may be whole future, but that is only to the research domain and experimental therapy in a limited settings, not routine.
How much garlic and how long we should give?
Calorie.
Garlic, how much and how long?
Garlic, consider is the two terms. One is you can give the straight way which you are using, and now it is coming as garlic pulse. The pulse is concentrated one which contains the active ingredient of this, and we usually give 2 pulse thrice daily, but I don't exactly know the dose, but we write this is way that it should be given 3. And most of what we have experienced in practical is that we add to them rifaximin or norfloxacin, so they may be having a dual action. So this is, you can garlic pulse with rifaximin as a good combination.
Thank you, Ashok. That was nice. And we'll go on to the next talk. The next talk is by Dr. Uday Zakaria. He'll be speaking on liver and IO. Have I got it wrong? Uday's not here. Dr. Rohit Gupta. He'll be speaking on sleep disorders in patients with cirrhosis. Sleep is always a major issue, and patients keep coming to us, and we are concerned about giving them sedatives. So,
thank you,
Rohit, please.
Chairperson. At the outset, I'd like to thank Professor Ajay and Team INASL for giving me this opportunity. So it has been a great conference. This is the last talk of this INASL 23. And in next 12 to 15 minutes, I'll be talking about this topic, which is not commonly discussed in conferences. So what I'll do is briefly talk about classification of sleep disorders, common sleep disorders which are encountered in liver disease, briefly discuss about pathophysiology, how do you assess, and treatment guidelines are not much, so briefly we'll talk about treatment. So whenever you ask a physician or a gastroenterologist what are their concepts of sleep in liver disease, so one answer is alteration of sleep-wake cycle. So this is the most common answer residents are going to give in ward rounds. If you ask majority of gastroenterologists, so they know about association of hepatic encephalopathy and sleep abnormalities. Now, the reason is this is not got so much of importance is because we as hepatologists are more involved in medical management of because there are a lot of medical problems with these cases, and we do not really give focus on quality of life, and we know that sleep is an important aspect which determines the quality of life of these individuals. So this was first described by great Sheila Sherlock in 1954, where she described sleep-wake abnormalities in patients with hepatic encephalopathy. And studies have shown that it has a significant impact on health-related quality of life. Now, why do these patients have poor sleep? They may be having pain, they may be having ascites, abdominal distension, poor sleep hygiene, medications that interfere with their sleep. Some patients are given diuretics at the bed in the evening, and then they have to go to washroom, so there is frequent sleep interruptions. And patients of primary biliary cirrhosis, we know, have pruritus and fatigue, which can lead to sleep abnormalities. And there is no routine protocol for evaluation of sleep in these patients. So this is a classification of sleep disorders, which has been given by International Classification of Sleep and American Society of Sleep Medicine. So on the right side, you will find that there are 7 groups of disorders. And on the left, on the right, some of the classical disorders which we see. So insomnia is the most common disorder, and the classification is chronic insomnia disorder. Sorry. Then sleep-related breathing disorders include obstructive sleep apnea. Circadian rhythm disorders, the classical which we see is jet lag disorder. Then there are parasomnias, sleep-related movement disorders, the classical of which is restless leg syndrome. Then central disorder of hypersomnolence, which is narcolepsy, and then other non-specified sleep disorders. Now, what are the most 4 common phenotypes we see is, of which insomnia is the most common, then excessive daytime sleepiness, restless leg syndrome, and obstructive sleep apnea. So how do you define insomnia? We all know insomnia is defined as difficulty in initiating or maintaining sleep. So cirrhotic patients, they have a lot of issues with insomnia. So as my previous slide said, this is the most common sleep disorder. So what happens is they have difficulty in falling asleep. They have frequent nocturnal awakenings. They have fragmented sleep. And it results in impaired sleep quality. And if they do not sleep well, they have impaired daytime functioning in form of fatigability in the daytime, frequent sleepiness in the daytime. Now, what we need to understand is that insomnia has no relation with severity of cirrhosis. And this has been beautifully documented in patients with chronic hepatitis C without cirrhosis, where in comparison to general population, they tend to have more sleep abnormalities. So this was one of the, some work in sleep has been done by our group from AIMS Rishikesh. So this was a study which published in 2020 in 131 subjects of chronic liver disease. Majority, 50% of these were alcohol use disorder. And using Pittsburgh Sleep Quality Index, what we could found was that poor sleep quality was seen in around 37% of patients, and 20% of patients reported insomnia. Now, second most common disorder is excessive daytime sleepiness. Now, this is classically associated with hepatic encephalopathy, where we know that patients of hepatic encephalopathy have inversion of sleep-wake cycle. They have excessive daytime sleepiness, and they have nocturnal awakening. And as the severity of cirrhosis increases, so child C patients will have more inversion of this sleep pattern. Now, obstructive sleep apnea has been classically defined in patients with non-alcoholic fatty liver disease because they share the common metabolic pathway. These patients are obese, they have associated fatty liver disease. But we need to understand is that there is some data to say that obstructive sleep apnea perpetuates fatty liver disease, and the fatty liver disease perpetuates obstructive sleep apnea. So what happens in fatty liver disease? So obstructive sleep apnea patients have chronic intermittent hypoxia. Now this chronic intermittent hypoxia leads to multiple hits. It leads to hypoxia reperfusion injury. It leads to ROS mediated damage. Then there is overexpression of hypoxia induced fibrogenic factor and endothelial injury. Apart from that, hypoxia also leads to lipolysis and increased fat accumulation in the liver. So this is a recently conducted study which we have sent for publication. It's under review. So where we use, this was done during COVID time, so our participants were less. So what we did was took group of OSA and then looked for prevalence of fatty liver disease and looked for factors in those fatty liver disease which were being contributed by sleep and development of fatty liver disease. And we found that oxygen desaturation index, these are index which we calculate using polysomnography, apnea hypopnea index, and T90 index, which were associated with presence of steatosis and fibrosis. Our group has done some work on this entity also. This is called as restless leg syndrome, also known as Eichbaum syndrome. Now, a lot of time in our clinical practice, we get patients who come with complaints of nocturnal movement of and they have frequent urge to move their lower limbs. So it manifests as the urge to move legs or other extremities during rest, and it may be associated with unpleasant or painful sensation. It's a relatively recently described entity, first described by Franco in 2008, and it is diagnosed using this International Restless Leg Syndrome Study Group 2012 criteria. So the important thing is there is an urge to move legs, which may or may not be accompanied by painful, unpleasant sensation. It gets improved with movement, but last point is important that you need to rule out other disorders like cramps, edema, arthritis, and deep vein thrombosis. Excuse me. So a lot of work has been done in this RLS group, and the highlighted studies are from India. So this was a study which was done by SGPAGI group by Dr. Amit Goel, where they found the prevalence of RLS in liver disease in around 6.6% of patients. One of the studies has been from Rajasthan, and the number 9th study is from our group. So in the same cohort, where we looked for prevalence of RLS, and our prevalence of RLS was 19.1%. So then we did a systematic review. This was a multi-centered review, and the pool odds ratio of development of RLS was 8.62. So with this background of common sleep disorders which are encountered in patients with cirrhosis, so it's not only excessive daytime sleepiness, there's a whole spectrum of sleep disorders. So briefly, I'll briefly discuss about pathophysiology. So sleep is regulated by two processes. So there is one circadian process, which has a 24-hour periodicity. Now this is regulated by a suprachiasmatic nucleus, which is located in hypothalamus. So this leads to circadian variation in the melatonin. So melatonin is a neuroendocrine marker for sleep. Then there are circadian variation in cortisol, and there is circadian variation in core body temperature. Now this circadian variation, it is dependent on the light which gets thrown into the retina, and these pathways goes to the suprachiasmatic nucleus. Now this is the first part of the sleep regulation, and the second part is the homeostatic process with increase in sleep propensity with increase in wakefulness. So a person who wakes up at 7 a.m. and sleeps at 11 p.m., so his propensity to sleep will increase as the day progresses. So this is a very natural phenomenon. So these are two processes. One is circadian rhythm, another is the homeostatic process. So the top panel A tells you about the normal process. Now I'd like to bring your attention to the bottom line where the 23 means 11 p.m. So this distance is maximum between homeostatic and circadian rhythm is maximum at 11 p.m. normal individual. So more the distance between these two lines, the better is the sleep propensity. Now what happens in patients with cirrhosis, because of melatonin metabolism abnormality, this circadian rhythm graph tends to move towards right, and this distance decreases. So these patients tend to have delay in sleep onset, and they have frequent nocturnal awakenings. And this panel C tells us about what happens in patients with hepatic encephalopathy. So there is abnormality in circadian rhythm, there is abnormality in homeostatic pattern, and these patients they do not sleep well in night, and they have excessive daytime sleepiness. So with this background, how do you assess these patients? So subjectively, what you can do is you can use a sleep diary. So what does a sleep diary does? It tells the patient comes with the information at what time he's sleeping, how many times he's awakened, when he gets up in the morning, is he feeling fresh? Is there an episode of excessive daytime sleepiness? But then the problem is it's very subjective, and for studies it's not very useful. Then this is the questionnaire, which is the standard, which is called as Pittsburgh Sleep Quality Index. So it comprises of 7 domains with a score from 0 to 3 with a maximum score of 21, and any person scoring more than 5 is considered as poor sleeper. Then we all know about this Epworth sleepiness scale, which is measured in patients with sleep apnea, with obstructive sleep apnea. So it works, so it comprises of 7 domains. So in daytime, while sitting, do you feel asleep? While sitting in a meeting, like a liver meeting, do you feel asleep? Or have you slept? Are you snoring during these times? So on this basis, there is a score which gets calculated, and any score more than 5 is considered to be significant. So these are subjective methods. Now, objective method is the gold standard for studying sleep is this test, which is called as polysomnography. So for this, the patient requires admission. He gets attached to a lot of monitors. So you measure the electroencephalogram, you measure the eye movement, their muscle activity, their heart rate, and their oxygen saturation. And on the basis of this, a lot of indexes like apnea, hypopnea index, T90 index, a lot of indexes are calculated. But the problem is for this patient requires admission, and patients of liver disease may not be suitable. A lot of these patients will not be able to undergo this test. So this is a semi-objective method, which is an actigraphy. So this is a wristwatch-like device. So the basic premise is, if the person is sleeping, then there is no movement, and if the person is awake, there is movement. So it measures movement of body part of hand in relation to sleep. Okay, So I'll quickly finish. So once the person has complaints of sleep, that he is complaining of difficulty falling asleep, frequent nocturnal awakening, excessive daytime sleepiness, EDS should make you think for hypermonemia, inquire about their sleeping patterns, look for comorbidities. If there is obesity, look for OSA, look for additional investigations like daily sleep diaries. You can use questionnaire, and you can subsequently go for objective test. Now, coming to the treatment, so I'll take one more minute.
Take in a couple of minutes.
So non-pharmacological treatment is improving your sleep hygiene, progressive neuromuscular training, taking a warm sponge bath or foot bath before going to sleep. And so there's not much good data available on majority of these approaches. Like there is one case report which has been described in literature where exposure to light in the daytime and has shown improvement in sleep. Now, for pharmacology treatment, we know that for hepatic encephalopathy, lactulose and rifaximin is used. Rifaximin has shown using objective parameters of polysomnography to improve variables of sleep parameters. Now, what about, this was the question which Sir had put before start of this, use of sleep agents. So benzodiazepine agonist contraindicated because it can tend to precipitate hepatic encephalopathy. There is some data that zolpidem can be used at a low dose, especially in patients with childhood cirrhosis. 5 milligram for 4 weeks is to be safe, effective, and well tolerated. Continuous positive airway pressure therapy is an important treatment for patients with obstructive sleep apnea. And RLS, the pathophysiology is some abnormalities of iron metabolism. So iron supplements if the patient has associated iron deficiency anemia, and those patients who do not respond to that can be treated with pregabalin. So I'll conclude my presentation by saying that there is a better understanding of these abnormalities as they are high prevalent. It's more than just hepatic encephalopathy. There is a bidirectional relationship, no well-defined therapeutic strategies, and there is need for further studies. Thank you. Thank you all for your patience.
Thank you, Dr. Rohit. A couple of questions from me.
Yes.
One is any role for melatonin, and second is alcohol withdrawal. Patients often come with restlessness, lack of sleep. What would be your choice in those patients?
So melatonin, we need to understand what happens in patients with cirrhosis in terms of their melatonin metabolism. So normally what happens is how melatonin gets secreted. Melatonin secretion increases as the night increases, and it peaks during midnight. Now in patients, and then as the light increases, the melatonin levels falls. Now in patients with cirrhosis, because and melatonin gets metabolized through liver, these patients have increased level of melatonin. So the studies haven't shown much benefit of use of nocturnal melatonin. So currently it's not recommended. Second question here was on patients with alcohol withdrawal. So alcohol withdrawal, the treatment of choice is you use lorazepam in these patients. And if then in alcohol withdrawal, then it's important to understand that what is their baseline liver. It's extremely difficult, important to differentiate.
Child C. Let's say child C cirrhotic with alcohol withdrawal.
So child C cirrhotic with severe alcohol withdrawal, you need to give lorazepam, but these patients will have higher incidence of sedation, and their sedation takes longer time to come out from their sedation.
Any choice between chlordiazepoxide and lorazepam?
So chlordiazepoxide will never be used in acute setting. In acute setting, you have to use lorazepam, but in long term, in child C cirrhotic, it will be extremely difficult for you to use any benzodiazepine.
Questions from the audience, please.
Can the baclofen can be used?
Baclofen for sleep.
For withdrawal, alcohol withdrawal.
Baclofen can be used, ma'am, but as far as sleep is concerned, there is no data to suggest its role in promoting sleep in patients with liver disease.
Very nice talk, Rohit. I think a topic which is not very commonly discussed, thank you. So I just have a comment about the work which we had done. You mentioned about OSA in NAFLD. So this we had done around, I think, 9-10 years back and published in 2015.
Yeah, JCH.
Yeah, not JCH. This was in the Hepatology International.
Okay.
So we had taken two groups of patients. One was 100 patients with NAFLD, and we assessed historically for the symptomatic OSA in them, and we found only 3 of them to be positive, which means the prevalence of OSA in NAFLD was 3%. And the reasons were, other than the male gender, it was obviously the obesity which was responsible. But what we did, another thing was, we actually went to the chest people and we requested them, and we got 23 patients of proven OSA on polysomnography. And then we assessed NAFLD in them. And what we found was 91% of them had fatty liver. The OSAs, the prevalence of fatty liver was very high, 91%. The prevalence of OSA in NAFLD was only 3%.
3%.
And then in the OSA, when we looked at their liver disease and the fibroscan and the correlated OSA, the hypopnea-apnea index, which you said, that was actually correlating with the liver disease severity.
Yeah.
So which actually means, which you said, it does increases your severity of the liver disease, the degree of the OSA. So fatty liver is very common in OSA, number 1. And the severity of fatty liver is assessed by the severity of OSA, number 2. And as I said, the prevalence of OSA is not very common in NAFLD, but would depend upon your body weight and
So our data shows 67% of fatty liver in OSA patient population.
Excellent talk, Dr. Rohit.
Thank you.
A practical question: if a cirrhotic patient comes to me with lack of sleep and he is obese too, so what are the investigations you would advise us to do at that point? Would you advise us to do an EEG along with, of course, the routine parameters for cirrhosis would be anyway done, the lab tests, but would you advise us to get some sleep studies and EEG also in the armamentarium?
So,
because sleep is a very ignored part of our clinical practice. When the cirrhotic comes to me and says he's not sleeping, most often I presume it's hepatic encephalopathy. But studies are coming in with other factors being involved in this. So how would we approach practically if in the clinic?
Yeah, ma'am, your comment is well taken that sleep is an ignored part, and that's why I'm thankful to Professor Ajay for giving this opportunity. So, cirrhotic patient who is obese will possibly have an element of obstructive sleep apnea. So then you can have objective measures and subjective measure. So subjective measure, Epworth Sleepiness Scale, is a very simple scale. It can be downloaded on your mobile phone, and you can apply it in your OPD directly. And then you need to undergo, these patients can undergo polysomnography. Now, polysomnography has an EEG done in it. So there is an EEG, electromyoactivity, and electrooculogram. So then that gives you will tell you about episodes of apnea and hypopnea if your patient has underlying OSA. Now, there is some data to suggest that if these patients are treated with continuous positive airway pressure, then these patients can improve. So in this study where we have done this, our second part is going on where we are trying to find out that 1 year use of CPAP in these patients, how will their profile change?
Thank you.
Yeah.
Thank you, Dr. Rohit, for waking us up on sleep disorders.
Thank you
very
sir.
much.
So that was a well put remark, sir. Okay, so requesting all of you to kindly be seated. We will be announcing our valedictory rewards in just 10 minutes now. It's a very important session to be. Half an hour more we want from all of you. Please be seated, and we'll start in a short while. So, requesting all of you to kindly be seated for the next half an hour. We are about to start our valedictory ceremony. So, as every literature lover's favorite William Shakespeare says, all wells that ends well, we have reached towards the end of the journey of INSL 2023. What a marvelous journey this has been! An experience, learning, and everything was under this one roof. That feeling itself of being around stalwarts across globe was thrilling. So let's start with the valedictory ceremony. I'll request our esteemed President, INSL Professor Dr. Shivram Prasad Singh, Chairman Kalinga Gastroenterology Foundation, to please join us on the stage. Requesting Professor Dr. Dr. Ajay Duseja, PGIMR Chandigarh, Secretary General INSL, to please join us on stage. Dr. Pankaj Puri, Director of Gastroenterology and Hepatology at Fortis Escort Liver and Digestive Disease Institute, Okhla, New Delhi, to please join us on stage as well. I now request Dr. Ajay Duseja to do the honors.
So, good afternoon, everyone. Before we say a big thank you to all of you, I think it's time also to give away the prizes for this meeting. And thanks to all the participants for their, very active participation, I must say. So we've had few sessions for which we'll be announcing the prizes: the plenary session, young investigator, posters divided into two, clinical and basic sciences, and then we have prizes for the quiz. So the prizes are: the first prize is rupees 15,000, a certificate, and we are also giving 1 year subscription of Elsevier's Clinical Key, which is a new thing which has come up on Clinical Key now. So, and the second prize is, again, a key will be given to everybody, all the prize winners, the Elsevier's Clinical Key now. The second prize is rupees 10,000 and the third prize is rupees 7,000. Please check the spellings on the check which we'll be giving, and be sure to get these corrected now, otherwise it really takes time. So now I'll request our president and the treasurer to please come here and do the honors for us. So, plenary session, any guesses? First prize? No guesses. The first prize goes to Dr. Swagta Majumdar from Kolkata. Is she around? Yes, come, Swagta. This was a work on that knockout genes in HCC. Congratulations. Well done. Come, center of the stage. Please give that clinical key also and the check also. Where is the check? Please don't forget to collect your check, right? I think this is the clinical key and the certificate. The checks are on the way. He's writing the names. Please correct your check. Thank you. The second prize in plenary goes to Dr. Manas Vaishnav. I'm forgetting your work was on 1 day versus 3-day terlipressin in patients with GIB. This is from All India Institute of Medical Sciences. Well done. Congratulations. Don't forget to collect your check, please. Your check needs to be collected from Mr. Deepak, who is the INASL coordinator. Okay. The third prize in the plenary goes to Dr. Ashish Kumar for his work on the ARC, consortium, which he had done the MAFFLD and the ACLF thing. Is Dr. Ashish there? No, anybody from Gangaram there who can collect check and prize on his behalf? Anybody from Gangaram? Yes, please come. So certificate, clinical key, and the check you need to collect from Mr. Deepak. What's your name? Mahmood. Imad. You were doing DNB? Yes. Okay, please come. So now we invite the winners of the Young Investigator, which happened today morning. Uh, Again, the first prize for the Young Investigator, any guesses? Goes to, oh, sorry. Before we go on to the plenary, we as a from the governing council, we also give prizes whosoever presents in oral session, which is the plenary and the young investigator. So we have prizes for the other two presenters in the plenary session. Dr. Nipun Verma's work, which was presented by Dr. Pratibha. Are you here, Pratibha? I think no. And Dr. Ashrita. Are they there? They can collect their certificates then. Okay.
वो तो आप ले लो
ठीक है रख लेंगे
निपुण का
हाँ वो निपुण वाला मुझे दे देना the young investigator the first prize goes to Dr. Sonu Kumar. Again his work in HCC, the liquid biopsy using DNA methylation marker in patients with HCC from All India Institute of Medical Sciences, New Delhi. Congratulations, well done. The second prize goes to Dr. Hiteshi Thamit Shah from Global Mumbai for a work on sarcopenia as a determinant of outcome in patients with liver transplantation. Well done, Hiteshi. Congratulations. The third prize, good. The third prize in the Young Investigator session goes to Dr. Bilal Ahmed Mir from IGMC Shimla for his work in vitamin E with or without saroglitazar and lifestyle interventions in patients with NAFLD. Is anybody from IGMC Shimla here? Dr. Bilal, you're there? He's a friend. Come. These two prizes. The other two presenters in the Young Investigator also get the certificate for presentation in the Young Investigator. Dr. Aditya Verma, if you're there, please come. And Dr. Prabir Maji also, you also get a certificate for presenting your work in the Young Investigator. If you are there, please come. ये आदित्य का है, ये दे दो, ये रख लो. ऐसी भी गई है, कटक है, ठीक है. So they get a certificate and the clinical key now from Elsevier. 1 year subscription for that. The prizes for the poster session were divided into two categories. Clinical, we had the maximum, participation. So 5 prizes for clinical posters and 3 prizes for basic sciences. The first prize in the clinical poster category goes to Dr. Mebam Bobby Singh. Around? No. Second prize goes to Dr. Shinoy Katie. Dr. Shinoy is there? No. Third goes to Dr. Prabha Saran Kaur. Prabha Saran Kaur. The third prize goes to Dr. Ashrita A. No. The fifth prize goes to Dr. Tara Prasad Tripathi. No. Anybody? Yes, please come. This is the fifth prize. Congratulations. You are collecting on his behalf. You can also pass on our congratulations to him. तालियां तो बजेंगी. Tara Prasad Tripathi. Shanoy, yes, yes. Dr. Shanoy's certificate also, she's collecting. Big hand, yes. Ames Bhubaneswar. Ames Bhubaneswar? Yes. Dr. Shanoy. So there were 3 prizes for the basic sciences poster category, and the first prize goes to Dr. Rohini Saha. Is she around? No. Second prize goes to Dr. Inderbhan Singh, PGI Chandigarh, hepatology. Congratulations, Inderbhan. Well done. Come. The third prize in the basic science poster category goes to Dr. Hardik R. Saha. Is he around? No. Okay. So these were the prizes for the posters, and this now the last prizes is for the quiz which was conducted, and the first prize in the quiz, hepatology quiz, goes to Dr. Naveen Bhagat, PGI Hepatology. Is Naveen there? Anybody from the department can collect, please. Ganesh. The second prize, quiz will get the checks. The quiz will get only the checks. There are no certificates. So is Deepak there? No, not yet. Deepak, check. Okay, so you can collect your check for Naveen. Let me just announce the names then. The second prize goes to Dr. Nitish Patvardhan. And is he around? You can collect your check from Mr. Deepak. And the third prize goes to Dr. Yogender, again from PGI. Is he around? You can please collect your check from Mr. Deepak. Congratulations, all of you, well done. Amongst the faculty, there are no prizes, but the highest score was by Dr. Arun Walson. So congratulations to him also. So these were the prizes from, on the sessions, various sessions during the meeting. So it is now time for us to say thank you to all of you from the Governing Council of INASL. Our first, the biggest thank you is to the local organizing committee who have done a wonderful job. 3 cheers for Odisha. 3 cheers for the local organizing committee, G20. And I'll invite every one of them to please come on the stage. All the Dr. Manoj Sahu and his team, everybody please. And
3 cheers also to the crowd who are here. I've never seen such a crowd in a valedictory session. Even in it's more than what we have in the regular sessions sometimes.
Big thank you to all the delegates, all the faculty, national, international, and everybody for active participation. Yeah. So, Dr. Sahu, you would like to say something? Yeah, please come.
So, before Dr. Sahu starts speaking and thanking all of you, there's an important message from Dr. Abha Nagral. There's a FAQ books, you can collect it from here. Thank you. FAQ books can be collected from here.
Frequently asked question books can be collected here, from here.
I Ladies and gentlemen, can I request all of you to give them a big round of applause, the team behind the scene, please. Thank you. I now request Dr. Sahu to propose the vote of thanks.
So, very good afternoon. So, I'm requesting Professor Singh to be here, my teacher, mentor, guide. So, ladies and gentlemen, distinguished guests and esteemed colleagues, as we come to the close of the INASL 2023 conference at Bhubaneswar, it is with a mix of emotions that we gather here today. Over the past few days, we have witnessed a remarkable exchange of ideas, a sharing of knowledge, and a celebration of the collective efforts that drive progress in the field of hepatology. We are grateful to Professor S.P. Singh, President INASL, Professor Ajay Duseja, Secretary General INASL, and the Governing Council for believing us and bestowing the responsibility on us. This conference has not only been a platform for scientific discourse but also a testament to the power of collaboration. Researchers, clinicians, and experts from around the world have come together to discuss breakthroughs, challenges, and innovations that will shape the future of liver health in India. I would like to extend my deepest gratitude to all the speakers who graced our stages with their insights and expertise. Your presentation have illuminated new paths and ignited fresh possibilities, inspiring us all to continue pushing the boundaries of medical science, basically in a vision of universal healthcare in India. I also want to thank every attendee who participated in discussion, including the PG students who asked questions and engaged in meaningful dialogues. Your active participation is the driving force behind the success of this conference. A special note of appreciation goes to the organizing committee, Odisha Organizing Committee, G20 members, especially Dr. Sushant Sethi, Dr. Manas Panigrahi, Devanand Mohapatra, Dr. Vijay Mishra, Dr. Pritam, Dr. Jimmy, Dr. Rajat, Dr. Pragyan, Dr. Shivam Bajpayee, Dr. Akash, and many, many names. So if I am telling names, it will take a lot of time now. So many, many names. For their tireless work behind the scenes to ensure the seamless execution of this event. Your dedication and hard work have not gone unnoticed. It will not be fair if I do not acknowledge them. To the event team, Maisa from Delhi, thank you very much from the core of our heart for your support and effort in execution of the program. Grover's audiovisual group team for seamless audiovisual support. In fact, we had multiple meetings with them. Entertainment events, especially Saraj Babu, Raj Babu, for all the wonderful art and fabrication work. Social nights, spouse journeys, special mention of Adruto Children Home, Surabhi Odyssey Group, Moirbhanj Chhau Group, where the President of India belongs, and the most entertaining, most Mr. Javed Ali. So we met him today morning also. So what he wanted to inform you or convey his message, he is extremely gratified, satisfied. He told, please convey my regards to all the doctors across the world. So in fact, we signed an agreement for 90 minutes, but he's saying for, I think, 2.5 hours. What he told, I should have some little more time. So special thanks to him. Sanjukta Travels, Mr. Sarup, Mr. Abhishek, and the team for the wonderful travel and logistic arrangement. Casa Eventos, Miss Aditi and team. So I am part of Casa Eventos family now for the hospitality, great hospitality. And when we talk of hospitality, we cannot forget the most hospitable hotel, not only in Odisha. So they have presence now across India and they are planning something going beyond India. These are the Mayfair hotels, Mayfair chains. Our venue partner for their yet splendid care and involvement in the conference. Thank you for treating it like your own. A very special mention, Chidananda Babu, Mr. Chidananda Malik, Bipradeep Babu, Sanjay Patnaik. So who are the heads of the hotel, finance heads? So they are big people, but you may not believe they were here till 2 a.m., 3 a.m. very silently, seeing that things are done very perfectly. They had multiple meetings, training and execution, how to execute, training everybody. And so one example I can give you, our first day presidency dinner or faculty dinner with Odisha culture, Odisha food. Everything was very beautifully designed by them. Last but certainly not least, our sincere thanks go out to our sponsor and partners who have generously supported this conference. And I am expecting I need their generous support also for this conference because I am in little trouble now. So I am requesting for their support also now. I have spoken to them. Your contribution have been instrumental in making this gathering a reality and we are truly grateful for your continued support. Now, in no particular order, our industry partners are Son, Zydus, Natco, Takeda, Ross, Olympus, Tatva Care, Dr. Reddy's Laboratory, Alnich, Abbott, Alchem, Olivin, Lupin, Cipla, Mylan, Torrent, Delvin, Intas, Tasmet, AAA, Mankind, Santara, Waterley, Boston Scientific, Elsevier, RB, Invig, Aries, Zydus, Corja, Nexium, MQR. I might have forgotten few names, kindly forgive me, but you are part of this meeting. I'll just tell you one truth. When we are the local organizing committee requesting the former people, so then local organizing committee requested the Honorable President of INASL, sir, kindly help us, and he helped in a great way. And Fujinom also, I have forgotten name. So we believed and felt everybody is the part of INASL and everybody supported us as the part of INASL. As we depart from this conference, let us carry with us the knowledge gained, the connection forged and the inspiration ignited. May the insights shared here led to advancement that improve the lives of countless individuals dealing with liver diseases with a mission. Can we prevent liver diseases? We have one liver, one life. Can we able to keep our liver healthy so that we can have a productive life? Thank you, INASL 2023 attendees for being a part of this remarkable journey. Let us continue to strive for excellence, collaborate with passion, and drive positive change in the realm of hepatology. Until we meet again at the next gathering, I wish you all continued success and progress in your endeavor. I might have forgotten many names, those who are directly and indirectly involved in making this conference beautiful. So we are extremely grateful to you all. And the Almighty God for His blessing. And last, my wife. So my son and my family who supported me.
Who suffered all these days.
Thank you very much. Thank you very much.
His wife, his family, his close people who supported him, and without their support, blind support, this could not have happened. And he could not express that. He broke down and they had to learn to live without him for all these days. I have never heard a more beautiful valedictory final lecture in the last 30, 35 ISG cons and INASL conference. I have not heard such a. I was wondering what he's holding in the piece of hand, but it was really touching. Thank you, Manoj. Thanks a lot. And
Sir, gifts, sir, you have to hand over, sir. Sorry.
gifts. Okay, you first give the gifts and then.
So, can I invite Mr. Chidanand Malik, the finance head of Vice President Finance of Mayfair? So, can I invite anybody from Mayfair? Biprati Babu, Sanjeev Patnaik, who is the head of Mayfair Lagoon, Biprati Babu, head of Mayfair Convention. Biprati Babu, kindly come to the stage. You may not believe the kind of effort. So I'll send you a few photographs that how they are working, the kind of training going on for the staff. Biprati Babu, kindly come to the stage. Chidanand Babu, Sanjeev Babu. So, can I have the Biprati, please? So I'll not take much time, maybe 5 minutes timer. Okay, few words, Biprati Babu. Few words.
Namaskar everyone, sir. So we got an opportunity to serve you all, and we feel proud to serve the renowned doctors and all the doctor fraternity. And we welcome you all for the next conference. Whenever I feel like to do a conference in Eastern Zone, choose Mayfair. That's all from Mayfair side. Thank you.
Now you know, now you understand how, Manoj Sahu handled things. Not only the hepatology, the G20 team, but see how he handles the human resources of the hotel and why they are working for him day and night.
So basically, I feel I am a part of Mayfair Hotel. So and I am truly a part of Mayfair Hotel. Sir, three of them, for three of them. Can I request Mr. Saraj Babu, Raj Babu and team from Entertainment Events? Can I request Saraj Babu, please? Saraj Babu, yes. Team, can you have the entertainment team who are here kindly come to the stage? So the person who is at the front, you may not believe, he is hosting G20. He is doing everything. Orissa, beyond Orissa, you may not believe, he is here everywhere, but very silent. So every time getting my scolding, still very silent. So this is a great man, the great soul, who is doing all things, impossible thing possible. Whenever asked, I want this thing to be done immediately. Yes, sir. And this will be done perfectly. Saraj Babu, can you come there? Thank you, Saraj Babu. Saraj Babu, one little bit here, like.
Thank you, sir. Thank you, all of you. And trust me, it's all about Manoj sir. हम लोग के ऊपर जितना भरोसा रखें उसको ट्राई किए हम लोग जितना कर सकते थे. Thank you.
Thank you, Saraj Babu. Can I request Grover Group, Grover team to come here? Mr. Abhishek, I think they are known now. They are going beyond nationally. They are going for international presence. So we had multiple meetings with them here, Bhubaneswar, Delhi. So Grover team, please. Thank you, sir. Can I request Grover Governor team. Can I request Sanjukta Travels, Mr. Swaroop, Mr. Abhishek and team? So Sanjukta Travels, Mr. Swaroop, this person who is like at the front, so difficult to believe, he does wonders. So he is very silent at the backdrop. He does wonders. He does wonders so that your hotels are not empty. You are not giving retention charge. So wonders. Thank you, Swaroop Babu and team. So can I call Miss Pinky? Invite Miss Pinky Jha, very silently doing her job. Very nice, extremely nice. So please come, the MC for our conference, all four days. So everybody is thinking why I am not calling MISA. MISA is the part of INASL, special mention. Can I invite CASA eventers? Aditi and team. Aditi and team. So very beautifully organized everything. Aditi, where is your team members? G20 also. Thank you, Aditi. Thank you, Aditi. Thank you very much. So let's invite Maisa. So Maisa, Miss Sephali, can I invite her and Maisa team, whole Maisa team? They are part of INASL for a long time. Long time. So Sephali, so Sephali madam, so please come, whole Maisa team. So everybody knows, because any problem, the messages are going to her. Separately to this thing, this problem, etc., etc. And she made my life little simpler. So thank you, Sepali madam. Please come. So Miss Sepali and team. So our heartful gratitude to the team led by Miss Sepali. So the team is here at Bhubaneswar for a long time. For last 15 days they are here. We try to make them comfortable. There might be many deficiency from my side. Thank you very much. People are extremely good. So a little bit, Sepali madam. थोड़ा सा तो कुछ बोल दीजिए थोड़ा. Okay. Sir, all 2 minutes. Okay. Can I invite the pharma people who are here? Sun Pharma, Zydos, Natco, Takeda, Ross, Olympus, Tatva, DRL, Alnich, Abbott, Alchem, Olivine, Lupin, Cipla, Mylan, Torrent, Delvin, Intel, Stasmed, AAA, Mankind, Santara, Waterley, Boston Scientific, Elsevier, RB, Invig, Aries, Zydos Korja, Nexium, MKR, Fuginum. And if I am forgetting few names, basically, we might be thinking pharma people are managing their gas, their stall. No. They are part of INASL. Pharma people, I've divided their work. They are at airport, they are at hotel, they are at everywhere. They are there silently, they are doing their work. Bring. Sir? Give. Bag as like bag.
बिना
Okay, thank you. So I just forgot one thing. So special gift I brought for Maisa. Can I invite Maisa? Anybody from Maisa? This is the Maisa, please. Maisa team, please. For 1 second, can you just come to the stage? Maisa team, please. So, sir, basically, Maisa is a part of INASL. INASL is a part of Maisa. So, if I'm wrong, then Dusaja sir will just correct me. So, they are here for 15 days. My job was to take care of their hospitality, but they're so good, so good. So they are doing their work very seamlessly, very silently to put everything in perfect position. So if our conference is little successful, so the very good credit goes to MISA team. They are working for last 2 years for Bhubaneswar 2023. And for last 15 days, they are in a very small hotel, very lots of problem in that hotel. Food is not there, electricity is going, and very difficult. And with all difficulties, they supported the local organizing committee. With all difficulty challenges, they are here for last 15 days and they're supporting us. So from our side, from Professor Singh and the local organizing committee, so we are grateful to Maisa and team. So Professor Singh and Professor Duseja are requesting both of them, both eminent personalities, to hand over a tribal art to everybody. So any MISA team, whom I'm forgetting, any MISA team? तो सर एक सेकंड सर आपको तो कुछ बोलना है आपको कुछ you have to tell something you cannot go without that sir tomorrow my job is to take care of their hospitality मैं थोड़ा उनको लेके जाऊंगा भुवनेश्वर पुरी कर्नाटक that is my job now because I am free completely so Shefali madam please.
I am always very particular about time, so I was saying we're running out of time. That's why I just said thank you. But since I have to speak, I hope Dr. Sahu, he had a dream and a vision in mind for INASL 2023 at Bhubaneswar. And he just told me, this is my dream and this is the way we'll go about. And we spent a lot of time. It's been over a year now that we've been talking and working. I hope, sir, that your dream came true.
Thank you very much. So God bless you. So let me associated with as long as we are alive.
Oh, that's
Thank
so
you, thank you
sweet.
very much.
So,
The
but did your
last
dream
word,
come
the
true?
last word. I'm just want to thank Professor Joyant Panda with the sir, President API chapter. Okay, okay. So Professor Joyant Panda, who is the President of API Odisha chapter. So I spoke to him, I met him, discussed with him. Can we do a physician program that went on very beautifully because of his support and the complete API team support. So Professor Jayant Panda, please.
I invite Dr. Chotra here. Actually, I'm the immediate past chairman, API Odisha. Dr. Manoj Chotra is here, our chairman of the API Odisha. Sir, please come. Uh, it's a pleasure being part of this national events. Uh, as you know, all the conferences, physicians are a very important constituent, and unfortunately, many sessions don't address physicians in the national, maybe endocrine, maybe neuro, maybe nephro. Physicians are very important constituent, but in INSL, physician and hepatology was a special session. The physicians chaired, physician by the physician, for the physician, and of the physician. That's a big gesture. Please give a big hand to the team INSL 23 for that invitation. And on behalf of API Odisha and API as a whole, we want to felicitate Professor Singh. I was talking in the other hall. The first work in the NAFLD and the metabolic derangement is from him. And the Hepatitis Day, World Hepatitis Day, is taken as per his suggestion. Many things first, and contribution of the Kotak and contribution of Professor Singh, many people don't know. So please give a big hand for Odisha, for SCB, for Professor Singh, and bringing the National INSL 31st to this place. And on behalf of API, I felicitate Sir with a small token of gift, along with Dr. Manoj Shahu, who was working day and night for so long years, and congratulate all of them for a very successful event. I request our Chairman API present to hand over the memento to Professor Singh and Dr. Shaw.
Sir, the last line I just want. So before Duseja sir, because who believed us, so our dream, my dream came true. So my dream came true. I'm extremely happy today. This was possible because of your blessing. You blessed us. This is possible now. So this might happen. So thank you very much.
Before these people are very eager to close the ceremony, but before that, I want to invite people, I mean the delegates, the faculty, the participants, the postgraduates. If anyone has to say something, we would love to hear their feedback, brickbats, whatever. May I invite? कोई है नहीं? I think आभा कुछ तो बोलो.
Sir, Dr. Rohini wants to take a photo with you, then we will.
हाँ, sure. Abha, please. Your feelings, your gut feelings, your liver feelings, whatever.
I think I have to say what most people have said. It was a great meeting, and I think the warmth which we felt from the organizers was at a different level, be it for all the academic functions, be it for the gala dinner and the dance where we all got involved and were still there for the early morning sessions. I just feel that we need to maybe focus a little more on our PGs coming for this meeting. Just a feedback, because now there are so many other parallel meetings which are going on that the PG involvement getting a little diluted. And I would just urge INASL to ensure that we have more postgraduates coming for this meeting. But I think those who have come have had a real rich learning experience. And thanks to everybody, right from our organizers, Dr. Duseja, Dr. Singh, and the entire organizing team, Dr. Manoj, and everybody else who was involved. Thank you very much. Yeah.
Just a comment regarding the postgraduates. Half of the people who attended were postgraduates this time. And in fact, in 2010, there were 66 abstracts. Chandigarh, 2011, they broke the 100 barrier. Okay, 100 abstract barrier, 122. This time there are almost 400 abstracts. So 3 cheers for the postgraduates.
Yes, of course, Dr. Duseja did mention that yesterday, but I would say that then keep a longer time for the poster session so that all of us also can appreciate and enjoy that.
Okay, I think before we close, I think Dr. Sushant also wants to say something.
Before I say something, I can see Chidanand Babu here. He was not here. So he is the man for which, everything is possible. So big round of applause for Mr. Chidanand Malik, Hotel Mayfair. How do you feel? Good, right? But we are feeling bad. Actually, we don't want you to leave Bhubaneswar. Leave from us. But meeting and partying are the go of the days. So we have to see each other. We have to say adieu each other until we meet next time. So see you next time. Thank you all. God bless you all. Jai Jagannath.
I think, thank you all. I think you must have seen, the meeting is only 4 days or 3 days, 3.5 days, but then the effort which goes on in organizing any kind of meeting starts actually 2 years in advance. And for last 6 months, the kind of effort which has been put in, obviously I think you see the end result, which is 4 day, and we are feeling okay, we are feeling satisfied. We hope that I think you also like the meeting, and we can take it as a success with the kind of academic participation, discussions, and everything we have had. And we will, from INASL Governing Council, promise you that we'll continue to do our best. I'll also take this opportunity to invite all of you for next year. The meeting is in Kochi, and the dates are 7th to 10th of August. So you can block your dates, block the calendar. So next year the dates are decided. 2025, the venue is decided. It's going to be at Chandigarh. Dates we will announce very soon. So till we meet again next year in INASL, please continue to participate in various other activities which we keep doing online, offline from INASL, and we'll really need your support and your contribution to make INASL and take INASL to greater heights. Thank you all, and see you next year. Bye-bye.
Last one. Actually, Dr. Duseja is so pivotal for this program. We want to acknowledge his contribution and felicitate him in the land of Lord Jagannath and Odisha. I request our Chairman API to felicitate Dr. Duseja.
Lunch is ready for faculties. Lunch at the third floor, faculty lounge here at the convention, at the Lily Hall, first floor of Mayfair Lagoon, at the Lagoon, and for delegates, lunch at the ground floor hall, PFA area, pre-function area, and for delegates, other in the basement area, and for all our friends today, lunch is ready down. Kindly join us for lunch. So I'm inviting everybody to join us for lunch. Chidanand Babu, please come here with Dr. Sushant, with Dr. Sushant. The kind of hospitality, the function, everything would not have been possible without the support of Chidananda Babu and team. Kindly.
Namaskar to all the participant delegates of INASL. It was pleasure being a part of this grand gathering and intellectual peoples, and I am really happy being associated with Professor Singh sir, Manoj sir, Sushant sir. It was like I felt like I am part of being INASL. So it's a great honor for me. Hope to continue our relationship forever. Thank you.
Thank you. A very special mention, Mr. Deepak. Can you kindly come here? Duseja sir, so before photograph, can you just we want to honor Deepak, Mr. Deepak. And Mr. Deepak is here from 1st of August, 2 days before conference. So initially I put him in a very small hotel here, lots of problem. So in spite of that, he's smiling every time. He's helping me like anytime. Thank you, Deepak.
So Deepak is the official INASL coordinator, and he was coordinating most of the things. So special thanks to him.
Can you give me another one? सर आप दे दीजिए.
And finally, Lord Jagannath's blessing for the whole team, and to be received by Dr. Manoj Shahu.
So this thing I am receiving on behalf of our Singh sir and the whole organizing team. Yes. Organizing team, everybody who was partner of this conference, everybody, the Lord Jagannath, the Lord of the universe. Thank you very much. Kindly join us for lunch, please, Dr. Sivam. Lunch is open for all. Kindly join us. 3rd floor for faculties and down for everybody, all our guests, special guests. And 3rd floor for the faculties. 3rd floor convention and Lily Hall at Lagoon for faculties, international, national faculty, our physician guests, all faculties. 3rd floor of convention. And all pharma people, kindly join us for late. Today is the last days. If you are able to take lunch with you, we will be feeling fortunate. Kindly join us for everybody from pharmaceutical industry. So Saraj Babu team, Sarup Babu team, Aditi team, Everybody, Grover team, everybody who are here, kindly join us for launch. This is a very humble request. Everybody who are here. Dr. Manas, can I invite you? Dr. Manas Panigrahi, please. Dr. Manas Panigrahi, 1 second. Can you kindly come to the stage?
Thank you everyone for joining us, and thank you everyone for supporting, joining and part of us. And at last, let's have a lunch with us, and thank you God.
Excuse me, sir.
So this is from like Odisha Organizing Committee to the Honorable President of INASL. Okay. From Odisha Local Organizing Committee to the Honorable Secretary General of INASL. Set up. Thank you. A kind and humble, sincere request. Everybody, kindly join us for lunch. We'll be grateful to everybody. Kindly join us for lunch.